Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions. Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional.
Good morning, everyone. Thank you for joining us early. I'm Greg Patakos, here with Stamatis Makrigiannis and Kyriakos Katsianos. We're also going to be moderating with Dr. Papadopoulos, our good friend who has left us for the co-capital of Greece, Thessaloniki. We see his beautiful smile on the screen. And Dr. Pereas, the renowned, known throughout all of Greece, Europe, and the rest of the world, cardiac surgeon from the Onassis Cardiac Surgery Center. Thank you for being online with us, Dr. Pereas. It's our honor to have you this morning. We have a very interesting session where we're going to be discussing mitral techniques, mainly transcatheter, but at the end we have Dr. Sardari, who's also going to be giving us a look at minimally invasive cardiac surgical repair for mitral regurgitation. Our first speaker is going to be Dr. Pibereau. Dr. Pibereau is a world-renowned expert in heart valve disease, is a very intensive researcher, and has brought us many of the evolvements that have occurred in the field of transcatheter valves. We'll begin with this. I'll ask that we keep questions short and probably until the end. So without further ado, Dr. Pibereau from Canada, here to give us his insights about patient selection for MT, or a hot topic.
So I've been asked to talk about patient selection for mitral TEER. These are my disclosure. So for TER, we have several devices, the MitraClip and Pascal, that allows for edge-to-edge intervention and correction of the leaflet coaptation without annuloplasty. As you know, we treat two etiology of MR. The primary MR, essentially the type 2 with the mitral valve prolapse, and the secondary MR, especially the type 3B, according to the Carpentier classification. And let's start with the secondary MR because maybe it's the more challenging and actually secondary MR. Generally, there is a myocardial injury with adverse LV remodeling and dilation that cause a tethering of the mitral valve apparatus and therefore causing secondary MR. And then the secondary MR, of course, further worsen the LV remodeling and dilation and, again, the tethering of the leaflet. So it's a kind of MR budgeting MR. So it's a vicious cycle here. So what are the guidelines for indication of TR for secondary MR first? Well, first you need to have a chronic severe secondary MR with persistent secondary MR and symptoms, patients not appropriate for valve surgery, not having end-stage LV or LV failure, because otherwise you should consider palliative care, and who fulfill criteria suggesting an increased chance of responding to TR. And well, the guidelines are relatively vague on this last step. So if you do have all these criteria, yes, TR is indicated. If not, you may consider TR, but with caution. So I summarize here again the criteria that should be considered for patient selection for TR in secondary MR. Again, persisting severe secondary MR and symptoms, not eligible for surgery, no end-stage LV or LV failure, fulfill criteria for likelihood to respond to TR, and finally, of course, considered anatomically suitable for TR. So let's first pause on this definition of severe MR in the context of secondary MR, because for primary MR, we know the criteria that are generally used, an airway more than 40, regurgitation volume more than 60, and regurgitation fraction more than 50%. But for secondary MR, some studies suggest that the impact on clinical outcomes may occur at lower threshold of airway and regurgitation volume with airway more than 30 and a regurgitation volume more than 45. And these are actually the criteria that have been used in the COAPT and mitral FR. So this is the definition for severe MR or moderate to severe secondary MR, and can be considered as an indication for intervention. And in this study, actually, it is clear that patients who have an airway more than 30, regurgitation volume more than 45, but corresponding probably to a regurgitation fraction more than 50%, because these patients with low flow state, these patients with a secondary MR often have low flow state. So a regurgitation volume of 45 ml actually corresponds to relatively large regurgitation fraction. And so these patients should be considered as having at risk severe or moderate to severe MR. So we know all these results, these diametrically opposed results of the two trials that have assessed TR in the context of secondary MR, the COAPT trial that was very positive, and the mitral FR trial that was completely negative. And a priori, this was the same trial design in the same population, but if you look into the details, there are some differences in the trial, and the main differences are that in the COAPT, there was clearly more patients with true severe or moderate to severe secondary MR, whereas in mitral FR, there was a higher proportion of patients with moderate MR and maybe less with severe. The other difference is that the LVs of in this trial appears to be more dilated in mitral FR than in COAPT, so maybe more advanced heart failure and LV dysfunction in a mitral FR versus COAPT. And so, yes, indeed, I think where the TR is most likely to benefit the patient are the patients who have a significant, so moderate to severe MR, so grade 3 or 4, with not too much LV dilation, so and LV dysfunction, so LV and systolic diameter less than 70 millimeter. That was one of the inclusion criteria in COAPT, LVF more than 20%. On the other end, the patients who have maybe less severe MR, so mild to moderate, are less likely to benefit from an intervention that target MR. Makes sense. And also the patients who have moderate to severe MR or more, but who have advanced LV dysfunction, dilation, well, the benefit is uncertain. So this is what led some investigators to propose this proportionality framework in secondary MR to be able to interpret the differences between the mitral FR and the COAPT. So this proportionate MR will be an MR that appears more severe than the LV dilation, that is disproportionate versus the LV dilation. And the proportionate MR is, well, the opposite, where the MR severity is in proportion with the LV dilation. I have to say that I like the concept. I don't like the way it has been labeled, the terminology that has been used. And indeed, using this concept and the ratio of the ROA to the LV and diastolic volume, the patients in COAPT will be in the severe and disproportionate MR, more likely to benefit from intervention, because here the MR is probably the key factor and the key causal factor of the heart failure. This also has been called, and I prefer this terminology by other investigators, as MR dominant. So MR is the expected main cause of the heart failure. Whereas in the mitral FR patients, where there is proportionate MR or MR LV co-dominant, then maybe the benefit of TR is more uncertain. So to kind of reconcile this concept and make it more clinically applicable, we propose this reappraisal of this framework. So the first step is to make sure you have a chronic secondary MR that is at least moderate to severe, so grade 3 or more, so ejection fraction more than 40 or 50%. And then the next step is to assess this LV dilation versus MR severity proportionality. And let's start by the far hand on the right here. If you have extreme LV dilation, very advanced LV failure with LV and diastolic volume index more than 140 ml per meter square, then probably it's too late, and you should consider other therapeutic options in palliative care. On the other hand, you have what was called before disproportionate MR, but what I prefer to call proportionate LV dilation, where there is, this ratio of EROA to LV and diastolic volume ratio is more than 0.14. So there is, I think, some evidence that the MR is causal in the heart failure, and the LV and diastolic volume index is abnormally high, but not too high, so between 82 and 140 ml per meter square. Then these are the patients who are the most likely to benefit from TR. These are good candidates for TR. If there is excessive LV dilation, where you have the ratio, the proportional ratio that is now less than 0.14, then these patients, well, you're not sure if the MR is an active contributor to the heart failure or a bystander. And so let's say that these patients are less likely to benefit from TR. They may benefit, but it's a bit less predictable. And finally, if you have small LV dilation where the LV is not or minimally enlarged, I always think that maybe the MR is not that severe, and you should rule out overestimation of MR severity and more optimize the medical treatment. Then the next step, once the patient is probably a good candidate for TR, is to make sure that the patient is anatomically suitable for TR. And you have this great table that provides the criteria of suitability for the TR. It's for the mitral clip. In the left column, if you have this criteria that in the grid zone, these are patients who are suitable for TR neocord. In the orange here, if you have one criteria, that's okay, but if you have several, maybe you should, it's more like a decision to take between TR or TMVR. And finally, if you're on the red here, it's more not good candidates for TR and would be more TMVR. The next step, and why the anatomy of the mitral valve leaflets and subvalvular apparatus are important to consider, is once you decided, okay, TR is a good option for this patient, and for example, here you decide to use mitral clip, you can use this criteria to decide which type of clip you're going to use, the NT, the NTY, the XT, or the XTY. So some example here of patient with severe secondary MR that you can appreciate here. And so we're going to measure the extension of the jet. You see here that is pretty long, around 10 to 11 millimeter. And the leaflets are not calcified. It's essentially a pathology that is dominant in segment 2. You can appreciate again here the MR. So there are several criteria that are met in the green light. So central pathology in segment 2, no leaflet calcification, mitral valve opening area that did not show, but obviously more than 4 centimeters square. The mobile length of the posterior leaflet was more than 10 millimeter. The coaptation depth, which is an important parameter, is less than 11. So several criteria in favor of TR. There is one that is kind of in between, which is the Carpentier 3B, but that's most of the case in the secondary MR in this category. So in this case, we decided to do a TR. And so a mitral clip was selected as device. And given the wide elongated jet that I showed you, we're going to use a wider device. And because of the other criteria mentioned here, we're going to use a longer device. So it's going to be the XTY that is going to be selected. So showing here first clip. Often when you have some criteria that are in the orange, you often have to use 2 clips, and indeed there was some residual MR after the first clip, so putting here a second clip, and now much better. You will see on the right, the final results that shows just a trace to mild residual MR. So for primary MR now, what are the guidelines? Well, there are maybe less criteria and step than for secondary MR. So if you have patient with, again, chronic severe primary MR who are considered inoperable or had high surgical risk and were anatomically suitable for TR without extended heart failure, with extended heart failure after extended heart failure treatment, let's say, then this could be a good candidate for TR. So I summarize here again. So severe chronic primary MR and symptoms, extended heart failure treatment has been accomplished, inoperable or higher surgical risk, treatment non-considered to be futile by the heart team as usual, and again considered anatomically suitable for TR. And we're going to use the same, anatomic criteria that we previously described for secondary MR. So showing here an example of a mitral valve prolapse, as you see here, and some significant primary MR. Here is the flail width that is pretty wide, actually, 2.18 centimeters, so more than 2 centimeters. This was the measurements of the length of the mobile portion of the posterior leaflet. The leaflets are not calcified. Again, this is more a P2 prolapse here. So a priori, if we summarize with the table, central pathology in segment 2, no leaflet calcification, mitral valve opening area, okay. The mobile length of posterior leaflets more than 10, coaptation depth less than 11. So the only criteria that is in the orange, more like hesitating, is this flail width that was more than 15 millimeter, actually more than 20 millimeters. So you know that if you go with TR, you'll probably need more clips, more than one. But I think it's reasonable. And there are some criteria for using a wider clip here because of the flare width more than 15 millimeter, and again, wider and longer. So again, in this case, we're going to use the XT wide, XTW. This is after first clip. Good results, but I think need more. So this is the first clip in place. And after the first clip, we check for the iatrogenic mitral stenosis, mean gradient of 2, pretty good. So no evidence of mitral stenosis. Putting a second clip now, and again after the second clip, no mitral stenosis, mean gradient in the 2, very stable, and pretty good results that I can re-show here. You see with really only a trace MR after the placement of these 2 clips. So if we summarize, the criteria for patient selection for TR, for MTR. For primary MR, first you need severe chronic primary MR, defined as EROA more than 40, reduction in volume more than 60, reduction fraction more than 50%, and symptoms. Needs to be symptomatic severe MR. Patients who are considered inoperable or high surgical risk, who have had an extended heart failure treatment, so medical therapy for heart failure, although there is not much for primary MR, treatment not considered to be futile, and finally, which is common for both primary MR and secondary MR, anatomically suitable for TR. So I've summarized the key criteria here: central pathology in segment 2, no leaflet calcification, mitral valve opening area more than 14 centimeters square, coaptation depth less than 11 millimeter, mobile length of the posterior leaflet more than 10, and the flare width less than 15 millimeter. And for secondary MR, same persistent severe secondary MR, but here the criteria for severe MR is somewhat different. It's more moderate to severe, if you will. EROA more than 30, reduction volume more than 45, and reduction fraction more than 50 or 40, depending on the studies. Not eligible for surgery. No evidence of end-stage LV or RV failure and dilation, and fulfilled criteria for likelihood to response to TER, which include the disproportional ratio of EROA to LV and diastolic volume more than 14, LV and systolic diameter less than 70 millimeter, that was a COAPT criteria, LV and diastolic volume index less than 140 ml per meter square, and LV ejection fraction more than 20%. You don't need all these criteria, but I think, the more you have criteria in this category, the more the likelihood will be of this patient to respond to TR. Thank you so much for your attention.
Thank you very much, Professor Pibarot. This was an excellent lecture, really, focusing on most things. Due to time, I think we will proceed with the following talk, and then maybe you could stay with us for a few more minutes. We kindly request all our speakers to try and keep in time so that we do not enter too much onto the next session. So, Dr. Patakos, would you continue presenting, please?
Yeah, Dr. Makrigiannis will present the next speaker.
Good morning from me. We're moving to the next presentation, imaging in pre and post MTR, and I have the pleasure to call the good friend and associate director of our department here in Hygeia Hospital, Michalis Socheris. Michalis, the stage is yours.
Dear Chairman, respected colleagues, thank you very much for the honor of presenting in this conference and following Dr. Pibarot in his previous lecture, which is truly amazing. We're going to be discussing the next 10 minutes about some of the insights about imaging during transcatheter edge-to-edge repair. We've come a long way since the introduction of TR many years ago with the introduction of next generation devices like the Gen 4 MitraClip and the Pascal devices, multiple device iterations in sizes and lengths, as we saw very nicely before. I mean, also for the Pascal device, two major iterations, the Pascal and Pascal Ace, which allow us to tailor our therapy to the individual patient. In particular, also imaging has evolved tremendously over the past few years, especially with novel 3D and 4D modalities, as we will see shortly. This allows us to plan our procedures very carefully before we start, in a way similar to how we plan TAVI using CT. We plan TEER using our echo images. And one of the basic modalities is biplane imaging with orthogonal 90-degree angulations, which works very well at the center of the valve, A2P2 area, very nice to see. However, it's important to know that when we discuss about edge-to-edge repair, that when we talk about implanting a device at the center, we need an orientation of B12.6, and usually we see that very nicely in a long axis view that's about 120 to 160 degrees. If we talk about medial position for the device, then we talk about a counterclock rotation of the device and usually long axis views of 100 to 130. And if we go for lateral commissure implantations, usually we use angulations in the long axis view of 150 to 180. This also evolution of biplane imaging to include non-orthogonal angulations has helped us tremendously in this respect, in a way that we can now visualize the medial and lateral commissures more accurately. In addition, transillumination imaging, as we saw before, gives us a very nice rendering of the valve and improves understanding of the leaflets. Also, transillumination with transparency helps us a lot to understand where the pathology of the mitral valve is, and in particular for color, where it originates. The big evolution also in imaging is real-time multiplannar reconstructions, which we use heavily in our procedures, where we get a 3D volume and analyze it to a commissural long axis and short axis view. This allows us to very accurately identify the leaflets and the morphology of the valve. So overall, the screening for mitral regurgitation with TEER involves all these questions that we need to answer for mechanism, severity, jet location, leaflet morphology, leaflet length, very importantly, and mitral valve area. I'm going to show you 2 or 3 examples of how we apply all these in clinical practice. This is a patient referred to us for treatment of severe functional mitral regurgitation. Interrogation of the valve with biplane imaging and color at the same time helps us understand the extent of the regurgitant jet. Initially, we thought it was mostly confined to the lateral aspect of the valve. However, when we go into more careful imaging, we see that actually it can extend all across the coaptation zone, maybe with a preponderance on the lateral side. So here 3D imaging is very important as well to understand the morphology of the leaflets, but multiplanar reconstructions here help us a lot to have a baseline understanding of the valve leaflets. Here we are positioning in the middle of the valve, A2P2, and we can clearly identify the leaflets, the leaflet length, morphology, and everything else that we need to understand clearly. This is the medial commissure. You see on the right upper hand image the grasping view in the medial commissure. We're not going to be working in this, obviously. And lateral, where we had the most jet from the beginning, this is how the morphology of the valve looks in the right upper hand image. Superimposing color also helps us understand exactly the location that we need to target with our devices. So in planning for TEER, for this particular patient, we opted for a single Pascal P10 in this location on the lateral side, and next to it, depending, an ACE device to supplement for any residual MR. Using fusion imaging helps us a lot in terms of transeptal and gives us a good understanding, especially when we have lots of wires on the right side that we want to navigate around so we don't dislodge anything. Also, biplane imaging with non-orthogonal biplane imaging helps us a lot to simultaneously project the short axis image as well as the bicaval view. And help us guide us. And in addition, the 3D rendering of the unfast view of the septal of the fossa ovalis helps us understand the morphology of the fossa ovalis and how we should, where we are entering the fossa ovalis into the left atrium. The guide insertion can be seen very nicely with fusion imaging as well. And in addition, we're always try to pinpoint the exact point of entry, so we can have that as a reference during our procedure, especially with Pascal. The edge of the guide sheet is not as clearly seen as with the MitraClip, so we have to use that as well. involving introducing the device into the left atrium. We use 3D imaging to help us navigate. And moving over to the mitral valve and understanding position and trajectory is very important in order to have the correct engagement with the valve. Clocking is the next critical component of the imaging, and we want to clock the device to be perpendicular to the coaptation zone that we're interested in. Multiplanar reconstructions also help us a lot in to get all this information in one setting without the need to go back and forth with 3D and 2D imaging. And there's multiple advantages in this. However, disadvantages include the low spatial and temporal resolution and the difficulty in obtaining multiple acquisitions when we want to review our clasping sequences. Here we have the engagement of the valve leaflets. In this particular case, we did independent grasping of the anterior leaflet first, followed by independent grasping of the posterior leaflet with the Pascal P10. Optimization of the posterior leaflet, which is something that we usually do very often, depending on our initial results with color, and further optimization with of the anterior leaflet, as you can see here. The goal is always to try and get the best result with the first device, with a single device as possible, and use a second device only as needed. Leaflet insertion evaluation depends heavily on reviewing our clasping sequences and our biplane scanning and MPR scanning. This is an initial appearance after the first device. The color seems to be very nicely reduced. We have color only from one side of the device. This is a good reduction before deploying this first device. We could live with this color if we could not put a second device, but obviously we will try to get a second device in. Get it right next to the first device very carefully, optimizing the leaflets. And this is our final result. An evaluation of the MR reduction is performed primarily with qualitative measures, viewing the color. We can also assess ERO, vena contracta area, and indirect measures like pulmonary vein flow and LA hemodynamics, and also assess mitral valve orifice area by 3D planimetry. In addition, we have to point out that there are some data of an annuloplasty effect, an indirect annuloplasty effect of the edge-to-edge repair that we can also see here in this particular patient, a reduction in the posterior anterior diameter of the valve. A second case that sort of highlights the role of multiplanar reconstructions in creating a long axis view that is a grasping view as we would like it to see in the particular area that we're interested in which we can guide our device nicely in this view, and then go with the 2D biplane imaging for grasping. This is an XTW device for this patient with severe functional MR, followed by a second device in the center, an NT device with an optimal result. And this last case I wanted to show you is because of the complexity that it shows in the beginning and how you can go through and clarify things. The initial image on the left side looks very complicated, what we're going to do. However, when we sort of go into live 3D and live 3D imaging with color, we can see that most of the jet lies in the lateral A1, P1 area of the valve. Biplane imaging in this area didn't help us significantly, so we went with MPR. MPR in this lateral area shows clearly in the left upper, in this part of the image, on the left upper part, the flailing of the anterior leaflet, creating severe eccentric regurgitation. And this is obviously our target for a device. Photorealistic imaging and transillumination also help us understand the flailing segment in the lateral commissure. So this would be our plan, to put one device, a Pascal ACE in this particular patient in this configuration. Again, MPR for guiding the positioning over the valve, with color also to navigate. We use long axis images at about 170 for good delineation of the device, and optimization of both posterior and anterior leaflets to ensure maximal leaflet insertion before closing the device. And this is the final result with a single Pascal ACE in the lateral commissure, with a single orifice valve, and a fine result. A small iatrogenic ASD is commonly seen after these procedures. However, sometimes they can be large and significant, in which case closure devices might be indicated. So keep that in mind always to assess the ASD at the end. Finally, just a quick word on intracardiac echo, which is coming into play. This is our initial experience with 3D echo intracardiac for the mitral valve. In this patient, we can see a good delineation of the mitral valve leaflets. So it's a modality that's here, and we're going to be seeing more and more of this in the future. At this point, is complementary to standard transesophageal echo. However, there are case reports and evolving understanding of how we can use intracardiac echo as a sole imaging device for edge-to-edge repair. In summary, imaging with echocardiography has advanced significantly and offers important tools that help planning of the procedures in great detail. Intraoperative guidance with 3D and NPR imaging streamline the procedure and improve accuracy and efficiency. And we will see more in the near future with intracardiac echo that will play a significant role in these procedures. And with that, I would like to thank you very much for your attention.
Thank you, Dr. Chrysoheris, for the marvelous presentation. So our next speaker will be Professor Kassel, head of the Structural Heart Department in the University Hospital of Zurich. Edge-to-edge repair for MR. Professor Kassel, we're happy to have you here.
Thank you very much.
No.
It's working? Yeah, thank you very much for your invitation. Here I want to give you once again an overview about edge-to-edge repair. So here is an overview about the frequency of valve diseases in Europe, and we see that mitral valve diseases with a moderate or severe mitral valve diseases are very frequent, more frequent even than aortic valve diseases. We have seen already the classification discriminate in between primary MR, degenerative, here's the leaflets, the problem, and secondary functional MR. Here is the ventricle or the atrium dilatation, the problem. We spoke about also here about the guidelines. So primary MR has the 2B indication in the European guidelines, and secondary functional MR a 2A indication. Here's an easier overview. So how is the workflow when we have a patient with symptomatic severe degenerative primary MR? So heart team assessment, when the patient is inoperable or has a high surgical risk, then mitral edge-to-edge repair is an option. And when we look to the right side, symptomatic severe functional MR, also heart team assessment, including optimal medicament treatment of the heart failure. So when the patient is coap-like, here are the criteria, then also for severe functional MR, mitral edge-to-edge repair is an option. So when we look at the valve itself and which patients are good for edge-to-edge repair, there's a nice overview. And on the left side, the green, I think here we can get to a very predictable result when we choose edge-to-edge repair. Here it's a bit bigger. So when you have long leaflets, not a lot of calcification, not a big flail gap, then it is really predictable that you can treat this patient very good with edge-to-edge repair. There are two different devices on a approved devices on a European market. On the left side, the MitraClip 4th generation with 4 different clip sizes, and as it's shown here. And on the right side, the Pascal Precision device. It came later on the market, and this device has two clips, a smaller one, and the P10, what is a very wide clip. So what is the difference in between both clips? The one is made out of cobalt chromium, so it's very stiff, and the other one is made out of nitinol, and nitinol is more flexible. And so I think Pascal precision is, because of this, not this aggressive to the leaflets. So when we look at the different pathology and the best choice of clip sizes or Pascal sizes, there's also here an overview, which is nice. So you have some anatomical features, and when you look on the right side, there's a choice for all these different anatomical features to use the best clip size and length. So I want to show you also two examples. Here's a case of an 85-year-old patient with a severe reduced LV function, but also a big atrium, and with a moderate to severe functional mitral regurgitation, as you can see here. So in this case, we decided for the Pascal device, and as you see here, in fact, there are three catheters, one in the other, and you can navigate it in more or less 16 different dimensions. So here, once again, the steps. In 3D, you can do the initial placement above the pathology. We look here from the arterial side, and then once the clip is above the pathology, you do the alignment that it is 90 degrees to the commissure. And in this case, it's a pathology straight in the middle. A2, P2 was the planning for the placement. And then once the leaflets are on the device arms, then you can put the clasps in the name for the Pascal grippers, and you put down the clasps. And with both devices, with the mitre clip and also the Pascal, you can do leaflet optimization. That means you can open the clasp independent, and you can, when there's not enough leaflet inside the clip, then you can readjust it, and you can catch more if you want. You open the clasp once again, you go, for example, to the posterior side, and you catch more leaflet then. You are able to catch more leaflet then. Also, you can do, we saw it before, you can do a staged leaflet capture, as it is shown here on the right side. So you can grasp, for example, anterior leaflet or posterior leaflet first, and then the second leaflet. So once the leaflets are in, you can close the device. So here it's a P10, and what you see also, the P10 has a spacer in the middle, so it fills the gap in between the leaflets. And you close the device, you look for the result, and once when the result is good, as it's shown here, and you see a good bridge in between the device and the anterior and posterior leaflet, then you can decide, and when there's not a significant gradient over the valve, that you can decide to release the Pascal device. So this device has 10 millimeters width. So here it's released, and finally you can see the result. And in this case, only one of these Pascal devices were necessary to reduce the insufficiency really significant. Second example for a degenerative primary MR, in this case I will show, this case we did with a mitre clip device. As you heard, there are different clip sizes available for different sizes, too small and too wide, too long and too short. So this is a case, in this case it was a 70-year-old patient with a normal LV function, a high surgical risk. That was the reason why we decided for edge-to-edge repair and a severe mitral regurgitation. The pathology in this case was a chorda rupture in the medial segment, in a P3 with a flail leaflet. We started here with an NTW clip close to the medial commissure. It's shown here. But there was still a significant insufficiency, so we needed a second clip, and in this case we used a small NT clip, a second clip on the lateral side, direct next to the first clip. So when you combine here NTW with the NT clip, then you can bring the second closer to the first clip, and then there is no gap in between the two clips. And also here we achieved a good result. So let's speak about the timing. I think it is not the right time in a very early stage when the mitral insufficiency is not really significant. But what we learned also, it is not good to wait too long. And especially in secondary MR, you can do optimal medicament treatment, but not forever. So it has to be limited for some weeks, some months, perhaps 2 to 3 months. It's a good timing for this. But when the patient is afterwards still symptomatic, or he has still a severe mitral insufficiency, I think you have to decide for a treatment, and a good treatment for functional MR. It's edge-to-edge repair. So we have also a score which predicts the long-term outcome after edge-to-edge repair. I think it's helpful because it shows you risk factors for bad long-term outcomes. It's shown here. And when you add the different points, up to 3 points, you are able to have a good long-term result. More, then it becomes difficult. What is the next step? I think here it's perhaps robotic systems, and they are the first on the Chinese market, which the systems, you have a lot of knobs and catheter systems. You have to turn different catheters, but these robotic systems are able to put every movement in one joystick. You go up and down and right, left, only with the help of this robotic navigation system, and it makes it much simpler. This is my last slide. Thank you.
Thank you, Professor Kassel, for the brilliant presentation. I'm sure all of us have a lot of questions for you. We'll save our questions for the end due to time.
I come back.
Schedule. Thank you very much. And now Dr. Papadopoulos will present our next speaker.
Yeah, I'm happy to announce Professor Souvi from Jerusalem. Professor, welcome. Thank you for being with us.
Good morning.
Good morning. We are going to listen to mitral tear in cardiogenic shock. We know that you are the top expert in this field, and
Thank
we
you.
are happy to listen to your presentation. Thank you.
Good afternoon, and thank you for inviting me to the Transcatheter Heart Valve in Greece. Hopefully next year I can attend in person. I will speak today about mitral tear in patients with cardiogenic shock. So let's start with a case. The first case, 74-year-old woman, presented to the emergency room with light arrival inferior ST elevation MI. She was coming from another hospital, then in which she was treated medically for 5 days, and then she was transferred to our hospital. On arrival, the patient was in severe tachypnea. Her blood pressure was low, 60/40. In fact, she was in cardiogenic shock. We can see here the X-ray showing pulmonary edema. She was transferred to the cath lab. We can see here diffuse multivessel disease with acute occlusion of the left circumflex artery. On echo that was performed immediately, we can see severe tethering of the leaflets. We can see the tethering of the posterior leaflet, but there is no papillary muscle rupture or no caudal rupture. And we can see here the jet of severe mitral regurgitation. In fact, she presented with acute, functional, severe mitral regurgitation due to late arrival inferior ST elevation MI. When we talk about acute mitral regurgitation, we're talking in general about three mechanisms. The first two are related to myocardial infarction. We have the dramatic approach of papillary muscle rupture. Patients often come in cardiogenic shock due to the rupture of the papillary muscle. We have a more subtle mechanism of rapid remodeling, like in this patient. The infarcted area is remodeled, causing tethering of the leaflets, an acute functional MR. And we have a different mechanism. Patients most of the time have degenerative mitral valve disease. They sometimes they rupture a cord, and then they come in decompensated state. So what is the cause of the decompensation in acute MR? Patients with acute MR, as we all know, have normal left atrial compliance. They have a small left atrium. Therefore, the smallest amount of regurgitant volume causes a rapid increase in the LA pressure. The LVDP is very high, and these patients get into pulmonary edema. In fact, there are two mechanisms. The mechanism of pulmonary edema due to the very high pressure, the LA pressure that goes very high immediately, which cause acute pulmonary edema. And on the other hand, we have a volume overload on the left ventricle. The stroke volume the forward stroke volume is decreased because most of the blood is going back to the left atrium, and those patients has a cardiogenic shock and signs of oliguria and other signs of hypoperfusion of vital organs. This is the mechanism of the acute MR, regardless of the etiology of the MR. The problem with acute severe MR that in many times the clinical picture is inconclusive. As we teach the students, the murmur is often soft and even may be absent because we know there is rapid equalization of the pressure between the LA and the LV. Relatively small amount of volume goes from the LV to the LA. There is equalization of the pressure, and therefore there is no additional flow to the left atrium. Similarly, the color Doppler that we see in the echo often underestimates the severity of the MR, in particular in patients with very high left atrial pressure. In addition, the quantitative evaluation of MR severity that sometimes we try to do effective regurgitant orifice area, vena contracta. It is important to remember that they were validated only in chronic MR and not in acute cases. And in most cases, the usage of this quantification underestimates the acute severity of the mitral regurgitation. So how we can validate the acute severe MR? We often need several modalities. We have some echocardiographic features that are not related to flow and color. We can see tethering of the leaflets. We can find elevated pulmonary pressure. We see severe pulmonary pressure with no other explanation. We can see right ventricular dysfunction due to the rapid increase in the wedge pressure. An important feature is the pulmonic vein flow. It's very important to look at it. And if we see a deep reversal of the systolic vein in the pulmonic vein flow, we can suggest that there is a clinically significant mitral regurgitation. In addition, hemodynamic evaluation can also help if we see elevated wedge pressure with very high V wave. This both suggest that this patient has severe mitral regurgitation. And for example, if we see very high V wave and low blood pressure, though this patient is often have acute severe mitral regurgitation. Therefore, the clinical suspicion is required among patients with acute heart failure. If we don't have a good explanation for the acute heart failure, we must remember that acute MR is one of the causes in this condition. So what is a clinical spectrum of acute severe MR? In general, this is a classification that we published recently. We have the type 1 patients. Those patients are in the extremes. Patients in cardiogenic shock, the blood pressure is below 90, they're in pulmonary edema, there is signs of hypoperfusion reflected by high lactate levels. Those patients often required inotropic therapy and mechanical support, intra-aortic balloon, impeller, ECMO, and those patients often required an urgent mitral intervention. The type 2 is less severe, although those patients are pretty severe. They have refractory pulmonary edema, but the blood pressure is still maintained in normal range. Often they have signs of hypoperfusion, like low cardiac output, but normal lactate levels. These patients often require intravenous diuretic continuously, and they might require urgent mitral intervention. Less severe is a type 3. Those patients maintain their blood pressure. They might have some low cardiac output state. They have episodes of flash pulmonary edema. This is one of the signs of acute severe MR, episodes of flash pulmonary edema. They need IV diuretics, and we don't know exactly the role of valvular intervention. And there is the less severe conditions, the type 4. Most of those patients has probably a previous mitral disease and some remodeling of the left atrium. Therefore, they are not in decompensated heart failure, but those patients can be treated medically in most cases. So which patients are at risk to develop acute severe MR in the context of MI? Like the first patient that we presented, those patients often come with late arrival myocardial infarction. We have a suboptimal reperfusion, slow flow. Sometimes we don't get any flow at all. In many cases, there is involvement of the left circumflex artery, and in many cases, they have also multi-vessel coronary disease. So those patients often go into a heart team discussion. We know that medical therapy is option, but those patients have very limited ability to tolerate the medical therapy. After a reduction and ACE inhibitors and stuff cannot tolerate it because of low blood pressure and a kidney injury that is common in those patients. Surgical mitral valve replacement is an option, but we know that those patients that get into the surgery in decompensated state are often have some issues in recovering from surgery, and there is an option of TEER or a mitral clip in order to try and fix the mitral valve and allow the recovery of the patient. So the data regarding urgent mitral clip in patients, it came from a few years ago. This is one of the first publications of ours, and some centers in Europe, including the center in Athens, our friend Michael Christoheris and Kostas Pargias. In this registry, we first described the 20 cases of patients that were treated with urgent mitral clip due to severe acute functional MR after myocardial infarction. We see that the procedure was very successful in most cases, reducing the severity of the MR. You can see here the immediate impact of the left atrial V wave and the pulmonic vein. In fact, we can see during the procedure, the minute you grasp the leaflets, you can see a decrease in the LA pressure and increase in the systolic blood pressure, a very common phenomena in patients with acute MR. And those patients also, we can see here the recovery of them. They were able to recover the acute phase of the decompensated heart failure after the TEER procedure. This is the first publication, our publication, and a publication of our friend Rodrigo Estevez Luyero, the IREMI trial. And after those publications, we decided to join and try to do a better registry. And before this registry, we also had a publication from the TVT data showing that patients that go for a mitral clip in cardiogenic shock, we can see the procedure was safe, the device success was high, and we can see that patients that had good result of the mitral clip procedure had better outcomes compared to patients that were not successfully treated with the clip, suggesting the importance of the TEER in those conditions. So, as I told you before, we had combined our registries, and we approached the hospitals and asked them to send us data on patients with acute MR that were treated or by clip or by surgery, or were treated by only medications. Those patients were recruited in 21 centers in Europe, North America, and Israel. All of them had at least +3 MR and heart failure after acute MR. And as I said, they were treated by surgery, clip, or by therapy. This is the patient characteristics. We can see the patient not very old. You can see that most of them came in KLIP 3 and more. Half of them were in cardiogenic shock. Many of them required inotropes, and many of them had intra-aortic balloon pump. The first findings that we see is that patients that were not treated by any mitral intervention, which means that were treated conservatively, had the worst outcomes. Almost 40% of them died in the first months, suggesting that waiting and treating with medication might not be a good solution in patients with acute severe MR. Next, we evaluated the comparison between patients that were treated by surgery and those that were treated by TEER. PMVR here is TEER. And we can see here that although the procedure, the mitral clip and the surgery were both successful, more than 90% of the procedure were successful, patients with that were treated with surgery had very high complication rate. 1/3 of them had major complication, and this was translated into an increase in in-hospital mortality that was much higher compared to the TEER, suggesting that TEER in this condition might be a safer solution than surgery. And we were able to publish this findings in European Heart Journal a few years ago. As a result of this study and additional study, the recent guidelines of treating patients with acute MR, suggesting that after evaluation of the patient, of course, opening the artery if it's possible, considering mechanical support, then when you treat the mitral regurgitation, TEER is the first option. And surgery is advised only in selected patients in which TEER is not available or TEER is not safe to perform in those.
Thank you very much, Dr. Shuvi. We appreciate it, and thank you for allowing us to shave 2 or 3 minutes off the end of your video.
Sure.
Because all of our audience here and our audience online, we're more excited to have you with us for the discussion. Everybody likes the live interaction. I think everything that you showed us was groundbreaking. If you would be so kind as to remain connected with us, we have 1 lecture remaining, and at the end we've asked all of our speakers to just have a few minutes of patience, and Dr. Pereas will coordinate a lively discussion, but we just needed to make sure that we leave enough time for that discussion to be respectful to the next session. Thanks so much, Dr. Shuvi.
Thank you very much, too. This was really impressive, and I think it will generate a lot of talk. We've heard you before in Athens, and you're always very welcome. And we hope to learn, basically trying to identify the 2 edges of the mitral disease, the very futile and difficult towards the easier, let's say, and surgically managed. So as we're speaking about surgery, I would like to present Dr. Sardari, who is a very renowned surgeon, very active not only in minimal invasive mitral valve surgery, but also in disseminating knowledge through his position at the Maastricht and through EACTS, with a lot of training sessions at his hospital. So we're very eager to listen to his talk and then have a chat and discuss all the issues with our esteemed colleagues. So let's start with Dr. Sardari's presentation, please.
Distinguished panel, dear colleagues, I would like to thank the organizers for the kind invitation and also for the honor and privilege for giving this lecture. I was asked to talk about surgical techniques for mitral valve repair. These are my disclosures. If we consider surgical techniques, we have to consider that the mitral valve pathology is very heterogeneous, but also the anatomy of the mitral valve is complex. So if you consider all those things, then there are more than 120 options to repair the mitral valve. But as you know, there are 2 schools in mitral valve repair: the resect school, the Carpentier school, and respect school. The resect school is based on the philosophy that if you normalize the anatomy, you will normalize the function, and the respect is more focused on restoring the function. And the difference becomes more evident if you consider the more complex V-leaflet prolapse, because as you can imagine, to normalize the anatomy of this kind of valve, a Barlow disease, you have to do more resection and more. You need to use more techniques to be able to do that. Whereas respect technique, you use artificial cords to create a large coaptation area to be able to make the valve competent. What is also very important, that there is an indisputable link between volume of individual surgeons and the outcome for mitral valve repair. This has been established in multiple studies, and overall is it that you need to do at least more than 25 repairs per year to have a stable results. What is also important, beside the techniques, what you do at the level of a mitral valve, how you approach the operation. Obviously, the conventional technique through sternotomy, which is still the most prevalent technique. Around 80 to 90% of all operations in the United States, across Europe, except some countries, is through the sternotomy and a minimal invasive approach that you use a small mini thoracotomy with the help of a videoscope or robotic assistant to do the operation. What is important here as well, that to learn this kind of minimal invasive procedure, you need to at least do between 75 to 125 cases to overcome your learning curve. What is also important, that there are 4 different distinctive minimal invasive techniques with the direct vision, use of retractor, with the robotic assistance, with 2 endoscope, and with the 3D endoscope. And the most advanced technique is using the 3D endoscope and do the operation fully endoscopic. And why is that the most advanced technique? Because you can do the operation through a very small incision around the nipple. There is no need of rib retractors, because once you put a rib retractor, you create more pain and more discomfort for patients. Obviously, using a 3D camera abolishes the main advantage of robotic approach. You don't need a second surgeon, and it is also more accessible than robotic approach. What is also evident, if you use minimally invasive procedures, it has become very important to use an extensive procedural planning, what we use in our center, using 3D softwares to create a hologram of patient's anatomy. Based on that, we determine the level of incision. We can even simulate the cannulation that we normally use during this kind. So ideal patient to start with is a lean patient with good left ventricular function, a common pathology, a P2. But once you have gained expertise, you can do anything from complex valve, complex anatomy of the patient, reoperations, and from low risk to high risk patient. What is very important, this is a Barlow disease. One of my patients operated 6-7 years ago, that in mitral valve repair, the evaluation of the echo very crucial, because at the end, when you go to the OR and look at the mental analysis, you need to confirm what you have seen on the echo. And this applies actually to most valvular pathologies, except for Barlow disease, because of the fact in Barlow disease you have a kind of functional prolapse of the valve because of the junction of the annulus. So if you look here, you have 2 patients with Barlow disease on the echo, but if you evaluate the intraoperative image of the valve, you see here only a P2 prolapse and here full-blown Barlow disease. So in a Barlow disease, the intraoperative testing is crucial. What just wanted to show you some cases is in which cases would I do a resection, and in which cases I would respect the valve and use mainly artificial cords. So this is a patient with a P2 prolapse, and if you look at the valve, what you can appreciate is a large annulus, and you have a valve with extensive tissue, but not too extensive in relation to the annulus of the mitral valve. And if you look at the valve, and if you look intraoperatively, what you can see through the valve into the ventricle, so you have a large annulus, but this is not that you have too much tissue in the relationship of the dimension of the annulus. And these are the typical cases that I would do a chordal replacement, as you can see here. So here is an end result with the annuloplasty ring in place. And these are the kind of valve I would do the respect. This is the intraoperative, postoperative result of this patient. And when would I do the resect technique? This is a patient also with a P2 prolapse. What is important here, if you look at the excessive tissue and the extent of that excessive tissue, you see that there are, this is too much in relationship to the dimension of the annulus. And if you look at this valve, you see that this valve is quite different than the previous one. You cannot see through the valve into the ventricle. You have overlapping tissue of the posterior leaflet over the anterior leaflet, and this is the kind of valve I would do a resection, as I have done here. It's a quadrangular resection, and then you have also a very nice result at the end here. These are the postoperative images of this patient. Then you have obviously complex pathology, like here a B leaflet, a multisegmental prolapse. And this kind of valve needs multiple techniques to be able to repair the valve. And you can appreciate it here at the right side. I've did a quadrangular resection, a sliding plasty, reposition of papillary muscles head, and multiple cords of different segments to repair this valve. I'm not going to show this video up to the end, but what I want to show you is at the end you can have a very nice repair of this kind of valve. As you can see here, post-operative image, and you can have also a very good long-term result. This is the TTE at 36 months of this patient. So what is also I would like to emphasize is at the end, if you want to have a good mitral valve program, you need to establish a dedicated heart team, focus on the lifetime management. As well, this is the way we have organized our mitral program in Maastricht. So we have a dedicated team for all comers. We decide together. We allocate the treatment based on the patient's characteristic and extensive procedural planning, and we do also the operations or interventions together. And by this, we have been able to improve the mitral valve program. This is a study published a few years ago showing that patients treated by dedicated mitral heart team have superior survival compared with patients treated by non-dedicated heart team. So at the end, repair techniques you have to consider as a tool in the toolbox, and the future is a smart surgery formula in a way that you need to work together as a team. You need to tailor the approach to the patient's anatomy, and obviously for future some kind of simulation to be able to predict what you're doing at the level of predictability and also outcome for patients. Thank you so much for bearing with me, and I'm happy to answer any questions during the chat box.
Thank you very much, Dr. Sardari, for this impressive presentation. I think this shows that being together with our cardiology colleagues, we can advance therapy options together with the structural heart disease options and the transcatheter options. So just one question from me, and then I'll pass on to my colleagues and moderators. I have seen that you are obviously, I'm likewise a lover of partial rings. Would you elaborate a little bit more on your choices of rings? And the second question is, which is a very hot topic in the TEER approach too. What is your belief of secondary mitral valve disease. Do you think there is any space, given the fact that we can approach this now endoscopically, so we might be offering our patients something slightly better than the older surgical results that we had on this type of patients?
Yeah, thank you for the kind invitation again, and for your questions. For the first question with regard to the ring, I'm using nowadays predominantly bands. And the reason for that is, as you know, there is no annulus at the level of aortomitral quarter. That is a dynamic place of the annulus. And the whole annuloplasty concept ring works because you pellicate the annulus from the trigonum to trigonum. So what is important is that you have something in place from trigonum to trigonum. So that's why in most cases, I think a band is more physiological and much better. Obviously, in functional mitral regurgitation or mixed disease, so if you have, for example, a P2 prolapse, but you have an extreme annulus dilatation because this is a far more advanced disease in volume overload, in those cases, you can opt for a complete ring. But the concept of the ring only works because you have two fixed point trigonum and go from trigonum to trigonum. But what is very important, the very correct use of the band, because the thing is, in the ring, you cannot make a mistake, but putting a band, you could make easily mistake if you're not an expert, because you need to have the trigonum very fixed to the band. With regard to your second question, I think the treatment of the mitral valve disease in functional mitral regurgitation is palliation, because it is not a disease of the valve, but a disease of the ventricle. So as a surgeon, I'm very reluctant to treat surgically functional mitral regurgitation. There are only two instances that I'm open to do that. One is if you have atrial mitral regurgitation, which is because of the atrial fibrillation. And in those patients, you have in those patients also not only mitral regurgitation, most of those patients have also tricuspid regurgitation and EF. So during the operation, you treat the underlying cause, which is EF, ablation, and then you put two rings to treat the consequences of the underlying cause. That is one. And the second is, obviously, if you need to revascularize the ventricle and you have still viable lateral wall, you can revascularize. So you treat the underlying cause of functional mitral regurgitation, in this case, restriction of the P3 area, and you can repair the valve. Otherwise, in those cases, if there is already an infarction, you need to replace the valve because the results are not well. Or if you don't need to do any revascularization and you have a purely functional mitral regurgitation without atrial component, I would opt for TEER, because I think in the end what you do is palliation, and you shouldn't do a major surgery for that.
Thank you very much, Dr. Sardari. To pass on some remarks and questions to my colleagues and my moderators, Dr. Katsianos would like to contribute to this conversation, and then Dr. Papadopoulos.
Thank you, Dr. Perez. I have a question for Professor Kassel. So we have cautiously selected our patient according to the criteria presented by Dr. P. Barrow, and we have a very good imaging, pre-TEER imaging according to the information presented by Dr. Chrysoheris. I would like to ask you, in terms of device choice, when would you choose a mitral clip and when would you choose a Pascal, in the knowledge of the differences of the characteristics of the two devices? Thank you.
Yeah, that's I cannot answer this question really for everybody because it depends on the experience of the user. The one has more experience with the one device, the other with the other device. In my opinion, the pro for Pascal device is that you don't give too much tension on the leaflets. What means when you have to foreshorten the annulus, like in a functional mitral valve problem, then I prefer more this nitinol device. In my opinion, on the opposite side, in degenerative disease, I think it is good to have more clip sizes. And in this, I like, for example, then also using the smaller clips. In these cases, I prefer more or less the mitral clip device. But I think more or less the Pascal users, they use mainly the Pascal ACE, and the mitral clip users now, they use mainly the W clips, and I think it's more or less the same treatment option with both devices.
Thank you very much.
Thank you very much, Dr. Castle. We're really impressed by your work too. Dr. Papadopoulos would like to make a comment or maybe ask a question.
I would like to make a short comment following Professor Sardari lecture. And I would like to say that according to guidelines, we have an indication of 2A for transcatheter edge-to-edge repair in functional mitral regurgitation patients, but only for patients that are not suitable for surgery or are at high risk. Maybe I agree with atrial functional MR that should be treated surgically, but maybe these indications should change in the following guidelines, because in routine practice, when we screen a patient with secondary MR due to LV remodeling, we usually go with the transcatheter option and not we do not send these patients to the surgeon. I would like a comment on that. And my question for Professor Bibaro is, in real world, which patient will you reject from mitral TEER? Considering that even though we might not change the prognosis of the patient, we certainly reduce the hospitalizations. And this is something that we experienced from our team with Dr. Sparias, from all patients that came, even with very low ejection fraction or advanced heart failure. And if you use advanced strain techniques for remodeling of the LV at follow-up. Thank you.
Yeah, so that's a very good point. I think there are two ends of the spectrum that may be where MTR should not be considered as the first options. I think on one hand, there are the patients where I always felt that if you think, in terms of lifetime management, and the patient is eligible for a surgical mitral valve repair, especially for primary MR. Secondary MR we can discuss, but I think we should do a surgery first, because if you do MTR, you may compromise a future repair. It might be difficult to do repair, and finally it's going to be a replacement. But that's, I would say, the easy end of the spectrum. The other end of the spectrum, what we were calling in the early days of TAVI, the cohort C, were the patients where maybe the heart failure is too advanced and probably the TR will be futile, because it's a procedure that has a cost in terms of paying the device, the healthcare resources, and if it's futile for the patient, then it's a waste of time and money and resources, and taking a risk for the patient. So I think, as I mentioned, the patients that have very delayed LVs, LV and systolic diameter more than 70 millimeter, that has been, by the way, used as a exclusion criteria in COA. If you have a very low LVEF, or if you have this very large LV and diastolic volume more than 140 ml per meter square, they might not be the best candidates. And at least you should try to optimize first, really, the heart failure therapy as much as you can, the pharmacotherapy, and including resuscitation if needed, before eventually considering TR. I do not mean that we should not consider TR, but because sometimes in some patients, at least to improve quality of life and prevent rehospitalization, that might still be a good option, even if you don't maybe have any impact on the improvement on the longevity of life. So I think these are really the patients that may be used. And maybe we need, I'm still, a bit, I mean, these criteria that I provided are relatively simple, and this is what you may have in guidelines, but maybe we need more advanced imaging to really identify the patients who actually may respond to TR versus those where the treatment may be futile and should be treated conservatively. And I think, the myocardial strain may be useful. I think also MRI, T1 mapping, if you have a ventricle that is highly fibrotic, maybe whatever you do, it's not going to remodel and it's not going to respond. And then the indication of TR would be only for improving quality of life.
Professor Pibaro, mille merci. That was really nice. And it shows that this collaboration helps a lot, because we need to identify which patient is for which treatment.
Can I answer the question? Don't know whether.
Yes, please.
There was a question with regard to the atrial mitral regurgitation. Actually, there is no evidence what is the best surgery or so. I was answering which kind of patients I would accept as a surgeon if you consider the functional mitral regurgitation. With regard to the guidelines, it's very important to state that the treatment choice of the functional mitral regurgitation is guideline-directed medical therapy. So it is a 2B actually in Europe and 2A in US. So if that doesn't work and patient is still symptomatic, then you can opt for TIA. So, and you do it for the palliation. So that's
maybe Dr. Patakos would like to make a contribution. As we started 10 minutes late, would like to deliver the table.
Perfect.
On time.
So we have Dr. Reardon in the audience with us, who just wanted to make a quick final thought. And then I think after this, we could continue this conversation for 3 or 4 hours, but we do a disservice to the next session. Thank you, everybody, for being with us. I'll let Dr. Reardon give us his input, and then Dr. Pereas, I'll ask you to close the session. Thank you, everyone.
Well, I want to thank the speakers all for such great talks, and certainly as a cardiac surgeon, I'm very grateful to TIR for particularly the functional MR that I really want to operate on. We do have to remember that, at least in the US, you have to get to the top 10% of risk for repair before you go above a mortality of 2%. So repair remains a very, very safe and reproducible surgical procedure. And there are only a minority of those that have really true degenerative MR that we can't fix surgically or don't want to fix. But certainly for functional, I'm yet to be convinced we've come up with good surgery for that. And MTIR is a great alternative. And of course, we haven't talked about it yet today, but the devices for replacement are making slow but steady progress. But I thank you for some really great educational talks. I enjoyed them all.
Thank you very much, Dr. Reardon. It's really a pleasure and an honor always to have you and share thoughts, because you are also pioneering this. We're looking forward to your speeches later on today. So just to thank everyone, this was a very interesting session. I think a lot of ideas were exchanged and there's a lot to be discussed more, but we would like to finish on time and pass on the table to our next team. Thank you very much for being with us.
Good morning. We're going to start. It's just 12 minutes, a little bit late, but we are going to speed up, so we're going to keep the time. It's session number 2. In Greece, we separate things, session 1, session 2, and there is a competition. So we'll try to make at least equal to the session 1. So good morning. We're going to start. We see here Vlasis Ninos from Thessaloniki. He does a neat introduction. Chief and interventional cardiology, Diavalkaniko, Inter-Balkan, how you translate the hospital. Ηλίας Νινιός, ο κύριος Πιπηλής με τον κύριο Δανιά. Ο κύριος Πιπηλής και ο κύριος Δανιάς είναι φίλοι τα τελευταία τόσα χρόνια στο Υγεία Hospital, so we share the same roof. Οι κύριος και κύριος Νινιός εκπροσωπούν τη συμπρωτεύουσα. So we're ready to start. We have with us Dr. Albin Musa, who is from the Interventional ECHO, Riyadh, Sultan Hospital, I think. Is that pronounced well? So it's nice to have you with us. And we're going to hear a very interesting imaging considerations for non-eligible M-tier patients. We're here to enjoy your talk. Thank you.
Thank you. It's a pleasure to be with you. Thank you for the organizing committee for the invitation. It's a pleasure to be in this city, beautiful city, for the first time in my life. So I'm going to give some lights on some difficult or non-eligible, non-variable cases of non-eligible for mitral tear, and we'll just go over one case at the end to show how to deal with such patients. So, sorry, it's not moving. Okay, so these are my disclosures, and it's clear now that we are in approaching the mitral valve management, we have to understand the etiology of the cause of the MR, whether it's a primary or secondary. But commonly, we are seeing a mix of both etiologies in the same patient. Now, from imaging point of view, we have to look at carefully at the anatomy of the mitral valve and try to decide whether it is suitable or not suitable. However, I like to use this terminology, it's a favorable or unfavorable, because as your experience grow up, you will be able to do more complex and less favorable cases. As a startup, when I started the interventional program of ECHO, I was looking for these patients where it is ideal. Central pathology, no calcification with the large mitral valve area, enough posterior leaflet length, where if you see this patient or you deal with such patient, you will end up with a very favorable result with mild MR and the low gradient. However, life is not easy always. We always see such patients like rheumatic mitral valve with a small mitral valve area, restricted posterior mitral valve leaflet with high gradient. And I was thinking always why the smaller mitral valve area will end up with, it is less favorable, but this is clear by this study where it showed that using one clip will reduce the mitral valve area between 52 to 57% of the original mitral valve area or the baseline mitral valve area. And if you add one more clip, you will end up with more 25 to 34% reduction further in the mitral valve area. So it's clearly that you don't want to use to deal with patient with mitral valve area less than 3 centimeters square. The very short posterior mitral valve leaflet is a challenging let's say, condition where we are dealing with very short and difficult to grasp. And it's not only the length of the posterior mitral valve area, the posterior mitral valve leaflet. It is all the shape of the leaflet. It's usually curvy, and this restriction which make the grasping of this posterior mitral valve leaflet difficult and challenging for interventional colleagues. Now, another challenging condition, which is the severe MAC, this will make the posterior mitral valve area is very short, restricted, and will put a great risk on the leaflet for if you grasp that leaflet to rupture or to tear. However, saying that, I came across this study from Spain where they did actually deal with the severe MAC patient with the mitral valve tear, and they have a good result compared to the control, but also saying we have to mention that there is a risk still of cord rupture and conversion to surgery. So you have to be careful with dealing with such patients with mitral valve tear. I personally prefer to send these patients to cardiac surgery rather than dealing with them percutaneously. Deep cleft or indentation, another challenging condition for tear, where you have to make sure it's not a true cleft, not extending to the annulus. If it is not, it will be also challenging for the strategy and planning of treatment, where you don't know how to treat them ideally, but now we are using the A technique to deal with such patient. But if it is like this image, if it is a two cleft, really I don't know how to deal with such a condition. We didn't do such a case. We use only one cleft rather than two clefts. So it's another challenging condition where you have to think deeply how to deal with such patients. Another condition which is I face not that frequently, but I would say we have those patients with a small left atrium. And I'm not sure if it is an accurate terminology to call it a small left atrium, but rather the shape of the left atrium is a small in the vertical axis. I would think that the dilatation, it is more of a horizontal dilatation rather than vertical dilatation. This makes the septal height low for your transseptal puncture, and maneuvering the device will be more difficult in this small LA. And like this patient, we were doing the perpendicularity in the ventricle, and this will put a high risk for complication during the procedure. So it's not that common, but you have to be careful for these patients and expect the worst. So I'll present this case, and I'd like to hear from you your opinion. A 76-year-old male, diabetic, with history of MI, post-BCI to LAD in 2022, ejection fraction severely reduced with 25%, with recurrent admission due to decompensated heart failure despite optimal guideline-directed medical treatment. A recent coronary angiogram showed patent state with no obstructive coronary artery disease. Not candidate for CRT because he's a narrow complex QRS, and this is his transthoracic echo. So you can see that it is severely reduced LV function, dilated left ventricle, and it's clearly a severe MR. But the question, what do you think about the posterior mitral valve leaflet? So it's a functional, let's say. Do you agree or not? We were really concerned about the posterior mitral valve leaflet, and we thought that there is some rheumatic changes. The transesophageal echo, you can see there is a wide gap, severe MR definitely, no doubt, but again, there is a great concern about the posterior mitral valve leaflet. The gradient was 3 to 4. That's added to our concern in discussing this patient for mitral valve tear. The mitral valve area, now we had two measurements. One is 3.2, one is 3.7. Probably the 3.7, we a little bit extended our tracing, but clearly also you can see the reverse in the pulmonary vein. This is a STS score. You can see that the morbidity and mortality is quite high, 17 to 20%. And the cardiac surgeon in that hospital, actually we were doing in a different hospital, so the cardiac surgeon, he said, no, I will not operate in such patient. And there was no percutaneous mitral valve replacement, no tendine in that facility. So what do you think? Should we proceed with mitral valve tear or not? So we decided to, let's try. And this was after using the XTW, and after grasping of the mitral valve, there was really a wow in the cath lab, because there is almost elimination of the mitral valve regurgitation, but the problem was this, the gradient 12. So now the discussion was very, let's say, hot in the cath lab, what to do. So the options we were discussing, abort, send for surgery. The surgeon, he said, no, I cannot take, I will not take. Then the other option, as I said, it's percutaneous mitral valve replacement. It was not available in that facility. We remain with NTW, NTR, XTR. So from expand registry, we know that there is no difference between XTR and NTR in the mean gradient. So we thought the same, using NTW will not change the outcome, so we remain with XTR and NTR. Unfortunately, NTR was not available in the room, so we used the XTR. After careful adjustment of the perpendicularity and the positioning of the mitral valve of the clip, we end up with this result. So the MR is in the range of moderate, if you agree with me. And the gradient was 7, and there is no pulmonary flow reversal. What made us more, let's say, happy is the hemodynamic results. So the LA pressure, the mean LA pressure dropped from 45 to 20. The V wave from 65 to 40, and the next day transthoracic echo, the mitral valve mean gradient remained the same, so 6 to 7 with same degree of MR. So we thought it's a reasonable, good result, taking all the circumstances the patient has and all the condition. So I will conclude that careful assessment of the mitral anatomy and morphology for better selection and outcome. At some time you have, actually not sometime, frequently you have to balance between MR reduction and stenosis and complications. If you are starting up your mitral valve intervention, start with more favorable condition, and as your experience grows up, you can do more complex cases. And by this, I would like to thank you for listening. Thank you.
Thank you, Dr. Al-Mamouza. We saw how you can deal with difficult situations and especially making decisions in the operating room. At the end, we are going to have questions for you.
Thank you.
So thank you very much. Dr. Danyas, senior expert, especially in the MRIs in our hospital, a well-known cardiologist from US, from Harvard, is going to introduce the next speaker, Vlasis Ginos.
Thank you, Mr. Chairman. It's a really great pleasure and honor to introduce the next speaker. Dr. Ninos is an interventional cardiologist. He's the director of the second cardiology clinic of the Transbalkanic Center in Thessaloniki. and we will listen to the discussion about transfemoral TMVR. Dr. Ignaz, the podium is yours.
Thank you, Mr. Chairman. It's a great pleasure to participate once again in this, I would dare to say, legendary course. It really set up the standards in Greece. The question is, why TMVR and why transfemoral TMVR? And why do we need it now that we have such a successful TEER outcomes? You've heard the previous session about the TEER and the eligibility, but you've also heard the previous speaker talking about the non-eligible or limited eligibility patients. So TEER is very powerful, is very effective, but there is high potential for residual MR or stenosis. TMVR by definition eliminates the mitral regurgitation, and you're just left with a new valve in place, which is good news for the patient. However, why didn't it take off like TAVR? Because clearly transcatheter mitral valve replacement is very complex. And we made some assumptions which were obviously wrong back about 10, 12 years ago when the first designs of the valves came out. And out of these designs, only 3 are still alive and with several modifications and still struggling. Why did we make the wrong assumptions? Because we didn't know how to size the implants. We didn't know what technology to use. We didn't know which patients to enroll in the clinical trials. Let's not forget that TEER was also at the early stage itself. So we had issues with the size of the ventricle, the size of the annuli, the ejection fraction. We also had issues with the large valve profiles that were mostly transapical route, and we know transapical is not good. The radial force was low, and we were clearly having a lot of trouble with the potential for LVOT obstruction, with the difficulty in getting a percutaneous femoral access. And let's not forget the MAC, which there's a talk about it later on. That is always a big issue for surgeons and interventional cardiologists. The thing is that with the Choice MI registry, we realized that due to the annulus size, due to the risk of the LVOT obstruction, due to the presence of MAC, and the difficulty of having a transeptal delivery, a significant proportion of patients, up to 85%, have been screen failed. And in my humble opinion, this percentage is even higher because you have to think that these patients have been submitted by experienced centers that have already had a selection bias on these patients. So some of them went to TEER, some of them were ruled out because of various issues, and then the ones that were thought to be potentially suitable were sent out to the companies to be screened in for the various trials. And of course, these are the most important reasons why the patients have been screen failed, but clearly the LVOT, the MAC, and the size have been limitations, the big limitations. But we have new kids on the block, we have new devices, we have all these names that I will allude to in a minute, and clearly everybody now is thinking transfemoral, everybody is thinking of fully percutaneous approach, and in order to do that you have to reduce your sizes. So Intrepid is going down to 29, and Circle M3 within Circle trial is going down to 28, High Life is going down to 30, and the CardioValve down to 28. And for example, Intrepid wants to increase the size to 54 in order to include more patients. High Life has come up with an open frame design, the Clarity trial. We have AltaValve that I will allude to in a minute, and we have a new design, totally revolutionary, the InnoValve, which is twisting the subvalvular mechanism in order to create a more physiological response, especially in functional patients. And we have Sophia that has been redesigned now in coming in lower profile and larger size matrix. InnoValve is a new design that comes in transfemoral, twisting the cords in functional mostly patients, and this is aiming to restore the bidirectional flow and promotes potentially the LV remodeling. AltaValve, I will speak to about in a minute, is a transatrial device. It is an atrial fixation device, supraannular, that leaves the LVOT and the left ventricle widely open and unaffected, and allows for potential more physiological way of function. And of course, the transapical tendine that the information says that is going to be out of the market, at least in the US. There's no potential for that. But the MAC arm of the Summit trial has finished recruiting, so we're eagerly awaiting for these results. I'm not sure if the randomized arm that was very bold and very ambitious to compare it with TEER will ever complete recruitment. Apollo trial, or Apollo Odyssey, shall we say, with many redesigns of the trial itself, is now moving on in US and Europe. So hopefully we'll have some results on that in the next years. And I hear that the Encircle trial has finished recruiting, at least in the MAC arm, perhaps in the main study. So it will be very interesting to see the results of this too. AltaValve, we have some personal experience, so it's nice to show one case just to have a flavor what TMVR is about. It's an atrial fixation device with a nitinol stent frame opposing against the left atrial wall. The valve itself is a bovine pericardial valve. It's sat above the annulus. It's a 27 millimeter, same size for every implant. There's an annular ring at the bottom of the implant that conforms against the left atrial annulus. There is no active fixation. It's all passively opposed against the left atrial wall. The interesting thing is that the clinical experience is increasing, and potentially there is a broader applicability of patients. The system we're currently uses 29 French, so is low enough profile to allow for fully percutaneous approach, and the procedure itself is done in a single stage, 5 single steps, as I will show you in a minute. So up to 77 implants have been implanted worldwide, and the EFS now has an update in EuroPCR of more than 25 patients. So we have these sizes. 25% of these patients have been implanted with a 54 millimeter device. Interestingly, the procedural mortality and major adverse events, especially in the transfemoral cohort, is 0%, which means it's a very safe procedure, as you would expect for a transfemoral approach. Patients are improving their functional class. There's no gradient, both in the mitral valve and the LVOT. And interestingly, the ejection fraction of the left ventricle is maintained. KCCQ is improving, especially in the transeptal cohort, by 20 points, and 6-minute walk improves significantly by 80 meters. And we have a small subset of patients published recently about MAC. It seems that the device is interacting quite favorably with the MAC, which is, as I said, a difficult subset of patients, improving their functional outcomes. This is how we do the procedure. It's a standard transeptal puncture, inferior and posterior. We thread a Landerquist wire for support. We create a balloon septostomy. Just 8 millimeter balloon is enough. We don't need to create a big hole. The steerable guide sheath is introduced, 29 French, inside the left atrium, as you can see here. And then through that sheath, in a minute, you will see the delivery system being introduced there. And then we will just flex the sheath towards the mitral valve. This flexion is monitored both on fluoro and echo. You will see the flexion there. It's a simple function, nothing really spectacular. Everybody that is doing a TEER procedure is very familiar with that. The device finds itself 10 to 15 millimeters deep inside the mitral valve, and you can monitor that on TE with the commissural and the long axis view. And then the whole procedure starts by unsheathing the valve backwards. So there's a dual unsheathing function. First, you unsheath the inner catheter by deploying the annular ring. You can see now the valve is flaring. And in that particular stage, the valve is already partially deployed, but is functional. And then the next step will be to unsheath the cage. And I'll just accelerate this video. You can see now the nitinol stent frame. The cage is deployed against the left atrial wall. You can monitor that with echo. The valve is fully functional. The patient is hemodynamically stable. Fast pacing, but not rapid pacing, is required. Once we're happy with the position and the hemodynamic check and the echo check, we're ready to deploy the valve now. And you can see that deployment. There is an inner catheter for stability that is removed. And then the final deployment. The valve is fully repositionable and resheathable up to the last deployment function. And this is how it looks on echo. You can see the valve is sitting at the level of the annulus and above it. Clearly there's no stenosis. And interestingly, there's an anterior tilt of the valve, leaving the LVOT widely open without any LVOT obstruction. This is how it looks on the 3D echo. And generally, a procedure like that takes about half an hour. You can see the active sealing that the native leaflets are providing to the implant. The pivotal trial is about to start in Europe and the US. So, in my personal opinion, I think we're getting into a more promising era of transfemoral TMVR. Potentially, you can say that we are going to live exciting times ahead, but of course, we need to be quite humble and just do the work. Since this is a forbidden fruit for interventional cardiology, the field is exceptionally difficult. However, if these steps are taken, it's quite likely that we may have a commercially available device sometime in the near future, and that potentially could change the field dramatically. Clearly, in my opinion, the future is transfemoral and fully percutaneous. There's no doubt about that. The big provocative question and discussion for the panel and the audience is it now time for TMVR to step forward and finally come out of the shadows? Is it prime time for a randomized trial against TEER? And if so, for which patients? Thank you very much for your attention, and I'm clearly open to discussion.
Thank you very much. Thank you very much, Vlasi. I see that the speakers, this session, they keep the time quite well, so we're on time. At the end, we're going to have the questions and answers. The director of the first department of cardiology at the Gia Hospital, Dr. Pipilis, Thanos Pipilis, will introduce the next speaker, who is Dr. Pitsis. Yes.
Yes.
Dr. Pitsis is a good friend, a leader, a pioneer in Thessaloniki and everywhere, hard worker, big sailor. It's very nice to see you, Dr. Pipilis.
I'm also glad to welcome Dr. Pitsis to this interesting meeting. Dr. Pitsis is from Thessaloniki, so we stay north, and he's one of the leading surgeons in Greece. I have a personal experience of his achievements. His topic today is therapeutic options for degenerated mitral bioprosthesis, a problem which is inherent to the bioprosthesis. Some people say that it's very few years that they last. We usually give false hopes to the patients that it will last longer, but we face the problems quite often.
Adoni, before you start, I don't know, I'm sure your speech is going to be excellent, but who took care of your picture this morning did a good job. You look 10 years younger.
Thank you, thank you. Well, we have the zoom effects, you know, the background effects and the zoom effects, so I have used them all, you know. If you are reaching, you know, a certain age, you need all the help you can get. But Stratis, I have to say that I'm really deeply honored to listen, to be invited, first of all, to this great meeting by Kostas. And I mean, he has done an exemplary work, and I'm deeply honored to be a friend of yours. I consider myself a friend of yours, and you know, you are the king of cardiac surgery in Greece, and but you are a great person. Thanos, thank you very much for the kind introduction. Petros, I do appreciate the collaboration and the work with all of you. And of course, we are in the same heart team with Vlasis, who just presented. So my presentation, I took the liberty of slightly change my title. But before I go there, I want first to remind everyone that we are very, very lucky in Greece in cardiac surgery that this year we have 2 international meetings hosted in Greece. The first one is the end of the month, 29th of May, 1st of June in Athens. It is the meeting of the International Society for Minimally Invasive Cardiothoracic Surgery. It is an annual meeting. It's a great honor for the Greek Cardiothoracic Society, Cardiothoracic and Cardiovascular. It is in the Intercontinental of Athens Hotel, and this is the venue. And there are many participants as Stratis, Patakos, Theokofidis, Gregory Patakos, and lots of Greek faculty as well included in this meeting. So really, it's a great honor. And the second one that I want to remind to everyone is another international meeting, which is the 3rd annual meeting of the Endoscopic Cardiac Surgeons Club. This is going to be hosted in Thessaloniki. It is under the auspices of the Hellenic Society of Thoracic and Cardiovascular Surgeons. We're going to have lots of live cases, endoscopic and robotic for the first time. Many live cases, many live in a box, video competition, video games, as we call it. So hopefully we're going to generate a lot of interest. I mean, the cardiothoracic society community around the globe is deeply interested in the endoscopic cardiac surgery and robotic cardiac surgery at the moment. There is no question that the interventional cardiology has made a huge step forward with the introduction of TAVI and TMVR and TEER and all these great technologies and techniques that we have witnessed, but also cardiac surgery has made a lot of progress. So I'm going to, okay, I mean, Vlasis has really alluded us in what's going on with all these TMVRs and so on. So as Vlasis said, and Kostas, I have heard him many times mentioning, there is no question that mitral valve is not like aortic valve, and there is no question that TMVR is not like TAVI. There are many things that we don't know. Reminds me of obviously the quote by the Greek philosopher Socrates that everybody knows. I know that I know nothing. The only thing that I know is that I know nothing, and this is, I think, what we can say about TMVR. The only thing that we know about TMVR is that we know nothing. And I mean, there are lots of examples and lots of paradigms that we can give, but certainly it is a quest to find the right device, or the right devices, I may say, but certainly we have lots of issues in this quest. I would like to present a case, and this is just to say that there is plan B after a failed TMVR. So I'm not going to talk about failed surgical barrioprosthesis, and this is the slide change I'm making my topic. I'm going to talk about failed TMVR. Obviously, you need a great heart team in order to be able to do these cases. The same like Hygeia Hospital has among all of you guys, and we have a great team here in the European Balkan Medical Center in Greece. So the case presentation is this. We're talking about an Alta valve that was implanted something like a year and a half ago on a 76-year-old man with a BSA of 2 square centimeters, BMI 28, height 173, weight 84. He was in class 4. Before the operation, I think the patient was suffering from dilated cardiomyopathy. He had annular dilation type 1 due to chronic AFib, and he had obviously severe MR, and there was some degree of TR as well. At the time, I can't really recollect the patient myself, but anyway, the patient was implanted with an Alta valve, and following that, his heart failure started to worsen. And when he arrived back to the heart team, Vlasis asked me to have a look at the patient because he was in class 4, and there was a significant paravalvular leak in the Alta valve. Obviously, the patient was still in chronic persistent AFib. The coronaries were normal. The Euroscore at the time, the Euroscore 2, was calculated as 10.9%. I'm not sure whether, obviously, it is applicable in cases like that, but this is a rough estimation. And the patient was with a pre-op systolic pulmonary artery pressure of 100. I'm sure that the surgeons in the auditorium will say, okay, 100 pulmonary artery pressure systolic is not really a Euroscore 2 of 11%. It's a lot more than that. So this was the echo. This is the intraoperative, preoperative TOE, and you can appreciate the Alta valve sitting where it has to sit, probably, but there is significant paravalvular leak. Maybe it's a bit, well, Vlasis would be better in describing the position of the aorta valve. Maybe it is a bit moved or rotated, maybe. But there is significant paravalvular leak. There is a mean gradient of 5. This is the ASD in the place it should be for the positioning of the aorta valve. And also, I will go a bit back. You can appreciate that now there is also significant tricuspid regurgitation. Yeah. So there is a significant tricuspid regurgitation, as you can see in this area. So we have a patient clearly with a failed TMVR with a caged valve, with a huge metallic cage inside, expanded inside the left atrium. And the question obviously is what we're going to do about that, because this is an issue that not many surgeons have encountered until now. So our approach was an endoscopic approach, and you can see the periareolar incision in the third or fourth intercostal, I can't remember, third or fourth intercostal space that we usually use for the mitral and tricuspid cases. And obviously it is a totally endoscopic approach. Everything that goes on the screen. The screen is 3D 4K. That's the reason it seems a bit hazy. It is because it is 3D. And this is a robotic arm that holds the camera. And this is the Bluetooth voice control of the robotic arm. So this is the endoscopic view. And obviously the aorta, SVC, RA, you can appreciate that there is a cannula. This is the long cannula from the femoral vein inside the SVC. And we're at the stage that we're about to clamp the aorta with the Chitwood clamp, the liver cardioplegia and the aortic root custodial cardioplegia. The surgeon's strategy, you see that the left atrium is very tense. And the reason is obviously that there is a metallic cage there. So the knife hits metal every so often. So we have to be extra careful not to destroy all of our scissors. They're very expensive. So here you see the cage. And as soon as we enter, again, we have to deal with this. So the umbilicus, should say, of the device was sitting inside the, as you can see, well, here, guys, is the, for the cardiologists, the surgeons know that, is the superior, right superior pulmonary vein. This is the right inferior pulmonary vein. And the umbilicus of the device is inside the right inferior pulmonary vein. So maybe this was one of the causes of this issue, that the device was going inside the right inferior pulmonary vein. So we removed it from there with some difficulty because there is Teflon there, there's Dacron there, there is a synthetic material that causes adhesions. So with some difficulty, the device was already a few months old. And you can see that there are lots of thrombus formation around the stent. And also you can appreciate that there is, this metal stent is going through the endothelium of the left atrium. So the next thing to do is to pass a thread around the umbilicus of the device in order to try to do a reverse expansion of the device. So the same way that the device was coming out of a tube, okay, percutaneous tube, but this time it's going to be an endoscopic tube. We thought that we're going to have to do exactly the same. So we passed this thread around the umbilicus and we passed it through a plastic tube. So in order to create this reverse expansion, and this is the plastic tube of a diameter of something like 12 millimeters or 15 millimeters, something like that. A good sized tube, and then slowly starting to take off the, take out the stent out of the wall of the left atrium with great care not to endarterectomize the lot of left atrial wall, because if we were doing that, if we were just pulling the device out, then obviously we would have a huge operation to deal with afterwards. To make a new left atrial wall, and the patient most probably would have died. So very, very slowly, going all the way down to the annulus. At the level of the annulus, we found this white skirt This is obviously a mesh material, which was good because it wasn't very adherent to the annulus. You can see that there are lots of clots around the stent, between stent and left atrial wall. And finally, we were able to rotate and get it out in one piece with the valve intact. Obviously, we were left with this thing. You can appreciate that up here, there is this hole. Up there with the hole is the ASD, obviously. There are tiny holes in the left atrial wall, like the one that we are closing now. There are lots of clots that we have we should be very, very careful and remove them all, because otherwise the patient is going to have obviously a stroke. And then after we finished with all the, let's say, the washing out as much as we could of the left atrium, it looks like a dog's food. There is no question about that. Then we started to put the annular sutures and implant a mosaic valve. This is a mosaic valve. We have chosen in this particular case the mosaic because it has a huge stent in order to cover any holes around the annular area. Also, you can appreciate, this is for the surgeons, that there is a suture for the commissural posts of the mosaic valve that cinches the posts together. And the reason for doing that is that we didn't want, obviously, one of the commissures to impinge on the leaflets. We try to preserve all of the subvalvular apparatus because this is a heart failure patient. After finishing with that and after closing the ASD as well, we also put an atri clip in the left atrial appendage. The reason for doing that is the patient obviously is in chronic persistent AFib, and this is the atri clip. I will go back a bit. This is another 2 minutes job for if you do it with this device, which is called atri clip. In chronic AFib, the patient, as I said, so we have to do that. This is type 1 indication in the guidelines. And after doing that, we did also the tricuspid valve. And here you can appreciate that these are the tricuspid leaflets. So we did a modified Clover technique, a triple edge-to-edge repair. So 3 sutures in each of the tricuspid leaflet. And we just closed these sutures together with a single cord knot that comes down now. Also, the patient had the pacemaker, as you can appreciate. The pacemaker lead was displaced towards the commissure between the septal leaflet and the posterior leaflet, which is here. This is the anterior leaflet. Obviously, this is done on the beating heart to save some cross-clamp time, and this is obviously the right atriotomy that we used in order to do that. And this is the post-op TOE. You can see the mosaic functioning normally, no leaks, nothing. And you can appreciate that there is also no tricuspid regurgitation and no atrial septal defect. So this is the, yes, this is, well, just a whiff of tricuspid rigors. As you can see, this is the triple edge-to-edge right in the middle with the cord knot right in the middle in this nice 3D view. And peak gradient of the mitral 2, peak gradient of the tricuspid 3. Is it tricuspid, this one? I'm not sure. Oh, sorry, it is mitral, sorry. So the peak gradient of the mitral valve, it is between 2.5 and 3, 2 measurements. Preoperatively, it was 5 something, 5.5 or something like that. So cross-clamp time 109 minutes, bypass time 210 minutes, skin to skin less than 4 hours. A post-op systolic pulmonary artery pressure 55 from 100, CVP 17 from 25. TV mean gradient, which is very important because we did a triple edge-to-edge 1.2. This is the mean gradient of tricuspid. And the follow-up in 1 year, the patient is still in class 1. Now it is more than 1 year. And at some stage, we have to report and publish this case. Thank you very much for your attention. And please don't forget to support the Greek participation to the international cardiac surgical arena. Thank you very much.
Thank you very much, Adoni. We didn't expect anything less from this impressive presentation, a life-saving procedure, and once again showing that cardiac surgery is not off. Still can go after interventional cardiology and save things. So please stay with us for after the next two presentations for some questions. Thank you very much, Andoni. Dr. Ilias, this time Niños, will present our president here, Kostas Parias, who, as we said even yesterday, for a little bit of unfortunate backache, he stays home. He's going to present his case right now, his topic, and Dr. Niños will present the...
Thank you very much. It's a great honor to introduce Dr. Sparias. Dr. Sparias is an interventional cardiologist, is the head of the Transcatheter heart valve department in Ygea Hospital since 2010. He has performed, and his team, many hundreds or thousands of transcatheter operations in the field of the mitral and the aortic valve. He's one of the pioneers in Greece and in the European countries, I think. And Kostas is going to talk about the valve in MAC. Kostas, thank you very much also for the invitation. The topic, the stage is yours.
Thank you, Elias, for the kind introduction. And what a wonderful panel I can see there, all good friends. And also the speakers in these sessions. I can't imagine of any best selection of speakers. Zachary, Adonis, Theo is coming after me, Vlasis, and wonderful talks I have watched so far. So I'm a testament that complications of TAVI also occurred in the operators, not only in the patients. So that's why we should be careful and take care of ourselves. That was a very difficult TAVI 2 days ago, and that it took some effect on me. But the meeting was ready, everything was set up, so I don't think this personal problem has any impact on the flow of the meeting. So I really enjoyed Andoni's presentation and Vlas's presentation earlier, and I think this is a testament of why we need the surgeons, like Stratis said earlier, and not just any cardiothoracic surgeon, but we need the cardiothoracic surgeons that are very, very experienced, because the cases that will be left for surgery in the future will be those select and very difficult cases, not the simple ones. So my talk is about MAC, and I think you would all agree that MAC is the worst of the worst, and is the worst pathology you can find in the mitral valve, because it usually comes with a combination of mixed mitral valve disease, both stenosis and regurgitation, that makes all the tools we have for treating stenosis or regurgitation individually and not valid in this pathophysiology. So the disclosures and our heart team at Ygea, and the pathophysiology of the calcifications in the mitral and aortic valve is very well presented by a fellow Greek in a recent review in the European Cardiology. It's not of my current speech, but I recommend that you go back and read this for the scientific background and the theory behind the calcifications of the leaflets. Just the presence of MAC in a patient is a very bad indicator. So in this ECHO study of thousands and thousands of patients, those patients that had MAC, they had the worst mortality during follow-up. And of course, we all know that MAC poses very serious risk in surgery. We can have lethal skeletal tears that we cannot correct, injuries from the sutures, dehiscence of the bioprosthetic valve, rocking bioprosthetic valve, and of course, paravalvular leaks. And calcification comes in many patterns. It can be symmetric or asymmetric. It can be something like a combination of cheese and MAC, the caseous MAC, as we can see here, where we have accumulation of different quality of calcium within the egg cell of the main calcium. It can come in beads, beaded MAC, like you can see here. And also we have the MAC queen concept when we have the calcification, but we have a hat on the top, which is a prosthetic valve, either a TAVI valve or a surgical valve. This is the MAC queen pattern, as you can see here. And we had the recent publication of Maya Guerrero of how to classify these MAC calcifications, and we give points depending on the thickness, on the distribution, on the trigon involvement, and the leaflet involvement. And this system, the score, is very important when we decide to do something for these cases. Let's start with a couple of cases we had the chance to treat in the past. This is the first MAC we did our team. So you see a patient typically with mixed mitral valve disease, both regurgitation and stenosis. You can see the calcification around. This is a MAC queen patient because we had implanted TAVI sapient valve some years before in these patients. And this is the assessment. We do the detailed assessment with the CT scan, the planning of the valve, and we like to do this assessment with 3D printing of the hearts of these patients when we want to do MAC cases at Transcatheter. So we like to simulate the procedure, we implant the valve, and we just visualize what is the effect, how the valve tilts, if there is any paravalvular space around it, and this is very, very helpful. So this is what we did in this case. We're satisfied that there was no alveolar obstruction, there will be no paravalvular leak with the selected size, and we went transapically. This is how we're going in the first cases, and you see the implantation of a sapien 29 valve. And you can see two sapiens, one in the aortic valve, the other in the mitral valve. These valves sat very well. There was no paravalvular regurgitation, and the final result was very good in the long term for this patient. And on the other edge of the spectrum, this is another patient that we embarked to do the same procedure, very severe MAC, as you can see. And it was considered to be inoperable because of the thickness, the extension, the distribution of the calcification. So our measurements were like borderline. You see at one level, the area was 700 millimeter, which is at the upper end for a 29 millimeter valve. But at other levels, it was larger than this, and the diameter was like 20 by 32 millimeters. So it was a very borderline case, the beginning of our experience. And we proceeded to do MAC procedure. The neo-LVOT was considered to be adequate, and we did all the screening. And we can see here that if we take a 29 sapien valve and you overinflate it, you reach to this area to 742, which in this calcium we thought it would be enough. So this is the implantation, again transapical, with 5 ml of contrast more. And initially the procedure was uncomplicated. The patient went very well, and we had the patient every day echocardiography, and we were watching the valve and the position. And then the day of the discharge, the 5th day, the patient started having shortness of breath, and we noticed that the valve had slipped and migrated a little backwards compared to the other days, and we had this paravalvular regurgitation. So this is from the table when we tried to save the patient. Unfortunately, we didn't make it. And this is the reason of why we need to flare the mitral valve when we do it in MAC. So MAC patients, when you do a transcatheter implantation of a sapien valve, we have, this is the largest registry of more than 100 patients. You see those patients are very high surgical risk score, 15%. In this registry, it was an equal share between transeptal and transapical. It's an older registry. And you see high numbers of problems, 11% LVOT obstruction, 4% valve embolization, need for a second valve in 15%, and conversion to surgery in 3 to 4%. And you also see a very high mortality, even larger than the STS score, 25% in the 30 days. Of course, during the course of this study, there was an improvement because they learned to use CT scan assessment and sizing, but still you can see in the later cases the 30-day mortality was close to 20%. In other registries, again, the same results, not very encouraging. You can see always double-digit mortality in 30 days when we embark to do these cases. So if we use this recent score, and this is how we use it, and as you can see, the score is from 0 to 10. The more calcium you have, the better for this case. And you see here that the more calcium you have, the less valve migration, the less PVL, and the better the result. Of course, when you have MAC, the neo-LVOT area is always smaller than when you have to do valve in valve on valve in MAC. So this is the printing we do and how we search for the LVOT, the view from the ventricle and the view from the aortic valve. And then we implant the valve of the size we intend to implant, and we check from the ventricular side and the atrial side if we have any problems of PVL. So in cases that you suspect to have an LVOT obstruction, transcatheter electrosurgery and alcohol septal ablation, pre-empty alcohol septal ablation, are used to reduce the chances of this event. And the laboon comes in many flavors. So you can go from the aorta to do the classic laboon. You can go transeptally to do the antegrade balloon. You can do the tip to base balloon when you create a loop. And all these are used rarely in cases that you cannot do anything else. So other also techniques are proposed, like to destroy the anterior leaflet of the mitral valve with a balloon, just to go through with the wire and then to dilate it with balloon and destroy it. And another position is to do a modification using endoscopic scissors like this. And this is a case that we tried this, the modification with endoscopic scissors. You can see it's again a mixed MAC with stenosis and regurgitation. You can see the anterior leaflet is very calcified, nothing moves. These are the gradients, 11 mean gradients. And there was also an aortic valve prosthesis there with the expected velocity through this. This is the calcification, and this is the beads of the calcium, as you can see, that are extending below the annulus of the mitral valve. And we did our measurements, and we thought that even if you put the valve very atrially, there will still be a problem, and all the measurements, as you can see, of the neo LVOT were like below 1 square centimeter. So this is the setup through an Accentra sheath that we use for transapical TAVI. We use this thoracoscopic scissor, and we initially transapically, of course, through the valve, and then you can see the scissor that is advanced to encapsulate the anterior leaflet. And here you see the opening and the closing of the scissors having inside the anterior leaflet and cutting the anterior leaflet, and here fluoroscopically the same thing. And we did it twice on the anterior leaflet. You can see it again here. And immediately we saw that there was a piece of anterior leaflet that was detached and moving, so we certainly modified the anterior leaflet. We also see the movement here, that was the cut we created, and of course more mitral regurgitation, as you can appreciate here. So we implanted the valve, and we had a very good result, stable position, and we used also a sentinel because of the calcium for protection of the brain. And this was our result, no regurgitation, and as you can see, very nice seating of our valve, and the gradient remained in the aortic valve unaltered, as you can see here, the same day and the following day, 2.4 velocity. And closing my presentation, uses of TMVR systems like Tendyne in MAC is undergoing investigation. The MAC cohort has finished of the study, but the problem is in the main study that has difficulties to recruit, and like Vlas said, we don't know if it will ever finish. Hopefully, we'll see the results of these sub-studies of the Tendyne. And as you can see, examples that Tendyne was used. But we know from the initial roll-in experience from this valve, as you can see, these are the first 103 patients, mortality is 7%. The 30-day mortality is 7%, which is really high, and I think it reflects the transapical nature of this procedure. And if we go to transeptal, like with the Alta valve, this number hopefully will be a lot lower. And this is the other valve that is undergoing investigation, the Intrepid. Also, the Apollo trial has a MAC cohort, and these are examples of MAC patients that are accepted for this valve. But I think the surprise will come from the M3 system. The Encircle trial has already has been completed, and we'll have the results at TCT this year. And rumors say that this will be the first valve to get CE mark and FDA approval within 2024. So this is the valve we all know, the Sapien valve, that is implanted within a dock. As you can see, this is a dock that you go and put into the mitral valve apparatus before you implant the valve. So the main study has finished, the failed T registry with 100 patients has finished, and the MAC registry has finished. And hopefully we have these results very soon. And with that, I would like to thank you for your attention.
Thank you very much, Kostas. Very nice, enlightening presentation. Once again shows how things in the difficult areas, or as is MAC, that, as I said to Dr. Danyas 30 years ago, we were going to surgery without knowing what we were going to see. We didn't have echo into the operating theater. And now how nice solutions and nice results from the patient. So please stay with us at the end so we can have some questions, because our first enemy is the time. 15 minutes left, but probably we're going to extend it to 25 because we started a little bit later. And I have the privilege to introduce Dr. Theodore Kofidis, professor, chairman at the Singapore University and Hospital. And he is going to be with us. It was about to show a video, but just I was happy to hear that Professor Kofidis is going to be live with us, and he's going to present the minimally invasive repair for mitral valve regurgitation. Professor Kofidis is going to join us forever for the next 50 years in a few months by late June at the YIA Hospital. So we have to have the honor, the opportunity to see him, work with him, and enjoy his experience. Good afternoon, probably. There is afternoon, correct? Good afternoon, and we're here to hear your presentation.
Good afternoon. Can you hear me and see me?
Yes, very well.
Thank you very much. I couldn't have been happier and more privileged to be introduced by such panel and Dr. Patakos. Good evening, good morning there to everybody. Indeed, a great honor to be part of this assembly. even though from the distance. Without much ado, let me share my screen, and you'll be fortunate to know that in the last few minutes I managed to chop my presentation down to a fewer slides. Let me see. Can you see my screen?
Yes. Yes, everything
okay. Excellent. I'm going on full presentation mode. Well, it is indeed a pleasure for another additional reason to be here today, because for the first time, you will not see my credentials under my name being assigned to Singapore in the National University of Singapore. And you will be witnessing more and more the futuristic images from Singapore being replaced by ancient cultural images from Greece. But I think it was mentioned already what's next to happen. In that sense, we don't need to waste any more time on that. Disclosures? Well, minimal invasive procedures can be many. Nowadays, we're moving towards minimal invasive approaches. They encompass mitral valve, tricuspid valve, aortic valve, combined surgeries, bypass surgeries of all sorts, ASD closures, and some other congenital disease procedures, MACE procedures, and, as I mentioned, congenital conditions. Now, there is little to argue about the pantheon of mitral valve disease. I may be forgetting some of our colleagues here, but I can't fit more on one single slide. The most known of all being Alain Carpentier at the top, the founder of modern mitral valve repair, whose principles of functional re-establishment of the mitral valve coaptation, physiological re-establishment of the coaptation, we still follow today. And I would say that my talk today is more suited and adapted to address the cardiological audience in terms of putting it in a context. What do we do during and for mitral valve repair in the operation theater? You may have heard or known that we can do in artificial cord implantations, smaller resections, rectangular, triangular, sliding plasties, butterfly plasties, cord transfers, shortening, and so forth. And part of most of our repairs is also implantation of a ring that comes also in different sizes and variable rigidity. We may use prefabricated multi-loops as well. Here you see the example of an asymmetric P2 prolapse. What do we usually use? We use single cords. We may put one cord on the anterior papillary muscle, another one on posterior papillary muscle. We may use single cords. We may use multiple cords, triangular or quadrangular resections, plasties, and so forth. I think it's important for the cardiologists as well in our respected audience to know what are the techniques we're using. We're going to talk about techniques and technologies. Now we have the Barlow's or form-fruste excessive tissue, hypermotile tissue, which makes it a bit more difficult for us to repair a mitral valve endoscopically or minimally invasively. But there are certain techniques, again, that apply. For example, cleft closures, partial resections, neocord implantations, sliding plasties, and so forth. Now, the Barlow's presents a more difficult target because oftentimes it comes with big clefts and very excessive redundant tissue, as well as commissural or annular disjointment. Now, I don't want to get too much into hyperspace theory, but minimal invasive mitral valve surgery is not the same. It's not equal minimal invasive mitral valve surgery. We all start, or most of us start under direct vision with without any assistance by cameras. Then we move on to endoscopic assisted minimal invasive mitral valve surgery, then totally endoscopic using 2D or 3D technology. There is robotic minimal invasive mitral valve regurgitation that did not actually establish itself widely around the world, ubiquitously for financial as well as practical reasons. It would be too long discussion if I went into that. And then, of course, we have the least minimal invasive of all minimal invasives. Anecdotally, I mentioned that once we have founded the Minimal Invasive Society of India, and I was propagating minimal invasive in the podium, and Gino Gerosa, who introduced the transapical neocords for the mitral valve, raises his hand and says, well, if you are minimal invasive, then I'm micro-invasive. Only then for a cardiologist to raise his hand and say, if you guys are minimally invasive, I'm nano-invasive. So in that sense, there are different worlds and different layers of minimal invasive. Benefits, as we all know, decreased risk of infection, less blood loss, less pain, less arrhythmia, less lactate, and better, higher albumin, as we have shown in our own series. The main benefit, however, is the better patient experience, faster mobilization, and as we know, mobility means life. And even after discharge, patient does overall better, decrease recovery time altogether, and return to full functionality in the daily life. I would like to raise an important point here. Why is minimal invasive important? Because it helps us customize and personalize the procedure. Until recently, or a few years ago, there was only black or white. There was median stenotomy and there is catheter. But now, having all these armamentarium in our hands, we can personalize the procedure together with the cardiologist, and we can offer the patient what fits that particular patient. So it's quite liberating. Now, the proportion, and I'll share a few of my experience or my outcomes as well. I think we should be going over to showing outcomes in series. The amount of cases that I do, and I think other minimal invasive surgeons can do as well, is quite high nowadays. So more than 95% of my mitral valves are done minimally invasively. Combined procedures more than 80%, MVR and atrial ablation more than 90%, and bypass surgery is not that high because there are a lot of drop-offs. Patients come, they get scanned, and then suddenly we see a porcelain aorta or many other difficulties that impede the femoral cannulation or positioning of cameras and tools in the chest. So not every coronary patient can be done like this. I would suggest the young surgeon who is transiting into minimal invasive to avoid certain situations and don't run into trouble, like flat-chested patients with verticalized hearts can be difficult. Very picnic habitus, severe obesity, and high standing diaphragm, extremely low ejection fraction, severely impaired right ventricular function, very severe pulmonary hypertension. Actually, the latest ISMIC's recommendation is for 75 millimeters of mercury, but an experienced surgeon scores even higher than that. Having said that, we must see the patient as a context. Severely calcified aorta or severe adhesions of the lung, former irradiation, and so forth. There are a lot of surgeons who still deny minimal invasive and endoscopic heart surgery, and as I go around different countries, I keep asking those surgeons, why? Are you too old, too scared, no time? Is it a competition? Is it too difficult? Mostly is number 5 though, inertia and comfort zone, because we're habitual animals, we tend to continue doing what we feel comfortable with. Now, for the cardiologist again, this is the setup in the operation theater for a minimal invasive procedure. This is the access. I'm not going to go too much into the technicalities because they couldn't interest you less. And this is the femoral cannulas we're using for femoral cannulation. The upper left corner shows you the queen of all clamps is the Chitwood clamp that we use to cross-clamp the aorta. These are the retractors we put into the left atrium to open the atrium and visualize the heart valve. Parenthesis, there is allegations by those surgeons who deny minimal invasive or have never tried minimal invasives that visibility is not good. And these things they tell the patients, well, this is wrong, and I'm sure that Antonis will agree with me, nothing gives you such physiological view and position as well as testing of the mitral valve as you go compared to the mini thoracotomy on the right side. Face on the mitral valve, and you can test it without stress. Different specific instruments, and then again, as you saw, as I've mentioned, a right lower corner here, you get directly into the mitral valve. This is the positioning of the patient. This is an animated setup of the procedure. Femoral cannulation. Now, when you start your experience, so you have more complex cases to do, you may choose to add a retractor for better viewing and more space, as you appreciate here. And this is how a patient ends up to be. I like putting in 2 chest tubes, one JP drain and one pleural drain. And then you move on in your experience and you start getting totally endoscopic, for example, like here, where the incision reduces inside, even though literally I don't believe it makes a life-changing difference for the patient. if the incision is 5 centimeters instead of 3 centimeters. If you follow certain rules, for example, no metal retraction, protection of the intercostal space, and so forth. Now, we have tools that facilitate this kind of procedure nowadays, 3D navigation, cord knots, and so forth. There are other devices, for example, the endo balloons that you can use to clamp the aorta from the groin, which allow you to make the incision even smaller. Here we see the typical outcome after a minimal invasive procedure on the mitral valve. 3 weeks later, about 3-4 centimeter incision. Young people, older people, ladies with small or big breasts on the left-hand side. I apologize, that's an aortic valve implant. And here you see some good cases for minimal invasive mitral valve, and here you see a bad case for minimal invasive mitral valve, which I would recommend against in the young surgeon who starts his experience, because the moment you take this Marfan patient on the heart-lung machine, you see how high is his spine on the lateral view. The heart flips over to the other side, and while the mitral valve is verticalized, so the surgeon may have problems visualizing. Possibilities. We push the envelope with growing experience. We operate concomitant pathologies, endocarditis cases, and so forth. Here, it was a quadruple case, MVR, ASD closure, atrial ablation, and TVR. Now, the ASD had a big and flexible margin, so I went in, repaired the mitral valve through the ASD, closed the atrial appendage, closed the ASD, and then proceeded to replace the tricuspid valve because it was rheumatic and required replacement. You can do atrial ablation with all the new devices. You can stitch bypasses for the right coronary artery. I don't recommend it to try it on the left coronary artery. And then, of course, there is another more, I wouldn't say new kid on the block, but in some cases it's possible. I just jump forward in the interest of time. The transareolar minimal invasive mitral valve surgery, as you will appreciate here, you go through the mamilla, through the nipple, a 50 to 60% incision around the nipple, and the rest of the operation is done with the endoscopic camera. I'll jump forward to see what it means for the patient after a few weeks, namely you can hardly see a scar. And that is cosmetically and functionally very important for the patient. Now, in the minimal invasive setup, we must make sure we don't run into trouble, and if we do so, how to get out of trouble. In other words, you must know where to stop. If you have an endocarditis case, such as our friend Mario Castillo-Sang here, which is not superimposed by endocarditis vegetations, the endocarditis is healed based on a Barlow disease, a preceding Barlow disease, then okay, go ahead, take care of the underlying disease, and you're good. Even though Barlow's, as I said, and remember these images, hold those images in your mind, because you see, Barlow's can deceive you. You put 10 Gore-Tex sutures, 5, whatever, 15, and you think you've repaired it, and then you do the post-op TE, and you'll be disappointed because Barlow's can deceive you. So there is a lot of guesswork going on in the way we do our repairs, and that could be eliminated with some new techniques I will show you later. I wasn't so lucky in my case. This is an 81-year-old patient, which I did endoscopically. And then you see the valve is partially calcified. It has florid vegetations, perforations, and the annulus is affected as well. In this case, I constructed a neo-annulus. I didn't repair the valve. Put in a pericardial patch, which gives you indeed a very strong neo-annulus on the posterior side, and you can affix a biological valve after that. Meaning to say, I don't like too extensive leaflet augmentations and extensions, building the whole valve anew, as some other surgeons may propagate. I would like to stop where I feel I should stop the repair and replace the valve. There is another similar situation. Here you see a 51-year-old gentleman who was defaulting treatment. He came macerated with 38 kilograms of weight. In this situation, decompensated heart failure in the middle of the night, and he wanted me to do a minimal invasive. Okay, fair enough. Very flat-chested, difficult access. You see the full length of my instrument disappears in the chest. And look at this Barlow's valve, which is superimposed with florid vegetations, huge clefts, ruptured cords. Would you repair this valve? I would. So I chose to replace this valve, and I show you the specimen once explanted. Look at these huge islands of bacterial colonies here. To me, that's the limit. You shouldn't try and repair this valve. Replace it and get out of the operation theater with the best possible impunity. Troubleshooting in minimal invasive mitral valve is usually about bleeding, conversion, and I always recommend the younger ones, bail out, convert on time, don't get into the catastrophe, don't try to fix problems that are very difficult to fix. For example, a massive bleeding from the left atrial appendage, or a free wall perforation of the left ventricle. Redo MVR, large right atrium, SVC, IVC, or very pressurized, no-go femoral, circumflex artery occlusion. These can be problems we have to troubleshoot in the operation theater. Now, in the interest of time, I'm not going to go through many of those problems, but there are different types of bleedings in minimal invasive heart surgery, each one with its own solutions. Minimal invasive is a lot, therefore, about tips, tricks to facilitate safe surgery. Good planning and patient selection is the key to success. New technology facilitates new solutions, ladies and gentlemen, but also may raise the bar for training. Combined cases of all sorts are possible, and I don't favor extensive patching. Good to know when to do something, but even better to know when not to do something and to stop. Some outcomes you see that against some allegations of people who don't like minimal invasive, these are my own outcomes in the last year or so, the last few years. The pink upper side is minimal invasive, the below open. The blue boxes are the anticipated Euroscore where we should be. You see the outcomes are far below the blue boxes, but in the minimal invasive there is a trend for better outcomes. Of course, here there may be a selection bias for the patients. Less hospital stay, equivalent non-inferior readmission 30 days from discharge, or rehospitalization. Therefore, minimal invasive is equally safe and efficient in selected patients. The innovation that is coming in, 3D, Cornot and RAM devices, automated devices that made our job easier. About 10 years ago, I introduced a uniport cardiac surgery that doesn't involve any femoral cannulation with a self-invented atrial retractor, so patient has hardly a scar in this context. Combined surgeries, and I'll spend just 2 minutes showing you the latest, which is my proposed minimal mitral valve repair techniques published in the European Journal and inspired from Greek technology and architecture, back-to-back papers in the European Journal. Techniques that I believe are more standardized, more reproducible, and can turn a junior surgeon into a solid mitral valve surgeon as well. For example, the Roman arch technique here, it works like this. I'm not going to show the video in the interest of time, just the animation. No guessing how many cords to put, where to put them. You just go into the anterior papillary muscle, travel along the prolapse, and go down the posterior papillary muscle. The same with the second part of the cord, and you land on the posterior papillary muscle, tie there, and you are done. You insert your ring, you test. It's a very dynamic repair method, and it distributes the tension across a long area, less risk for ruptures and calcification of the cords. I'll show you the Minotaurus, which really unties and cuffs your hands. It's a big help, I believe, in Barlow's or Barloid diseases. For example, this, you go into the commissure, anterior commissure, down the papillary muscle, across all prolapsing leaflets. You pre-close the clefts with that as well, and you exit in the posterior commissure. You may do one for the anterior, one for the posterior, or only one. You can close the cleft or add this individual cord as well. So please try it out, the surgeons among the audience, and tell me what you think. New tools, we invented a new retractor that doesn't require an external camera, gives you a very good view, as you will appreciate here. Here is a Roman arch technique I used recently in one of my patients. I won't stick to that. I explained the concept. I'll just show you the result. You can adjust, and when you are happy and ready, you do the final testing, and the result is really a very good one, and it took me only 5 minutes to apply the Roman arch technique for this patient. The same for the Minotaurus with the prolapsing tissue everywhere. Minotaurus technique, it looks like the horn of the Minotaurus. And the final result, it's not so much of an interest for the general cardiological audience how it's done. A small width, so very good outcome with one single running stitch. So training is very important. Obviously, we used to train like this with big books. Now with YouTube, all these tools are available for minimal invasive heart surgery. New devices, simulators. We have an excellent simulation center here in Singapore. And I won't miss the opportunity to introduce my book, the first book dedicated with QR codes, where you can scan and see how the procedure is done. I would also like to praise the book by Joseph Zacharias, our common friend, on endoscopic cardiac surgery. With that, I came to the end of my presentation, and I'm closing the historical loop with Claude Lorent's Embarkation of Ulysses at the land of the Phaeacians, not yet arrived in Ithaca. Thank you very, very much for your attention.
Thank you very much, Theodore. You showed us what progress is going to be, and in these few minutes we had the opportunity to see part of your achievements. We're looking forward to see them here in our hospital. Stay with us for a few questions, please. Dr. Pipilis, comments and questions.
Okay, thank you very much. A comment first, thank you very much for the presentation of Dr. Albin Musa. I enjoyed that you mentioned and you used the words favorable and unfavorable rather than suitable and unsuitable, because for most people, if something is clippable, then it doesn't make necessarily the patient being a candidate. For TER, is all the information you need from echo, just from ultrasound, or because I understand that for transcatheter, TMVR, and for MAC, we need a lot of information from the CT. Do we need a CT, or TER can go ahead only with information from echocardiography?
Microphone.
So for the mitral valve tier, I would say 2D and 3D should be enough data. I never used CT for such a procedure. I don't know if any on the panel has a different experience.
Ο κύριος Δανιάς.
I think this morning we really have experienced a great group of speakers and amazing lectures that have encompassed the whole spectrum of mitral valve surgery and procedures of the mitral valve. Certainly very complicated and difficult to deal with structure. I think what needs to be underlined, is that we need very good imaging, understanding of physiology and pathology, anatomy as well, and therefore we need very good imaging of the mitral valve. Certainly echocardiography is the most important tool that we have, transesophageal, intracardiac, and 3D echocardiography. CT also for the understanding of exactly where the mitral calcifications are. And I would also dare to add MRI as a means of understanding the physiology, measuring the exact ejection fraction, understanding and measuring the regurgitant volumes and fractions. And so integrating all these imaging modalities would give the interventional cardiologists and the cardiac surgeons the tools to understand and best plan their procedure. Really, thank you to all the speakers in the audience.
Thank you, Dr. Danias. Dr. Niños, any comments or questions?
Short question to Dr. Sparias Kostas. Which is the good candidate to put a valve in MAC?
I would say non-Ilias, but if everything else is exhausted, then you should have a very good pre-analysis, CT scan, screening, satisfy yourself that the sizing is okay for the valve you're going to use. Satisfy yourself that the calcium is distributed in a symmetric way. Try to predict that your valve, when it expands, it will go where you want to go. And finally, make sure you're not going to have LVOT obstruction. So I think if you do all this, if you apply all this, very, very few candidates will be good for valve in MAC as we're doing today. But I think that the valves that are coming, like the M3 valve, I think it'll be easy to implant because it will also pull the leaflets with that dock that I showed you earlier inside, inwards. So I think the LVOT obstruction problem will be very rare. And a testament that this is true is that this study completed recruitment very, very easily. So the inclusion rate was like 75% when the inclusion rate in all the other devices is like 20% or 15%. And then you have to say, if I'm going to use a valve that is only good for 20%, what's the point?
Ευχαριστούμε, Κώστα. Thank you, Kostas. And we couldn't have a better session with our eyes towards the future, the vision, the progress. And let's finish with the two friends, heart surgeons that I have with one question to both. Having a patient 75 years old with history of rheumatic disease and the regurgitant mitral valve, and the echo shows the restriction of the posterior leaflet, what would be your criteria for replacing or repairing the valve? Rheumatic disease, restricted motion of the posterior leaflet. We start with Adonis.
Well, 75-year-old, if the patient has got commissural fusion, that it is, I would go for this as well. Restricted posterior leaflet motion, I wouldn't trust it as a sign of rheumatic disease. But if there is fused commissures, then it is indisputable rheumatic disease, then I would go for a bioprosthesis. If the commissures are not fused, then I would very much question the diagnosis, and I may consider a repair. If the coaptation depth is above 10, I would still go for a mitral valve replacement with a bioprosthesis. With a lesser coaptation depth, I would attempt a repair, but most probably, the patient that you describe is for mitral valve replacement endoscopically with a bioprosthesis.
Thank you, Tony. Dear Theodore, your opinion, your approach.
Yeah, I totally agree with Adonis, and the devil is in the detail. I mean, how high is the posterior leaflet? What portion of it is mobile and what is fixed? Which scallop exactly, fused or not fused commissure, so it all depends on that. But 75 years old, let's say if it's tethered and immobile entirely, I'm not a friend of augmentations, even though it occurred to me before, and I extended the leaflet a bit and it worked, but it's not the everyday case. So I would retain the posterior apparatus to the extent I can and throw in the biological prosthesis in this case.
Thank you very much. With thanks to all of you, especially to Theodore, who is the far distant away. I hope the weather is good there. Theodore?
The weather is good, but I missed it. I was in a redo case today all day, so...
Okay, looking forward to see you here. Adoni, Vlasi, and Kostas, thank you very much for this very, very nice session that we had, and even on time, given the fact that we started 10 minutes late. Thank you very much, all of you. Thank you.
Thank you, Mr. Chairman. Thank you, Stratis, Elias, Petros, Thanos.
Good afternoon. Today we are now in a very interesting session of the both live in cases and case presentation. We will moderate this session with Dr. Zakarolis. And we have got 3 interesting cases, one from Higia Hospital, and Higia team is with us now. And Dr. Katsianos will present the cases. And Dr. Spargias and Dr. Ninios from European Inter-Balkan Medical Center also will join us. So please, Dr. Katsianos.
So thank you, Dr. Kilic. In respect of time schedule, I begin straightforward. A 79-year-old female patient, BMI 31.2. The transthoracic echo, severe aortic stenosis with a Vmax of 4.3 meter per second, gradient for 75 peak and 46 mean millimeters of mercury. LV ejection fraction 45 to 50%, RVSP 40 millimeters of mercury, and mild MR. Coronaries with borderline 60 to 70% proximal stenosis in a relatively small RCA. Medical history, diabetes, hypertension, mild CRF, history of NSVTs on medical therapy, hypothyroidism. We see the medication of the patient with diuretics, among others, Euroscore to 3.39%, STS mortality score 3.81%, and STS mortality morbidity 11.3%. The transthoracic parasternal long axis view, we see the heavily calcified aortic valve with no relevant regurgitation. The X-ray of the patient and now the ECG with the known LBBB and sinus rhythm. We see the heavily calcified valve, 25 millimeters at the area of 4 millimeters above the annulus, the diameter. We see the relative low height of the left main. We have an area of 5.19 square centimeters, the diameters of the annulus 23 to 27 maximum, with an LVOT a bit bigger with an area of 6.08 square centimeters. Here we see our measurements, the CT. We see the calcification, and we have a measurement of 24 millimeters from the left main to the calcification. Again, the height of the left main relative to the annulus, it is really low.
Kyriakos, sorry
Yes.
to interrupt you. Can you hear me?
Yes. Yes.
Just to clarify that the video that all the audience can see on the top of the screen is from this procedure. So it's edited and you can watch everything from the beginning to the end. So this is the ProGlide insertion. So just to clarify this. Okay, you can carry on.
Thank you, Dr. Sparias. We see the heavily calcified valve and the coronaries. The peripheral access seems not to be a problem in the CT TAVI. We see the right side, the angiography, and the left side. The aortography of the patient, we'll proceed. Here we have the balloon expansion, a 23 millimeter balloon of Edwards under rapid pacing.
So Kyriakos, let's make a stop here. This is the format of the TAVI rounds, and let's go back to make a short discussion about any concerns that you would have for this case. Let's go back to the CT scan screening, if you would. More back. Beginning of the CT screening. Okay, so here we see that the annulus is 81, 82 perimeter, and 519 millimeters is the area. The LVOT is a little larger, so the LVOT is opening, not closing. And if you go to the next slide, here you see that this is a bicuspid anatomy. You see a raphe between the left and the right sinus of Valsalva, and you see calcium, a big bulky calcium at the base of the non-coronary sinus leaflet. And this calcium would certainly affect and influence the expansion of the deployment of the valve. That's why we did these measurements here. So we measure from that calcium to the other side, and I think this comes to 24 or 27, depending at what height you are going to measure it. So if you measure it, the worst scenario is that if that calcium stands firm and pushes the valve completely on the other way, then we have 24 millimeters. Is that right?
So we can also discuss about it, maybe with the audience and the moderators. As you see, this is a bicuspid anatomy. And what are the other requirements for the measurements for bicuspid anatomy, both for selecting the balloon expandable valve or self-expandable valve?
Yeah, I think this is a very big discussion, Theo, that you can have. I just wanted to point out this fact on the CT scan screening, because this is the only thing that came out to my attention, that bicuspid anatomy, but the raphe is not calcified. It's a clean raphe. Most of the calcium is on the non-coronary leaflet. So this measurement comes it's a little borderline and bothering to have just 24 millimeters there. And then if you go to the valvuloplasty, balloon valvuloplasty with autography, and you also saw that the level of the left main was low. It was just 8 millimeters, so it is a low left main. And here, this is a 23 minus, I believe, balloon, so it's probably a 22 balloon. And you see how the leaflet behaves in relation to the left main. So I think it follows the expectation that it will move towards the left main, because most of the calcium is on the other side.
Yeah.
And if you say that this is a 22 millimeter balloon, then it goes very close, the white line of the leaflet in front of the left main, it goes very close. So if you go to put a 26 millimeter balloon expandable valve, because the sizing is for the 26, so probably there will be a problem there, because you will need another 4 millimeters, and I think that 4 millimeters would probably create a problem there in coronary obstruction. If you're going to use a self-expandable valve, depending on what device you're going to use, you know that the 24 will be very, very borderline, which is like the waist of the evolute will be 24. But if you don't put it exactly the waist in front of the left main and go a little bit higher, then probably the waist will be more than 24 and you'll have the same problem. So I just wanted to point out this peculiarity of this case, and then I will leave you to continue the discussion between you guys.
Yes, this is the most important afraid situation, that huge calcium on the non-coronary sinus and the low-lying coronary osteo. Even the Valsalva sinus is high. I mean, there is no shallow sinus of Valsalva, but you clearly demonstrated that with the balloon and with the angiography at the same time that the calcification pushed the balloon and there's risk of coronary obstruction in both valves, I mean, but for this, yes, please.
I think this is a nice illustration of balloon aortic valvuloplasty indication during TAVI. Many cases are done with direct TAVR, but especially bicuspid valves, we frequently do BAV for sizing as well as, in this case, to monitor what happens with the left main.
Did you make supraannular measurements in this case?
I can see if we have some.
Yes, we have that. We have that measurements back in the CT scan, but because there is no calcium in the raphe, although this is a bicuspid anatomy, I wouldn't expect it to behave like bicuspid because there's no calcium, as you can see in the raphe. All the calcium is on the non-coronary, so the raphe would give away, and this is what happens and what we see when we do the valvuloplasty. The raphe is not calcified, it gives away, and the valve moves all that way. And so here is the 4 millimeters above the annulus. You see the diameter commissure to commissure is 25 millimeters, and you can see the designated opening of the bicuspid valve.
Please.
So this is very unusual in native anatomy to have a problem of coronary obstruction, threatening coronary obstruction. It's extremely rare. And I think if that was, it's just the distribution of the calcium that makes this high risk because everything is on the other side of the left main. That's why it pushes the valve. It will push any kind of valve towards the left main. So it's not that the sinus of Valsalva are not wide enough. It's just the distribution of calcium, which shows how important it is to take into account in your screening, in your planning of every little detail. So like you said, if you think that this is a bicuspid anatomy, you say, okay, it will push me away because it's bicuspid. But no, it's not like any other bicuspid. It's a bicuspid without calcium in the raphe. So that's why it behaves this way.
May I add something?
Yeah, of course, Dr. Zacharelis.
It looks like a rather challenging case, although keeping in mind that this is a bicuspid anatomy, you have all the favorable assets of completing the procedure safely and successfully, mainly because the calcification pattern is not that bad and you have all the good signs for you there. But I would be rather worried about the left main. And I couldn't agree more with what Mike said, that it's very important to do the balloon valvuloplasty before you get a lot of information. From what I saw there, I would be more assured to go ahead, but keep in mind that I might need to do some coronary protection.
So for those who are watching the video, you will see that this is exactly where at this stage now, the valve is there, but we also have coronary protection. You can see the manifold there. So if Kyriakos, this is the initial coronary angiography. So there was no significant coronary artery disease. Here we have the wire for the protection. We're expecting potential problem here. This is the 26 Resilia valve that we haven't talked a lot about it, but I'm sure you will. And then we have the stent position exactly at where we believe we need to implant it in case we have an obstruction of the left main. So at the last moment we do this coronary wiring, and we advance the stent at the very last moment when the valve is there. So we don't want to have wires and stents for a long time in the coronaries, especially in the left main. So we advance the wire at the beginning, just the wire. We pull the guide catheter back, so it's not into the left main. And then when the valve crosses the annulus, then we advance the stent like we're doing here. to make our final positioning.
And there's no pigtail in the non-coronary sinus also? Here.
Correct,
Yeah.
correct. We found out that with the balloon expandable valves, in all cases we need to do coronary protection. It doesn't matter if we have another valve like surgical or TAVI valve for landmark. We can use the guide catheter like the JL4 here, because this guide catheter has large lumens. So just with manual injection, as you can see here, you can have a very nice aortogram to guide you for the valve implantation. So there is no need for third aortic access.
It's a great demonstration.
So here we see our stent, Onyx 3.5 18 millimeters in position, and the Edwards S3 Resilia 26 millimeter -2 valve. And we see under rapid pacing the valve implantation. We see the struts of the valve touching our stent. The patient was stable all the time. We see the great need for the stent implantation.
So what do you think about this imaging we have immediately after implantation of the valve?
Actually, I want to ask to the panel and the audience, will you put the stent proximally or distally for the protection of the coronary ostium? Dr. Reardon?
What I'm worried about is if you decide you don't need the stent, you have no telescope in there, and you can strip that stent off and pull it out. So if I do this, I'd have a telescope down there with my stent inside the telescope. And then if I decide I'm not going to stent it, I can pull it out. It doesn't look to me like you're going to need to stent this. You don't want to leave a stent in the left vein if you don't need a left vein. So a naked stent, to me, is a worrisome thing unless you're absolutely sure you're going to plant it. And planting a stent in the left vein you don't need is not a good thing. So I'm worried about, I always worry about stripping these stents off unless it's protected by a telescope or guideline or something. But I'm not a cardiologist.
Maybe distal.
I feel distal placement is, especially in this case, would be a little bit safer. Now, with regards to what Dr. Spargias asked, I would like to see another image with the parallax off. But for sure, there is you can see there is a chunk of calcium right underneath the ostium of the left main. So I don't know if there is another image, so we could assess a little bit better what we can have, what we have.
Sorry.
There must be another one. Next one.
There are two images.
Yeah. So let's see the parallax. The next one.
This is the next one.
Okay. So these are two 90 degrees difference imaging, and you can see the white line of the leaflet going up to the STJ. And I think the only thing that keeps the flow is the stent, and the power, the straightening power of the stent in the wire that pushes the leaflet, the native leaflet, down. And this allows for this flow we can see here. I think that your discussion was where to park the stent before the implantation, if you need to be distally into the LAD. Was that the discussion, the earlier discussion?
Yes, the discussion was before the protection. We put, should we put the stent parked distal or proximal?
Oh, yes, that was a discussion that I had many times, but there are cases that when you pack the stent into the LAD, if you have a big stenosis, especially if you have other hardware there, like a bioprosthetic valve, and you put another valve, the stent may be caught, and it may get off the balloon. There are cases that this has been reported. And so that's why I think the best approach is to have your stent at exactly the area you want to implant it. Of course, there is the risk when you implant the valve, the balloon may touch the stent and move it slightly out of the exact position you should have it. But I also accept this movement, this interaction between the valve and the stent as an indication that stenting is needed, because if it reaches to the stent and makes this bend to the stent like we've seen in the implantation here, I think this is the sign that the valve reaches the STJ and it will create a problem in the coronary flow afterwards.
Please. There's a question from the audience.
Kostas, congratulations for the case. Just I'm wondering if it was better to have a guide liner, a protection of the stent with a guide liner to avoid the interaction between the valve and the stent. So you have the ability to move forward or backward to assess the better position of the stent.
You're absolutely right. We've just tried to keep the procedures as simple as possible, Manoli, by avoiding to have a lot of hardware inside. So we have used guide liners a few times, but here, because the anatomy was large, there was still a hope that we wouldn't have this problem and we would avoid the final stenting. It's true, if you have a guide liner, you can have your stent completely into the catheters, but I think it adds some complexity, and we try to avoid that.
And how was the hemodynamic status of the patient when you put the valve?
It was good. We had no signs. It was light sedation. We had no sign that something was going wrong. Blood pressure was stable, ECG was stable. But the impression was that here we will have a real problem if we remove the stent. And then we might have the difficulty to advance it again. This is something that has been reported many times. And we weren't so lucky like the case Dr. Ziaka showed yesterday, that they removed the stent and then they re-advanced it when they did the reassessment, and it was easy to re-advance. In some other cases, when it's very tight, the space is very tight, you cannot re-advance. So you have to make a decision now. If you remove it, then you may have difficulty to re-advance it again because it will be metal to metal. And I think the decision here was very clear to us that we should deploy the stent.
Yeah.
And you can see with this autography with the guide catheter that, of course, the position of the valve is very nice. It's like 80, 20%. We have no regurgitation.
Also, seeing the impaired, seeing the impaired flow, maybe retrospectively in this occasion, the guide liner maybe would affect also the flow for some instances in the left main.
Correct. It would occupy more space. You're right, Kyriakos.
So we're going forward. Here we see the stent implantation, Onyx 3.5, 18 millimeters. And this is post-implantation.
And here you see how the white line of the leaflet is pushed downwards. So it doesn't reach to the STJ. I think it's pretty clear here.
Over different angles.
And in this angle, calcification go a little bit forward. Very interesting. Yeah.
Here.
This is the flare. You see that the stent is compressed. You see that there?
Yes, I mean that stent is compressed.
And we did multiple post-inflations to flare the entrance of the stent. And can we move on?
And here we see our final orthography, a good outcome.
So congratulations, and this is a very educational case, and the valve position is very good, but it's very, very important to put the protective guide wire and stent in this very important case. Dr. Corrales, yes.
Congratulations, Kostas, and to all of your team. I think it was a wonderful performance. One quick question. There is some reports in the literature that say that, when you're finishing with stent in the left main and going sideways with your valve frame, you should finish with a kissing balloon in the valve and the stent. Are you an advocate for that, or you think that's not that important?
I think it's an unequal cross of forces, because on one hand you had a stainless steel frame with a thickness of 1 millimeter, and on the other side you have a coronary stent with a thickness of, just a fraction of the millimeter. So I don't think this fight is equal, and if you do a kissing, I don't think it will affect anything. I think you should make sure that you expand very well your stent. If need be, take a non-compliant balloon, larger size balloon, to make sure that it's well expanded. And I'm not saying that this is a perfect solution, this way of coronary protection. It gets you away with a good result of the acute procedure, but in the long term, it's not certain that this approach will be without problems. So imagine that you have to go back. This patient had good coronary arteries, but imagine that there is coronary artery disease, or this patient comes back with a problem in the anterior coronary system. I think it would be very, very difficult to cross this stent correctly through its true lumen and approach the coronaries. So it will be very challenging if there is any need in the future to access these coronaries. That's why when we do this coronary protection, we shouldn't deploy the stent if we're not reasonably sure that we need to do it. It's necessary to do it, because if we do it lightheartedly in all cases, we may have problems in the future.
Okay. Well done. Congratulations. So second case. From Higia team.
So thank you very much. So we're going to show our initial experience with the Evoke valve. And as Dr. Sparias reminded us all, this is a TAVI round session, so anyone is allowed to pitch in while we talk and while we present the cases. So I guess we're just going to show the first case now. It's an 89-year-old male, BMI of 25. He has been complaining of shortness of breath and fatigue for the past few months, and he's been in uptitrating his medication. These are the BNP levels. A TT and a T of shows an EF of 65% torrential TR. Previous medical history, he had a mitral edge-to-edge repair almost 5 years ago, and he had a TAVI last year for aortic valve stenosis, and other pertinent history would be atrial fibrillation. So this is a patient with a Euroscore of 4 and a tri-score of 14%. So let's go to the images, and imaging people as well. We can have their comments. This parasternal long axis, where we can see the ejection fraction, we can see the mitral device. And this is the short axis where we can appreciate torrential TR. More or less good tricuspid valve function. Yes, Dr.
If you go back
James?
a couple of
Yeah.
slides, we can see also
Sorry
there's a
about that.
transcatheter aortic valve replacement and also a Pascal P10 in the mitral. These two procedures have preceded by probably a couple of years ago. We did the mitral first, and then he had a paradoxical low flow, low gradient aortic stenosis. We fixed that as well. He did well for about 6 months, and then he started having symptoms again. He had this torrential tricuspid regurgitation. Quality of life was, in this very active 89-year-old, he was limited by early fatigue and some dyspnea. So we proceeded with further evaluation for possible intervention. Reasonably good right ventricular systolic function, a dilated though right ventricle. And here we see biplane imaging of the tricuspid, torrential TR. These are images from a transesophageal echo. We see well-functioning aortic valve, well-seated Pascal device in the mitral with mild regurgitation. This is transgastric views of the tricuspid. We see a tri-leaflet tricuspid valve with generous regurgitation from the center and center anterior area. However, it's a white jet overall. We considered it for maybe a Pascal device tier, but we considered that it would be multiple devices and a suboptimal result in this patient. This is inflow, outflow images from for the tricuspid. Again, severe. The ERO was estimated at least 71 millimeters square. And moving on to the CT scan.
So when we're considering these patients, obviously we don't always come across just thinking about EVOQUE, but we have the opportunity to send images to the company, and so we get a very comprehensive and apprehensive PowerPoint. And so, as Dr. Christoheri said, so we didn't have many choices for this patient, so EVOQUE, we're very happy to be able to offer this patient if he was accepted by the company. So these are measurements that we do at the tricuspid valve annulus, and you see the PDT where we measure both diastole or systole, or maybe end systole, but we also see where the annulus is the largest in size. And we always need to keep in mind that we need to have some percentage of oversizing. This will come across later in the future, so the valve won't be dislodged, and we should anticipate an oversizing of 5 to 10%. And these are very beautiful images. So besides the tricuspid valve annulus, we measured the right atrium, the right ventricle. The distance from the IVC to the right atrium is very important, so it will assist for the delivery to come across. You get to see the images on the top right corner of the device. And you can also see the valve and the delivery outside of the training pavilion as well. And this is a CT angular measurement guidance. Currently there are 3 sizes available for the EVOQUE valve. On the left side, annulus is too small. On the way to the right side, annulus is too large. So basically, there's no possibility for EVOQUE cases right there. And they also present to the PowerPoint how you're going to have your II. So you can anticipate, depending on your angle, how the delivery sheath will be within the heart. And these are moving images where we anticipate in 3D and 4D the right atrium, the right ventricle, any possible, as you can see the TAVI before, and you can see the clips. So everything comes into play, and you can have a very good idea as what to anticipate the day of the procedure. So let me just stop for now. We can have a very brief discussion with the panel and the audience. How would anyone go ahead, or what other choices someone else would do? Anyone? No?
Yes, Dr. Zakouroulis.
Yes, thank you. I couldn't agree more. I wouldn't say that this is a good candidate for a TEER. I think you will end up with more than 2 clips, maybe. So, and then again, I think that we would have a suboptimal result. I don't know how about the trick valve system. I don't know what's going on with the hepatic veins and what's the interaction with the inferior vena cava there, and if there is space to implant the IVC valve. I would think of implanting a new valve there. That would be a good option. Of course, I know that's an evocation.
Compared to the trick valve, I mean putting two valves to the caval system, putting a valve into the normal area works much more physiologic. The results are coming, but especially in this case, septal leaflet is not also so much suitable. And my question, for example, before tricuspid valve implantations, do you measure pulmonary artery pressure?
We always do, and with the TT, and we do invasive measurements, and at the time of screening and at the time of procedure. And it's a very good question because, especially for all these new valves that we don't have enough data, and for instance, for the evoke valve, we need to be very specific about the weight of the patient and how strict we are. Because if something changes from the screening to the day of the procedure, we might need to change the size, or it might not be feasible. So this is a very good question, and in invasive hemodynamics, and we will hear about the invasive hemodynamics in the next session, it's one of the most important aspects, especially when you're treating the tricuspid valve.
May I stress something here? And I think that what Professor Kilt said is very, very significant and very important. It's what is the contract reserve of the right ventricle? Because you end up sealing a torrential TR, and you have a right ventricle that's not functioning at all. So, or you have all this pulmonary pressure being transferred back to the RV, and then you have you're stuck. You don't know what you don't have any other options. So I think it's very important that you have a mean to kind of evaluate what's the contractile reserve of the right ventricle, and it will help you to see how the patient will go, progress after the valve implantation. Having said that, I think that it's very important also to stress here that we should not neglect the right side. We had a very good result with your TAVI and your Pascal clip in the mitral valve, and then the patient came back again. This means that the right heart is something that we shouldn't be ignoring, as we have been all these last years, because this is something that can hamper your good results from the all your efforts that you did in treating the AS and the MR previously.
So these are great points, and this is exactly what you said. So you're abolishing the TR. So this is new ground for us. We don't know the long term what would that mean, that you're abolishing the TR with the clip. You're minimizing. So yes, but now we're abolishing. So indeed, you're right. We don't know yet. This is something that we're waiting after these transcatheter procedures in the long term to show us, are we doing good or are we doing harm?
It's not a concept but I think, for example, myself, when we put TAVI for low output, low gradient aortic stenosis, we evaluate contractile reserve of left ventricle with dobutamine stress echocardiography, for example. I think for the tricuspid valve implantations and tricuspid interventions, a specific parameter is required to assess right ventricular contractile reserve maybe, and the hemodynamic parameters. There are some echocardiographic parameters like tricuspid annular TAPSE and the others, but there are some exact measurements are required, for my opinion.
Yeah, definitely we have to do a thorough evaluation of the right ventricle, do our full complement of right ventricular indices by echo, including STDI, strain of the free wall and the total strain of the right ventricle. TAPSE is a very basic tool, so we don't rely on it so much. And also three-dimensional ejection fraction of the right ventricle is something we always try to understand. In addition, we always do invasive hemodynamics to assess the severity of any pulmonary hypertension and pulmonary vascular resistances to understand what this ventricle is up against once the regurgitant flow gets treated. And it's all afterload, it gets a significant afterload. So we have a full understanding of the right side before we begin these procedures.
I'm no imaging person here, but I would like to pitch in here an idea. I don't know, there must be data on that. I don't know what's the place of MRI or stress MRI in these people. And you could have a better assessment of the right ventricle using an MRI, and maybe that's that's one of the many ways that you could pre-assess what's your contractile wave on that right ventricle.
We use also a clinical marker for us is whether we can balance a patient or compensate a patient with diuretics and bring him to a steady state point. If you have a patient who is coming with ascites all the time, it's very difficult with massive doses of diuretics, then most likely we lost our opportunity. But in this particular patient, it is a patient who was fairly active, did not require heavy doses of diuretics, and he had some indices of good right ventricular function. So we have to take that into account as well.
In addition, these patients are usually very sick.
Correct.
Okay, let's proceed now. We're going to need to take all the time of the break as it goes. Blas is waiting for his own presentation. So let's go ahead with the rest of the case.
So I think we... Okay, so very briefly, this is how the Evoke valve is. Unique design, 2 stents, 9 anchors that go under the hinge points of the tricuspid annulus, 28 French sheath outer diameter, and right now we have 3 sizes of the valve, and you get to see this is the delivery sheath. You have the white knob, the blue knob, which is about the ventricular and the atrial release of the valve. And so, and Dr. Spargas can tell us more about the procedure. So you can see we have the extra stiff wire in the right ventricle. And
so here we rely heavily on 3-dimensional echocardiography, and in particular multiplanar reconstructions to create what we call the home view. So we do a 3D of the tricuspid valve, and then we analyze that to get on the left upper image is our commissural view, where we orient ourselves posterior and anterior. On the right upper is the septal and lateral orientation, and on the left lower quadrant is the short axis of the tricuspid valve in a view that is somewhat similar also to the transgastric view with the aortic valve at 5 o'clock. So this view is a view that we rely heavily during this implantation. There's multiple steps for the release of this valve. You see here that we're at 90 degrees of anchor exposure, in which case we, on echo, we want to ensure that all the anchors are sitting below the leaflets and that the leaflets are as above. So we have to rotate and see everything. Here we have atrial expansion of the valve. Again, we rotate through all the anchors as possible to make sure that all the anchors are nicely securing the leaflets, and that they're coming up to the hinge point of the leaflets. Subsequently, the atrial expansion will take place. Again, it's a very staged process, a very deliberate process, and here we have to take away the cone from the valve. Essentially, we're fully expanded now, and the valve is released.
And that's how the future looks like.
System looks user-friendly, I think.
Yeah, so initially when you have, just try to be very quick, when you have your extra stiff wire, you just make sure that the wire, and based on the echo, It's not somewhere lodged under the papillary muscles, because this will make major difference in the procedure. So it's very running freely, and then you just have you just push in the delivery sheath. But as Dr. Kusahir said, it's based on a TE, so you got to be very patient. We showed it very quickly, but it takes very long time, step by step, to make sure that all the anchors are exactly where they have to be under the leaflets. And of course,
yeah, this is now 3D from the right atrium, visualizing the prosthesis. And this is by color. We don't see any PVL. Nice laminar flow in biplane imaging. Full restoration of the tricuspid valve function, and with no significant gradient.
Congratulations for the excellent case.
If I may just make my comment, as an interventionalist, this procedure is the simplest procedure probably you've ever met in your practice, because the only thing you have to do is to advance the capsule of the valve to the correct position, and then everything is done very slowly. You just release gradually and in steps, and you rely heavily on the echo imaging to make sure that the positioning of the valve is very correct to almost to 1 millimeter or 2 millimeter. So this is what takes time. As for interventional skills, I would say minimum is required. But as in every procedure, the beginning is the most important part. So in this procedure, the beginning, I mean the correct coaxial positioning of the capsule into the tricuspid annulus plane, it's defining the success of the procedure. Everything is very slow and very simple after that. So that's why the initial positioning of the wire, like Konstantinos said, is very important to make sure that it goes to the RV apex. And then everything, it'll be very easy. As soon as the patient is accepted, the anatomy is screened and is acceptable. And just one last comment, there is a new size, a larger size, the 56 millimeter valve that will be available next year. And I think with that, all the range, essentially, basically, of the tricuspid anatomy will be good for this valve.
Thank you, Kostas. Excellent result. Now, I want to return to Vlasis. And Vlasis is one of the most important structural heart interventionalists from Inter-Balkan Medical Center, and he's not only important for the Greece, also very important for the region. Please, Vlasis. Hi, Vlasis.
Hi, Theo. I hope you can hear me and you can see me and you can see my slides.
Yes, we can see you.
So very good to see you again after your very successful interventional meeting in Antalya. We were very grateful for your hospitality, so it's good to meet you even from a distance. I want to say good morning to Achilleas too, your co-chairman. I'll just show a live-in-a-box case of a TAVI. There's nothing spectacular about this case. It's just a day-to-day case that we do routinely in our lab and in everybody's lab. I just want to highlight some of the lifetime management considerations and all the routine adjustments we have made, us and other centers as well, to make the procedure safe and effective. So it's a 77-year-old female patient, diabetic on insulin with moderate renal impairment. There's a history of coronary disease, so this patient had a previous inferior myocardial infarction with a PCA of the right coronary artery, and the ejection fraction was somewhat reduced with a 40% with moderate pulmonary hypertension, and she was significantly symptomatic and YHA class 3. There was significant aortic stenosis. You can see the numbers here, and the Euro score of this patient was calculated at 4.13%. So these are some of the features of the CT scan. You can see a tri-leaflet aortic valve with moderate degree of calcification, the speckles of calcium in the ascending and descending aorta, The anatomy is small, so the perimeter-derived annulus is 21.6, 21.2 the area, and the LVO2 is 20 millimeters, but the height of the coronary ostia is both okay, 15 and 13. This is the aortic tree. You can see there is a lot of calcification, especially on the abdominal aorta and the left iliac artery. The right looks a little bit better. Still calcified though, as you'd expect for a diabetic elderly woman, but the diameters look fine. And this is the anatomy of the cranial artery. So there's somewhat bovine, but borderline bovine. The right carotid is coming off at an angle from the innominous artery on the right. So clearly it's a relatively young patient, below 80. There is a known coronary disease, so likely to require further angiography, so small anatomy. So we have to consider all this. So our plan was to implant an accurate Neo2 size small valve. Because it's a supraannular valve, so it has favorable hemodynamics. There is the potential of easy commissural alignment, which helps a lot, both with the hemodynamics of the valve, but also with the access of the coronaries. And we plan to use cerebral protection device with this. The procedural planning would be the primary access from the right femoral artery. It is our routine to do a cut down on that, and we've been doing so for the last 3.5 years with great success, so we don't steer away from that. There is a right radial access using a sentinel protection, a left radial access using the pigtail, and the left femoral vein with a short wire to use the pacing from the LV wire. So we don't use any temporary wire for that. I don't know if there are any comments on the case or on the planning, anything you want to add, Theo or Achilleas or any from the audience before I show the case. It's a short case, so it's not going to take too long of your time.
It's a little bit small annulus, and in the small annulus anatomies, usage of the both other supraannular valve and a balloon expandable valve, we will use a small valve. It looks like 21 or maybe if you've got an intermediate size. But in this case, the selection of the valve, I think good because of the, but maybe we can ask about properties of the accurate neo, for example. I think you routinely use larger balloons. In that kind of anatomy, for example, will you use a larger balloon or what will be your selection?
The plan would be to pre-dilate with a 20 millimeter balloon. It's a 20 millimeter LVOT, 21 millimeter perimetry diameter of the annulus, so just predilation with a 20, and then use a size small, 23 millimeter accurate Neo2. Now, being a supraannular valve, it gives you favorable hemodynamics, and it doesn't have the closed frame that you have in other supraannular technologies, so coronary access is feasible quite easily with this technology from above. And also you have I will demonstrate on the case how easy it is to perform commissural alignment. So we do that.
I will ask to you, yes.
Exactly. So commissural alignment is very, very easy with this valve, and I will show it in a case. It takes just 30 seconds to 1 minute to do so.
So I guess in what was asked earlier, I think the most important thing here is to keep in mind that this is a relatively young patient, and you're going to have to intervene in the coronaries at some point further down the road. Therefore, I wouldn't agree more with the picking that valve, that specific valve. It has a very good profile and very good numbers to support a good coronary access after implantation. However, having said that, and just to be, for the argument, sake of the argument, I would say that maybe a small balloon expandable valve will also do the trick, although I wouldn't go there as my first choice.
And prosthesis patient mismatch also is a very important small annulus to predict long-term mortality, and so in this case, I think it's a very good selection.
In the discussion
about we were somewhat swayed away from using balloon expandable valves in the recent results of the SMART trial in the small anatomies, you see. So I think a supraannular prosthesis in this particular size would be my first choice. Of course, if you go to medium or large sizes, it's a different story. Then balloon expandable would definitely be a very good choice as well.
For the sake of the discussion about lifetime management, Vlasis, would you consider also the possibility of valve-in-valve possibility in the future for this particular valve? Now, obviously, the goal is now to get a new valve in there to work for this, to relieve the critical stenosis. But number one, would you consider the possibility of this valve that you're going to implant for valve-in-valve in the future? And
yeah, absolutely. There's good data that shows that a balloon expandable valve can fit easily in the frame of the Accurate Neo 2. That leaves you again, the coronaries unaffected. And because it's a second valve, it gives you a relatively bigger area compared to two balloon expandable valves. Plus, you don't have the worry of the tall skirt of, say, a closed cell supraannular valve that could potentially create any sinus sequestration, any blockages at the level of the sinusotubular junction, etc. So the valve-in-valve option is there for this technology as well.
Would you also consider an intraannular self-expanding valve?
Yeah, absolutely. That would also work. That is a very, very good point, because you have an annular leaflet, short skirt, and then potentially you can have the favorable hemodynamics as well as the future access to the coronaries. That's a very good point, Michalis, I agree. So if you, in the interest of time, I can move on to the case. So hemodynamics are top left, our table is on the top right, and the fluoro you can see. This is Konstantinos Papazoglou pushing very elegantly the long sheath in. It takes for him about 5 seconds, but we trust him. We never had any issues with that. So the next step is left radial for the pigtail. You can see pigtail is moving in to get access. First, we'll do an injection to visualize the cranial arteries, just to show the anatomy in order to implant the Sentinel device. And as I said, we do that as a routine. I mean, you can argue whether, this is absolutely necessary or not. You can argue about the data. I totally agree, but we have had some very impressive fishing elements out. You can see now the anatomy. It's sort of bovine. It's not 100% bovine, but there is a bovine element. So our practice here will be to push through the right radial artery along 300 centimeter wire, coronary wire, that will end up in the ascending aorta. And then over this wire, we will push the Sentinel device. You can see now the Sentinel is going in on the left. So the procedure is first to deploy the proximal basket, which is quite easily done. We have our anatomic landmarks, and then by flexing the distal basket, you can see there, we can rotate, and with some persuasion, the coronary wire will end up into the carotid on the left. I think in this particular case, we changed wire because the tip was a little bit damaged, so we just inserted a new wire. But that made it quite easy to go up to the carotid. Sometimes it takes a little bit of manipulation to do so, but usually it's not that difficult. See, the wire is going up, we're pulling the system, and then we're just pushing the distal basket. So once this is secured in place, then the next step will be to take our aortic root view by advancing the pigtail to the aortic root. And then once we're in position, we try to take a view that shows both cusps aligned. We only use the 3-cusp view, but we need to make sure that all the 3 cusps are aligned properly. We don't need to swing from the 3-cusp to the cusp overlap view for implantation purposes. We do that only to ensure commissural alignment. So that saves contrast and fluoroscopy with this particular technology. It makes it quite simple. Then the next step will be to cross the valve. And you can see here, we do that with a straight wire. Some people use a pigtail on that, but usually a straight wire if we have taken the fluoroscopy. It doesn't take that long. You can see now the wire crossing in without any problems. AL1 goes in. Then we change with a long exchange wire coronary. For most centers with high volume experience, these are automatic maneuvers. And then after getting the exchange wire inside the left ventricle, then we put a pigtail, which you will see in a minute. It's very important to avoid papillary muscles because papillary muscles will deflect the wire and will make the LV very irritable. For this particular valve, it's very important that we have a nice, comfortable position of the Safari wire inside the left ventricle. And we need to make sure that the wire loop will be facing upwards. So you will see that. We'll take the gradient first. So here you can see there's a gradient about 30 millimeters of mercury. And then we're just threading the wire inside the pigtail. So this is the position of the wire. So you can see it's very important that the loop is facing upwards and the wire follows the outer curve of the ascending aorta. This is the position that you need to have when you implant Accurate Neo2. So now the next step will be to pre-dilate the valve using a 20 millimeter balloon under rapid pacing. And as I mentioned, the pacing, we don't use a temporary wire because these valves have a very low probability of having a temporary wire. We would only use it if we have a pre-existing right bundle branch block. So this is the balloon going in, and you can see the black clip will go to the wire, to the Safari, and the red is on the venous sheath on a wire that is in the blood pool. So now we will pace at 180 beats per minute, and we will inflate. So we inflate. Okay. Pretty straightforward. And then we will implant the valve in a minute. So the valve is quite flexible. It follows the curvature quite easily without many issues. The sheath that we use is a 14 French and it's expandable. So the valve is inserted using a little sheath, a little insertion aid that you can see in my fingers, in my hands. That takes a little bit of effort to expand the sheath, and then it follows all the way up to the arch and down to the root. Now in this particular situation, we need to make sure we have commissural alignment. So we looked at the 3 posts up there that if 2 are on the left and 1 on the right, we anticipate that we have to rotate clockwise in order for them in the 3-cusp view to be totally aligned. And what we do now is we move to the cusp overlap view and we rotate the handle clockwise so that we can see a free strut there on the right and 2 cells and 2 posts on the left. So this is as easy as it gets. It's very visible, and it takes just a minimum effort, usually a few seconds to rotate. And then we're in good position. We just implant so that this marker in the middle of the valve is at the bottom of the pigtail. Most of the times we pace at 100 beats per minute to minimize any motion, and then we just deploy the valve from the top to the bottom. So first we open the crowns. We just recheck the position. Then we will open the arches that will center the valve and will make it stable. It's a process that takes a few seconds. Patients are usually tolerating that without any problems.
Is there any importance of the flashport position for the commissural alignment?
Correct. It is. We usually insert it at 6 o'clock. So by having it at 6 o'clock, it gives you 80 to 85% probability that you will end up in the commissural alignment. And then you can see the opening of the stent frame that is very fast, and then we just resheath the whole assembly, and then we take it out. Now you can see the 3 posts of the valve there. They're equally spaced in the cusp overlap, in the 3-cusp view. That having done all the work that before, it shows that we're commissurally aligned 100%. But in order to document that, we need to move over to the right side, to the areocaudal, to the cusp overlap view, and then you will see the 2 posts on the left side and the 1 post on the right side that confirms the commissural alignment. If it's the other way around, that means you're totally misaligned, and we don't want that to happen. Of course, having done all the procedure that we did before, all the steps, it's very unlikely that this will happen. But because it's a 60-degree rotation between one position to the other, to the full alignment, from the full alignment to the full misalignment, we need to take these steps. So first we take out the wire, we put a pigtail in. With this valve, and you can see the hemodynamics are great, no gradient and nice separation of the diastolic curves. It's very important not to lose your wire position in this valve, because if you want to recross, you need to take care, and you can see there's no PVL, you need to take care that you go through the valve and not through one of the arches, because that could potentially create problems if you want to post-dilate with a balloon. So it's one of the things that you need to take care. So now we're happy with the hemodynamics, and just for the sake of demonstration, we roll over to the areocaudal, to the cusp overlap view, and now you will see, I think I've seen it, yeah. So you can see here 2 posts on the left, 1 on the right, and that is a proof that we are commissurally aligned 100%. So I think pretty much this is the case. This is the removal of the sentinel. So after taking the pigtail out, we go up and then we just resheath the distal basket, and then they unflex the distal system and then resheath the proximal basket. And we always try to see what we captured. In this particular case, we captured this. So lots of white stuff, white clots or debris or, I don't know, calcium. So, you know, maybe nothing could have happened before if we haven't put the sentinel, but who knows, you know. That's the unknown of these procedures. So patient did very well, discharged on day 3 with an eventful recovery with single-digit gradients and no PVL. So thank you very much for your attention, and I'm open to discussion and questions.
Thank you very much. Thank you, Vilas. Excellent case. Is there any question from the panel and from the audience? I will ask one question for the alignment, commissural alignment. The system looks pretty flexible, and you can return it inside compared to the other system. Now, other systems are also focused on this point, I think, Vilas. What do you think about this?
I think it's one of the best systems to perform commissural alignment, because the markers right now in this iteration of the device, and I know the company is preparing another iteration that probably will make it even easier, but in this iteration you have 2 clear markers. One is the posts that you can align before, and one is the free cell that when you have it on the right side in the cusp overlap view, you know you're commissurally aligned. It's very flexible and it's very safe to rotate. Even rotation over 360 degrees is acceptable. The main thing is when you reach to your position to let the system dissipate. So get your hands off the system and let it torque back so that there's no stored tension. Otherwise, when you open the valve, it will continue to rotate and then it will lose the alignment.
Thank you.
Okay.
Now,
okay, I see there are no more questions, and I think we had a wonderful session. I would like to congratulate all the participants and the panel, and we hope to see you again soon next year. Thank you.
Hope to see you and meet you. Blessings. Bye bye.
Bye bye. Nice meeting you.
Tissue integrity diminishes over time, largely as a result of calcification. Tissue valves are exposed to a variety of calcification sources. Free aldehydes are one of these sources of calcification. They accumulate in the tissue during the glutaraldehyde fixation process and throughout valve storage. Collagen is a structural protein material that makes up 75% of bovine pericardial tissue. Bovine pericardium collagen is multi-layered and multidirectional, helping to give the tissue material strength and flexibility. Resilia tissue is bovine pericardium that has been transformed by a novel integrity preservation technology that virtually eliminates free aldehydes through the combination of two proprietary features. The first feature is stable capping, which permanently blocks free aldehydes in the tissue, preventing calcium from binding in vivo. A sheep study demonstrated 72% less calcium content after 8 months in valves with Resilia tissue. In addition, the COMMENCE surgical aortic trial showed that surgical valves with Resilia tissue demonstrated strong clinical outcomes and excellent durability at 7 years. The second feature is glycerolization, where water is displaced with glycerol, removing the need for preservation in liquid solutions like glutaraldehyde. This prevents further exposure to free aldehyde groups, thus protecting and preserving the tissue's integrity and enabling storage in dry conditions.
Good evening. I think that we have a very interesting session on tricuspid valve. Women in cardiology, all the speakers are women, and this is very interesting also. I think that the tricuspid valve is a very hot issue in clinical practice, and we have to start with the first speaker, Dr. Korkovelli. The topic is tricuspid regurgitation, heart failure staging, and hemodynamic assessment.
Good afternoon. Thank you for being here today. So in the next few minutes, I'm gonna talk to you about an old kid on the block who has become the queen of the ball, tricuspid regurgitation. Right heart failure is a clinical syndrome due to alteration of structural and functional structure and function of the heart that leads to suboptimal blood flow to the pulmonary circulation and elevated venous pressures. So when we have right ventricular dysfunction, it could be either primary or due to RV function decrease in its contractility, or secondary due to RV pressure or RV volume overload or right atrial remodeling. So the cardiac alterations in patients with right heart failure can vary depending on the cause. However, we have more or less RA or RV dilatation, increased RV filling pressures, and increased CVP. And all these lead to the signs and symptoms of right heart failure that we all know: jugular distension, ascites, liver distension, renal failure, malabsorption, and due to congestion of the intestine. So when the cardiac output of the right ventricle drops, we have a drop in the alveolar filling, the drop of the left ventricle cardiac output, and due to ventricular interdependence, we have increase in alveolar filling pressures. So all this results to hypertension, exercise intolerance, shortness of breath, pleural effusion. All these could be symptoms of patients with right heart failure. So in this scheme, in this picture, we can see what we already know, that even though the picture of patients with end-stage right heart failure can be dramatic, in earlier stages, even with severe TR, patients could be asymptomatic or mild symptomatic, and peripheral edema could be the only sign of disease. So tricuspid regurgitation might be a cause or a consequence. So right ventricular dysfunction feeds tricuspid regurgitation, and tricuspid regurgitation fuel right ventricular dysfunction. And the mechanisms associated with right heart failure and TR could be multifactorial, and there have been like more than 200 years since the first recorded description of diseased tricuspid valve to recognize tricuspid regurgitation as a health problem with high mortality. So the Framingham Heart study showed that the prevalence of clinical significant tricuspid regurgitation in the general population reached up to 5.6 in women and 1.5 in men older than 70 years old. Another report showing the distribution of TR in the community with 50% of TR being due to left valvular disease, and a quarter of that due to pulmonary hypertension. 1.6 million US citizens are believed to have moderate or severe TR, and the year mortality is over 10% in these patients, and more than 160,000 new cases per year are recognized. But while we have 1.6 million patients with TR, severe TR, the surgical procedures annually is less than 8,000. And why is that? Due to excess mortality associated with surgery in functional tricuspid regurgitation. So more than 85% of cases of tricuspid regurgitation is functional. But before going to that, we need to focus in another section, which is called iatrogenic related TR, and it's TR related with the implantation of devices. And we all know that the annual amount of devices that are implanted is increasing yearly. So the TR related to this implantation is increasing also. So this CIED-induced TR, as it's called, can be divided in primary or secondary. Primary is when it affects and interacts with the lead directly, and it can be found up to 40% of cases, while the secondary can reach the 60% of cases, and is a progression of the TR that already exists in these patients. So just keep under consideration when you have patients with tricuspid agitation, RV dilatation, and these patients are going to have a lead implantation or because of a pacemaker or a defibrillator. So we might need to think if we can go leadless, if possible, in these patients. So in this paper published by Dreyfus back in 2015, the authors state the obvious, that functional tricuspid agitation is not a valvular disease. It can be caused by different, it has different causes. As we said, left-sided heart disease that causes right ventricular remodeling affects the tricuspid annulus, but it can be due to atrial fibrillation, the so-called atrial functional tricuspid agitation. So we need to assess all this, the tricuspid agitation per se, the annulus and the leaflets, the coaptation gap, and the tethering or not of the leaflets before assessing these patients for any intervention. And the authors classified these patients in 3 stages, and based on the stage, they offered the right therapy. So the vast majority of patients having functional tricuspid agitation have heart failure or left-sided heart disease. And FTR due to heart failure is associated with impaired quality of life. And the more studies in the past have been restricted to half ref, but recent data have shown that more than half of all heart failure patients have PEF, and it's something that we need to consider. So these are reports from the past, from like 20 years ago, saying that patients with heart failure with reduced ejection fraction having a worse prognosis, and the prognosis gets worse if the tricuspid agitation is more than moderate. This was a very nice study with a very big amount of patients that had reduced ejection fraction, and showed that the prevalence of moderate severe FTR was 23%. But the author stated that given the fact that the burden of heart failure globally, it becomes bigger and bigger, this percentage might go up. So the FTR is a strong independent determinant of mortality and should be a therapeutic target. This paper has patients with all the subtypes of heart failure, reduced heart failure, mid-range heart failure, preserved heart failure, and it stated the same thing, that the presence of tricuspid agitation, moderate or severe, is associated with worse prognosis. This paper, and I know there are lots of papers, but I need to focus on 3 or 4. So it's for right heart failure, and in this paper, more than 1,000 patients, they were staged based on their symptoms, stage 1 no symptoms, stage 4 right heart failure, and it found that the fact that the clinical stage of right heart failure was an important prognostic factor in patients with right heart failure and tricuspid agitation. And in this paper, the staging was the same. It was patients that were meant to have like a tricuspid surgery, and it stated that patients that were in 1, 2, 3 stage of right heart failure had better outcomes than patients in right 4. We know, but it was documented as well. So pulmonary hypertension, a very specific and very important factor of FTR. As we know, the pulmonary hypertension associated with left heart disease and with lung disease are the most common causes, and we know that up to 88% of patients with reduced ejection fraction having FTR. And when it comes to precapillary pulmonary hypertension in patients with chronic lung disease, when the pulmonary hypertension is confirmed, TR is very common, and the estimated incidence of pulmonary hypertension in these cases ranges between 7 and 26 cases per 1 million adults. So diagnostic workup of tricuspid regurgitation, we need to focus on that. And of course, transthoracic echocardiogram is the first line, but it needs to be a multimodality session to assess the tricuspid regurgitation, but I will leave that to the next speakers. I will focus on right heart catheterization, has a key role to exclude pulmonary hypertension, to differentiate pre from post-capillary phenotypes, and to, finally to define the impact of tricuspid regurgitations. I know you all know these waveforms, just to bring them in your mind. When we go through the right heart cath of a patient with tricuspid regurgitation, we might encounter this waveform in the right atrium. It's the ventricularization of the right atrial pressure. We have a dominant V wave and the steep Y descent, and we have a fusion of the CV waves. And here I need to mention that the height of the V wave does not correlate with the severity of tricuspid regurgitation, which is a common disbelief. Common belief. So in the next picture, we show what we all know as Kussmaul sign. And what's that? It's the increase of the right atrial pressure during deep inspiration. And it's indicative of impaired RV compliance. So the most important thing when assessing these patients with heart failure and tricuspid regurgitation is to find the right diagnosis, because the right diagnosis will give us the right treatment. So when it comes to restriction and constriction, this is, as you can imagine, very, very important, because not all the patients, not restrictive cardiomyopathy cannot have transcatheter intervention treatment. The root sign waveform, I believe that it was sensitive, but it's not so sensitive and specific for the differentiation. However, the relationship between the RV and the LV during the inspiration, during the respiratory cycle, is very important, and this is what we call ventricular interdependence. So when we have an increase in the inspiration of both the RV and the LV pressure, and an increase in the diastolic pressures as well, we have this is indicative of restrictive cardiomyopathy. On the other hand, when we have an increase in right ventricular pressure, but this does not follow from with an increase in LV pressure, this is a sign of constrictive pericarditis. Ventricular interdependence has sensitivity and specificity more than all the other findings, hemodynamic findings. So it's something we need to focus on, remember. Of course, with the right heart catheterization, we assess the pulmonary pressure, the wedge pressure, which is also important to see if the patient has post or pre-capillary pulmonary hypertension. And now this is probably the only reference I did echo. So there is a very nice report from Lutz back in 2022, if I remember correctly, where it says that when the patients were assessed for having transcatheter intervention of the tricuspid regurgitation, and these that were assessed both with echo and invasively, and they found to have pulmonary hypertension, they had a poor prognosis, but not as poor as the patients that were referred for transcatheter treatment, and they were referred only with an echo positive for pulmonary hypertension, and they didn't perform right heart cath. That means that these patients, we don't perform transcatheter treatment in patients without right heart cath. Not to mention that we have to do the cardiac output, either with FIC or thermodilution, whatever makes us comfortable. And it will be a very brief case of a patient that went for tricuspid intervention in our department, 70-year-old with ischemic cardiomyopathy. And this is his right heart catheterization. You can see the ventricularization of the right atrial pressure and the high PA and wedge pressure. So when it comes to therapy in tricuspid regurgitation, so again, we mentioned many times because we need to focus on the underlying disease. There's no point of doing transcatheter intervention without knowing what's the issue, what's the main cause. And it's the only way to interrupt this vicious cycle of tricuspid regurgitation and right heart failure. So just to conclude, tricuspid regurgitation has been identified as a significant clinical challenge in aging society. A systemic multi-view and multi-parameter approach is crucial. Patient selection is the key to success, and we should all remember the FTR is not a valve disease and should not be treated like this. And transcatheter treatment is also the future in TR disease, but in very specific patients. Thank you very much for your attention.
Thank you very much. A very comprehensive talk. I would like to do a question, and after that we have discussed. In clinical practice, we see patients with severe tricuspid regurgitation, and after 1 or 2 years, the TR regressed, not progressed. This percentage is approximately 40%. Do you think that we have some points that we predict the regression or progression of TR after a therapeutic?
Because there are patients that we might see a difference in the tricuspid regurgitation on the echo, but this might has to do with the right ventricle function, because sometimes when the RV fails, then the jet in the tricuspid regurgitation is less. We can't measure it the same as it was when the RV function was good. So this something can happen when we have an RV failure, but what we need is to find these patients before and treat them before. So if I understand correctly, you asked me if what we should find or what we should do in order to prevent. So it depends on the stage we have and the clinical stage and how the patient feels, because sometimes and of course it depends on the etiology. So we need to find what's the issue with these patients, because if it's ischemic heart disease, we need to focus on the ischemic heart disease. If it's a cardiomyopathy, we need to focus on the cardiomyopathy, even put a defibrillator or CRT device and things like that. So I think that the main thing is to focus on what's the main problem of the tricuspid regurgitation, and then if we have done all the guidelines-derived things, then we can see if that patient could be referred for something else.
Okay, excellent. The presence also of atrial fibrillation plays a crucial role.
But then again,
then
again, we don't know how to interfere with atrial fibrillation if the patient is a good candidate for ablation. So this is something that needs more all the cardiology specialties, I think, the right heart failure and heart failure.
Or the presence of pulmonary hypertension. This group of patients are
again, we need to define what kind of pulmonary hypertension.
Any comments?
I think that as time goes by, we also use MRI more and more.
Exactly.
And there are MRI indices even of RV diastolic dysfunction now, fibrosis, systolic function you mentioned. So perhaps, and it's not easy to obtain an MRI in all of these patients because there are very many patients, but in some of these patients, and perhaps we can have comments from the audience, the MRI will give us some predictors about how bad is bad.
It's not very easy tool. I mean, it's very expensive, so that's the reason we can't have not every patient, even though they give us lots of details, more than echo. Sorry about that.
Very nice talk. Congratulations.
Thank you.
So just 2 points. The one thing is that women, as you saw, tend to get TR far more than men.
Fortunately.
So there is a sex-specific this entity. Second, and also you mentioned that it's very important to define the etiology because this defines prognosis and treatment. And the third one, and I think this is very crucial too, is that right heart catheter is a very simple procedure and very often
it needs to be done in these patients. We can't have treatment without that, in my opinion.
Very nice talk. Thank you very much. I want to ask something. As you said, the right ventricular function is very important in patients with tricuspid regurgitation because the outcomes are very different if we have a very bad right ventricle. So you have also experience because you have a lot of patients doing transcatheter procedure for TR. How are you evaluating the right ventricle which is your protocol for the patients in evaluating the right ventricle function? With 3D echo, are you doing MRI in all of them or in some of them? Or which are the protocols?
So depending, so because we do lots of, we have new devices and we are part of trials and things like that. Every trial has its own protocol, but most of them, they need a transthoracic echo, but we do a transesophageal echo, of course, and depending on what other comorbidities, we do a CT scan of the heart, but MRI is not in the protocol. If someone has it, it's okay, but we normally don't do MRIs in these patients routinely.
I mean, for the right ventricle, are you using TAPSE, for example? Are you using
you mean the echo?
Yes, the echo.
Okay, you wanted to go through that. So it's the next step. But we do TDIs, we do TAPSE, and we do things like that. But we do that.
But we have also the Dr. Samarkati, please, your comments.
Yes, thank you for having me here. I hope my voice is very clear. Yeah, first of all, congratulations on the very nice talk. And it's a very hot topic now, having transcatheter and tricuspid regurgitation of disease. But I think the most important slide that you have presented is from the nice paper saying tricuspid valve isn't a valvular disease. Actually, it's a consequences of multi other factorial. So evaluation the etiology of the TR, starting from the basic echo, TAPSE, PA pressure, and then maybe right heart cath, and give you a roadmap where to go with. And I agree with you, like for example, there is a vicious cycle going with dilatation of the RA, the RV, and so and so. And those patients, unfortunately, they are good until they're not good. So you have to define what is the best point to pick those patients before they go into the last end stage of heart disease. So I think we used to say, for example, rate versus rhythm control in atrial fibrillation, but I think maybe now we're shifting gears, we're looking at the things differently and actually considering earlier ablation. If you catch these patients in the early stage, maybe we just cardiovert them with a very simple maneuver rather than going to the expensive cardio ablation and going with these expensive procedure. So now I think in the last 5 years, everyone is looking at it differently in terms of the analysis, the investigation, and afterward, even the approach, people are going more aggressively targeting the etiology of the problem and the root of the problem rather than the consequence of the problem itself. So very nice talk. I admire the way we approached it. And to add to it, we can also include RA-RV coupling. Also, it will also help you sometimes, as we mentioned, the PA pressure and pulmonary hypertension, where to direct. Sometimes you want to help the people, but sometimes you cannot. So having a full image, full perspective, and you direct then or tailor the treatment based on each patient individually.
Okay, thank you. So we have to continue to the next presentation. Dr. Koutroulou, please. Echocardiographic assessment of pulmonary artery pressure and right ventricular function.
Good morning to everyone. Honored to be here today. Thank you, Dr. Sparias, for inviting me here today. So my talk within the next few minutes is going to be more echo assessment of the systolic function of the right ventricle as well as a measurement of the pulmonary artery pressure. With echocardiography, we can do, as you can see here, a lot of measurements with the 2D, M mode, as well as Doppler. Many of those things that we see here, we're going to discuss within the next few minutes. But what I want to start with is that regarding to the 2D assessment of the RV size, but also the systolic function, we're using a lot of images, but in order to see the RV and monitor and measure the systolic function, we usually go to the apical view, where we see the dedicated RV view, where we want to see the RV on its whole. We don't want to go with the image at your right side, where we miss the apex as well as most of the medial part of the ventricle, but we want to see a dedicated RV view. Here you see that we actually miss the RV outflow tract, but at least we have the rest of the ventricle. Just a brief of the geometry of the RV. As you all know, as you all remember, the RV has actually a crescentic size. At the top of our cursor, when we are placing the echocardiographic probe on our patient, we see actually most of the apex of the LV, and we need to see the RV like you see it on the left side. When an RV is dilated, because, for example, a patient has pulmonary hypertension, the apex of the RV gets this crescentic shape of the RV gets destroyed and becomes more rounded. In regards to the assessment of the size, I'm not going to say a lot of things because this is not a part of my presentation today, but just a reminder that we do a few of measurements. We measure the RV, again, from the apical window, the basal, the mid, as well as the length of the RV in order to decide if it is dilated or no. In regards to the RV function now, we have older but also more recent guidelines that give us a lot of information about how we can measure, as well as a lot of literature. Just a reminder that the right ventricle is a little bit different from the left ventricle. The right ventricle actually has a lot of longitudinal movement. However, the left ventricle has all three: longitudinal, radial, and circumferential. This is exactly what we want to evaluate the RV in regards to the systolic function, the TAPSE. We actually evaluate the longitudinal movement of the right ventricle. TAPSE is actually tricuspid annular plane systolic excursion. It actually we actually evaluate the distance that the tricuspid annulus moves up and down during systole. It is important to align our cursor actually parallel to the movement of this longitudinal movement of the tricuspid annulus. What we actually do with the echocardiography is that we zoom at the tricuspid annulus and we place our cursor at exactly where is the lateral part of the tricuspid annulus, and we measure the distance through the M mode at the bottom of the diastole to the systole, the longest distance. And when this distance is more than 1.7 centimeter or 17 millimeter, then we say that this patient has normal RV function. However, we all know that TAPSE gives us information only about the basal RV. There are people who have abnormal RV systolic function even with normal TAPSE when the mid or the apex of the RV is not moving well. There are data that are actually linking the TAPSE with outcomes of the patient, and that's a very important measurement that we have to have in all our measurements. The next measurement that we use in echocardiography in order to assess the right ventricle is the tissue Doppler. Via the tissue Doppler, we actually again evaluate the longitudinal movement of the RV, but now not the distance, but the velocity with which the tricuspid annulus moves up and down during systole. Here, what we actually do is that we place the tissue Doppler, we use our PW, and we place it exactly at the annulus, not at the myocardium of the RV. And there we try not to measure the first wave, which is actually the wave of the isovolume contraction, but actually the actual contraction, the S wave. And when the S wave is more than 10, then we say that this patient has probably normal right ventricular systolic function. I'm saying probably because, again, we evaluate the basal part of the RV and not the entire RV. Again, here there are data that link the RV systolic wave with the outcomes of the patient. And again, our cursor needs to be parallel with the longitudinal movement. Going forward, another measurement that we do when we want to assess the function of the RV is the actual RV functional area change. Here we measure the RV area during end diastole as well as end systole. So the area in diastole minus the area in systole divided by the area in diastole multiplied by 100 gives us the functional area where when it is more than 35%, then we say that this patient has a normal RV function. Here we have a lot more information about the RV than with the TAPS and the RVS, and the only part of the RV that we are missing is the right ventricular outflow tract, which actually we only assess with the parasternal and short axis view, and only when we see it with eyeball. Actually, the FAC measurement is the one that has been very well correlated with measurements that we do with MRI. So when we have a patient that we really need to assess the RV, this is a measurement that we want to do. A study from a few years ago shows that in people who have a heart attack, an acute MI, FAC is one of those echocardiography measurements that actually predict their outcome. RV strain is a measurement that we do. It's actually an easy measurement that we do in our everyday life. We used to do it for the LV, but the last many years we do it actually for the RV. It's I would say a measurement that it's easier to do for the RV than for the LV. We actually do the same thing. We use a narrow sector, but we make sure that we have the whole RV in our plane so as not to miss a few segments. We have, however, our sector as narrow as we can so as to have a high frame rate. We perform the strain in the RV like we're doing it in the LV. However, we disregard the segments that are in the septum, and we only account the 3 segments that are in the lateral part of the RV. Actually, it's 3 numbers. We divide by 3, and we have our number for the RV strain. And when it is more than minus 25%, then we say that the strain of the patient is normal. For the RV strain, there are a few data a few years ago, but also more recent studies that again link the RV strain with outcomes of the patient. It is very important that now we are independent of the angle, and of course it is vendor dependent. One more thing that we do, if we have a machine that does 3D, then we have the ability to do a 3D calculation of the right ventricular ejection fraction. In that measurement, we actually not using area anymore, but we're using volumes. So now we have the right ventricular end diastolic volume minus the systolic volume divided by the end diastolic volume, and we have our 3D assessment of the RV. Again, dependent on the vendor that we have, we take actually a full volume of our right ventricle. We try to have all the right ventricle in our sector, and we use multi-slice in order to make sure that we see our RV. Usually we make our patient do a multi-beat, we have our patient hold the breath, and then we are actually measuring via the curriculum that has each machine, and we measure the EF. And we have a graph that looks like that, like the green graph here. The prognostic value of the right ventricular ejection fraction via 3D was shown to have very, very good correlation, again, with the adverse outcomes of our patient. In a very recent meta-analysis in JACE, the 3D evaluation of the right ventricular systolic function was actually the best measurement that we can do in order to evaluate the 3D. The systolic function of the right ventricle. I'm just mentioning the myocardial performance index. It's actually a measurement that we don't actually do in our everyday practice. It's actually the time that the right ventricle spends in having the tricuspid valve open in regards to the ejection time, which is the time where the blood comes out out from the pulmonary valve to the pulmonary artery. What we need, actually, we need less time of the tricuspid valve to be open. The lower this number is, the better the systolic function is. Here, for example, I have an example. I have a patient who has a little bit of tricuspid regurgitation, so we can have a good envelope of the TR, where here we can measure the time from the start of our envelope to the end, which is the opening and the close of the tricuspid valve, and then we subtract it from the time that in the right side the pulmonary valve is open. However, again, in our clinical practice, we don't use that number. Literature says that when this number is less than 0.32, then we say that we have normal right ventricular systolic function. When this number is more than 0.43, like in this case here, it's actually decreased RV function. In the past, people thought that this was load independent, but actually this is again a measurement that is load dependent. So when we have a patient and we want to evaluate his right ventricle, the next question that we have in mind, because when we are doing an echocardiography, we're just don't doing an echocardiogram to do it, but we actually need to say a story about the patient, to have a story that we want to say. The next question that we have is actually, does this patient have pulmonary hypertension or no? When we want to think about the pressures in the pulmonary artery, I'm starting from the end, so I'm starting from measuring the pressure in the right atrium. I'm pretty sure that everyone knows that seeing the inferior vena cava and measuring the diameter, as well as the inspiratory collapse, then we can approximate how much is the pressure inside the right atrium. So when an IVC is less than 2.1 centimeter and the inspiratory collapse is more than 50%, then we say that this pressure is 3. When the IVC is more than 2.1 centimeter and the inspiratory collapse is less than 50%, then we say it's 15. But this is, and in between we have the 8. However, this is as per guidelines, and as we all know, this measurement can, of course, underestimate and probably underestimate a lot the pressure in the right atrium in people who have pulmonary hypertension and very high pressure in the right atrium. Some other echocardiography labs, for example, that one in Mayo Clinic, they use not 15, but they use 20 millimeters of mercury as the highest number that they can give in order to decrease the errors and be a little bit more close to what the cardiac catheterization would say. However, again, you can again underestimate it. So when you have the measurement of the right atrial pressure via the IVC, then you go ahead and you want to do a small cardiac catheterization via echocardiography. How you do that? You have the TR velocity envelope, and you can calculate all the red blood cells that regurgitate through the tricuspid valve. And how you measure all those red blood cells? You actually take the mean gradient, you take the VTI, the velocity time interval, and when you have, and then you add the pressure in the right atrium, and there you are, you have the mean pressure in the pulmonary artery. Of course, there is also another type that they use the acceleration time. However, the most in the literature, the best way to evaluate the mean pressure in the pulmonary artery is actually the mean gradient through the tricuspid valve. Going forward now, in order to see a little bit more about the TR velocity, the TR envelope, it's very important not to measure the fuzz. Also, when we cannot see very well the envelope, we can give to our patient normal saline in order to make that envelope be more obvious and make our measurement. In regards now to the systolic measurement of the pulmonary artery, we can use, of course, the TR velocity at the envelope of the TR and add it to the right eye pressure. And here we have the systolic pressure in the pulmonary artery. The same with the diastolic pressure. We have our envelope at the at the regurgitation of the pulmonary valve, and then via the Bernoulli equation and the 4V squared plus the RA pressure, we have the diastolic pressure at the pulmonary artery. Again, via echocardiography, this is an assumption. We make the best we can, and as Dr. Kurkovelli said before, it's very, very important in people who have severe TRs, pulmonary hypertension, dilated RV, is a question mark about what we do with those patients. We always want to do right heart catheterization. It's a very tricky thing to measure the pulmonary pressure in patients with severe TR, and we don't need to use numbers anymore. And this is because we know that when the RV fails, then the pulmonary pressure is going to fail. So in a failing right ventricle, we cannot use the pulmonary pressure via echo to say what is the pressure in that patient. There is the RV-APA uncoupling that occurs, for example, in pulmonary arterial hypertension, when there is hypertrophy of the smooth muscle cells in the pulmonary arterioles. So there is a lot of remodeling, and as a result, the afterload in the lungs increase, and there is a problem for the RV to extract the blood to go into the lungs. So important things to remember and account them when we are having a patient in front of us. Based on the recent guidelines, we cannot use TR velocity anymore. We cannot use a number that PASP gives us. We need to use a lot of things that the echo gives us in order to evaluate the RV systolic function and the PASP. Thank you so much for your time.
Thank you, excellent talk. I would like to point out that the RV coupling maybe is the most accurate parameter to evaluate the patient, the right ventricle, compared to the PASP. I would like to ask you, do you think that dobutamine stress echo has a role in evaluation of RV function? What do you think?
It has in regards to the increase of the pulmonary pressure. When we're doing a stress echo and we see that the pulmonary pressures of the patient increase, then we know that maybe there is a bigger problem with the RV. However, in our everyday practice, it's not that we are using a dobutamine stress echo in order to evaluate the RV. I would say more of the evaluation is probably the transthoracic echo and the MRI. But
maybe we evaluate the RV reserve. It's addition.
Of course. Always stress echo is useful.
Dr. Samargati, please, your comments.
Yeah, excellent talk. Thank you so much for the enlightenment. Though I am not an echocardiographer, but it was a very enjoyment. And being an interventionist working in the tricuspid, we became hand in hand with the our imaging department. So usually when we're planning a case, I agree, we usually spend majority of the time on transthoracic for the screening. And afterward, we go with the TEE. And if we have any suspicion of infiltrative myocardial disorders, we go for an MRI. And usually, right heart catheterization goes hand in hand with transthoracic. And then you decide where to go from there.
Thank you.
Any question?
Thank you very much for all the information that you gave us. Are you using, or how often are you using right ventricle, right atrium uncoupling in order to avoid afterload mismatch in patients with right ventricular dysfunction after closure of the TR?
You can use it. It's actually a measurement that is pretty easy to do. It's TAPSE divided by PASP. So it's actually a measurement that we can do after closure in order to, and it's actually before closing the TR. I think it's very important to evaluate the patient with everything that we said before, including the MRI, the cardiac catheterization, the echo, and the TE, in order to make sure that it's going to be it's going to be safe for the patient to close that TR. We want to have an RV that is actually has not failed. So the more important thing for me is to have an RV that is still functional before closing the TR. And your question is that after you place a tri-clip in the TR and you have the result is after, if we calculate the RVPA coupling, no?
No, it's how we are using it before. Do you have any number? I think then 0.31 is less than...
Yes, I think so. Yes. I think it is...
So are you using it in not everyday practice, let's
not
say?
Of
course, when you have right ventricular dysfunction...
When I have RV dysfunction, yes, I use it.
For example, this patient, it's possible to have right ventricular afterload mismatch after closure of the DR. So
sure.
Just to have an idea that, you know, he's at high risk of having,
so
you know exactly the profile of the patient.
So, for example, in a recent patient that I had with severe TR, I used it in order to see if this patient would have after. However, I do that only if I have a patient that has borderline RV failure or mild RV failure, and I want to predict how this patient is going to do after, and severe TR, of course.
Vivian, congratulations. I really enjoyed your talk. It was so concise and very clear.
Thank you.
I just wanted to make a comment that in patients with pulmonary hypertension, the RV to LV ratio has also been studied.
Of course.
And we use it a lot in congenital patients and tetralogy of Fallot patients, dilated ventricles, etc. So I found this helpful, having to extract from the pulmonary hypertension patients into our congenital patients, this RV-LV ratio. Mm-hmm. So you see the RV with a good ejection fraction, but it is dilated, it starts failing. Mm-hmm. And in the pulmonary hypertension group, it's been published at more than 60%, so it should be 0.6. Above that, you see that the RV starts to fail, and when the RV-LV ratio is above 0.9, then the RV is really very dilated, and we see that after our treatment, whether it's pulmonary hypertension treatment or anatomical treatment, the RV-LV ratio comes down. So although we don't do in the adult population commonly with acquired, or yes, sometimes we do, I think this is something very important to add in our everyday practice, because it's very easy to extract from this ratio about how our patient is doing. But thank you again, excellent talk.
Thank you.
Dr. Hirsch.
Congratulations, Vivian, a great talk.
Thank you.
I just want to point out a limitation of the RVPA coupling in the sense that it's an echocardiographic index, and we understand that in severe TR, we can't really measure systolic pulmonary pressure.
Correct.
And we use it for this index. Now, some people have tried to use invasive measurements of systolic pulmonary pressure to create an invasive type of RVPA coupling marker, which seems to work even a little bit better. So just to point out that limitation.
It is a big limitation. I said before that with the severe TR, we cannot measure actually with echocardiography the RV, the PA systolic function and the RV systolic function. And it's one of the limitations. That's why in those patients with severe TR, when we're planning to do, when you are planning to do your interventions, you always do a right heart catheterization, as far as I know.
Correct.
But I think this parameter evaluates both RV function and TR, and this is the most strong parameter value for this parameter. I think a bad RV with low TR has requires RV coupling. So it's very, I think that there are data concerning the prognostic value of this parameter in patients with severe aortic valve stenosis, with MR, severe MR regurgitation. I think it's a very strong parameter. Evaluates both RV function and TR. And velocity of TR, and I think it gives us a very valuable parameter. Okay, So we can continue with Dr. Drakopoulou, anatomical assessment of tricuspid valve, echocardiographic findings.
Good evening. It's a great honor for me to have this speech, and I would like to thank the organizing committee for the invitation. So for the next few minutes, we will talk about the anatomy of the tricuspid valve and the echo findings. So starting from the anatomy, we all know that tricuspid valve is the largest valve of the heart, and it has an area of 7 to 9 centimeters square, and the position is anterior and apical. As we may see in this figure, the tricuspid valve is quite challenging, and the tricuspid valve apparatus consists of these 4 parameters: the leaflets, the annulus, the chorda tendinae, and the papillary muscles. We know that the leaflets of the tricuspid valve are thin and mobile and are not prone to calcification as the leaflets of the mitral valve. And as we can see, usually the tricuspid valve has 3 leaflets, the anterior, the septal, and the posterior. We see that the anterior leaflet is the highly mobile leaflet. It is thin and it has a great circumferential area and a great radial length in comparison to the other 2 leaflets. The less mobile leaflet is the septal leaflet, which is attached to the septum, and the smallest leaflet is the posterior leaflet. And we know that the coaptation zone, the area that the leaflets coapt during systole, is around 5 millimeters normally, and the coaptation zone is at the level of the annulus or a little bit more in the right atrium. Besides the coaptation zone, there is also the commissures, the commissure between the anterior and the septal leaflet, which is the anteroseptal commissure that is in close proximity to the aortic valve. We have the septoroposterior commissure, which is close to the coronary sinus, and the anteroposterior commissure, which is close to the anterior papillary muscles. So going to the annulus, we know that the annulus has a 3D configuration, but recently in 2021, we had the new classification of the tricuspid valve leaflets based on the variation. And we know that the type 1 valve with 3 leaflets is the classic form, which is the normal valve. However, we have other types, such as the type 2, where the anterior leaflets are fused, and we have 1 anteroposterior leaflet and 1 septal, type 3A with 2 anterior leaflets, type 3B with 2 posterior leaflets, and other types. Among the variations, we know that the type 3B is the most common. It's about 33% as an incidence. And this classification was derived from this study that included 600 patients. So going to the annulus, we know that the annulus is circular. There is the anterior, the posterior, and the septal annulus, and we know the anatomic landmarks, which is the aortic valve, the coronary sinus, and the anterior papillary muscle. And we know that when the RV dilates or when the annulus dilates because of atrial dilation, the remodeling happens at the anterior and the posterior annulus, whether the septal annulus remains intact. When we go to see the tricuspid valve as a 3D structure, we know that the superior points are the anteroseptal and the posterolateral, whereas the inferior points are the anterolateral and the posteroseptal. What about congenital heart disease? We also have Dr. Jifa in our panel. We know that more than 100 years ago, William Epstein described Epstein anomaly, which includes, of course, tricuspid valve and RV. And we have the classification that was proposed by Carpentier, and it includes the displacement of the septal and posterior leaflets and the atrialization of the right ventricle. And we see that we have mild forms and severe forms, starting from the A to the D type. As we can see here, it's a moderate form, but we can have also extreme forms, like this patient that both septal and posterior leaflets are very high at the right ventricle, reaching the apex of the right ventricle. So this is the congenital heart disease and the Epstein anomaly of the tricuspid valve. If we go to the pathological changes, we know, as we previously said, that we have 3 main categories: the primary TR that involves pathology of the leaflets, and actually recently there was a great focus in the pacemaker-induced TR, which includes 3 subtypes. It's the implantation-related, the lead-related, and the pacing-related. So the implantation-related has to do with injury of the valve during the procedure. Lead-related, it's when we have lead adherence, lead entanglement, so the a leaflet may be tethered due to the position of the lead, and the pacing related is when we have RV dysfunction due to the pacing, so the RV dilates, and we have dysfunction due to the dilation of the RV because of the pacing. And actually, in this publication of the European Heart Journal in 2023, we know that this is a different category, the lead-induced tricuspid regurgitation, and we have two subtypes, type A that has to do with the lead, and type B, that the lead is incidental finding at the tricuspid valve but is not involved in the tricuspid regurgitation. And this is a 67-year-old female patient with mitral valve prolapse, significant mitral regurgitation, that in this patient we may see also prolapse of the tricuspid valve with moderate regurgitation and eccentric jet towards the septum, and we can see that the jet is mid-20 systolic. Going to the functional secondary tricuspid regurgitation, as we said before, we have two great categories. The one is the RV dysfunction, RV dilation, tricuspid annular dilation, where the RV is dilated and the RA is less dilated, whereas in the atrial form, we have a huge right atrium and the RV is less dilated, so we have less tethering of the leaflets and the dysfunction of the RV is less. And we see that actually we have different phenotypes based on the etiology of the secondary ventricular or atrial functional TR, and the differences are the tethering of the leaflets, the RV function and size, as well as the RA function. And here are some cases that involve, first of all, secondary ventricular TR in patients who have left heart disease, a patient with ischemic heart failure, dilated and reduced ejection fraction of the left ventricle. So we have involvement of the RV with significant TR. In the second category, we have primary RV dysfunction due to ARVC. It's an end-stage right heart failure patient with an ICD lead, as you may see, and there is laminar flow, so there is torrential TR in this patient, whereas the LV is functioning well and we have low pulmonary pressures in this patient. And there is another phenotype, as Dr. Jifa said before, when we have patients with pulmonary hypertension, as in major patients, as in this case we have a bidirectional shunt at the PDA, and this patient has pulmonary hypertension and significant TR due to the pulmonary hypertension. So three different phenotypes in ventricular TR. Going to the atrial TR, we see that the RV in these cases is good, is functioning well, and the size is good, whereas we have huge right atrium and biatrial dilation due to chronic atrial fibrillation. Going to the echo of the tricuspid valve, we know that we can have both the transthoracic and TOE images in order to clarify the anatomy. And transthoracic echo, starting from this, can clarify the morphology of the tricuspid valve, grading the TR severity and assessing the RV, as we said previously. So we have several views that we can assess the tricuspid valve and actually see the different cusps in different views tilting the probe. So starting from the parasternal views, we have the RV inflow view and the short axis view at the aortic valve level. We know that if we see the coronary sinus, then we go to this slide. If we see the coronary sinus, then we can clearly be sure that the leaflets that we see are the anterior and the septal. So in this case, we see that we can be sure that this is the anterior and the septal leaflet, whereas if we tilt the probe a little bit backwards, we can be sure that the leaflets that we see are the anterior and the posterior. Going to the short axis view in transthoracic echo, we know that we can see on this level the anterior and the posterior leaflet, whereas the septal leaflet has an apical displacement in most cases with moderate to severe TR, so we can see anterior and posterior leaflets in these views of the short axis aortic valve. If we go further on and tilt the probe towards the mitral valve and the short axis, we can also see the short axis in most cases of the tricuspid valve, showing the septal, anterior and posterior leaflet. And going on to the transthoracic apical views, we know that if we see a 4-chamber view, we can be sure about the septal leaflet. However, the other leaflet may be the posterior or the anterior. However, if we do the trick and open the LVOT, we can be sure that this is the anterior leaflet, whereas if we open the coronary sinus, this is the posterior leaflet. And going to the images, we see here, opening the LVOT, we see that this is the septal in the anterior leaflet, whereas in other views, closing the LVOT and opening the coronary sinus, we can be sure that we see the septal and posterior leaflets. The 3D, we can take the images from any side. We can see the tricuspid valve well, and we can well define the atrial, septal, and posterior leaflet based on this on the site of the aortic valve and of the interventricular septum. So the subcostal view is like the 4-chamber view. We see the anterior and septal leaflets, and if we tilt the probe, we can also see the short axis of the tricuspid valve. Concerning the echocardiographic parameters for the severity of the TR, we know that during the last years we have 2 more categories, massive and torrential TR, and actually these 2 new categories seem to have a prognostic role in the patients with severe TR, and we have qualitative, semi-quantitative, and quantitative methods so we can assess the severity of the TR. We talked about the RV function and the size of the RV, so there are indexes that we can rely and estimate the function and the size of the RV that we said a little bit earlier. Going to the TOE images, we know that TOE plays a crucial role, especially in patients that need and go for screening for transcatheter intervention, so we can assess the morphology, grade the severity, as well as assess the eligibility for transcatheter procedures. And we can see that the TOE offers images at different levels, at the mid-esophageal view, deep esophageal view, and transgastric view. Starting from the mid-esophageal view at 0 to 30 degrees, we can see the 4-chamber view. At this standard view, we can see the septal and anterior leaflets, as you see here in the figure. However, if we tilt the probe a little bit down to the esophagus, we can assess the posterior and anterior leaflets at this level. Going to the RV inflow view, at the short axis view of the aorta, we can assess both septal, anterior and posterior leaflets. As we can see, if we place our X-plane towards the aorta, we can see the anterior and septal leaflets. However, if we place the X-plane towards the posterior wall, here we will see the posterior and the septal leaflet. So we can assess all 3 leaflets. If we go a little bit deeper, we can see, like a 2-chamber view, the RA and the RV, and assess both septal and posterior leaflets if we go further on down. And going to the transgastric view, which is a very critical view of the tricuspid valve, we can see the short axis of both atrioventricular valves, and we can assess the anterior leaflet towards the aorta, the septal leaflets towards the septum, and the posterior leaflet at the posterior wall. And this is a very good view when doing the transcatheter procedure for deposition of the clip. Also, 3D offers a very valuable image, as we can see. We place the aortic valve at the 150 degrees. This is the anterior, the septal, and the posterior leaflet, so we can have a good orientation and offer guidance. Only 2 slides about the transcatheter procedures. We know that this has evolved during the last years, as starting with a clip at the position of the mitral valve. We have favorable, feasible, and unfavorable characteristics. Among them, it's the coaptation gap, which should be less than 7 if we consider it a favorable case. More than 8.5, it's an unfavorable case. We know that the lead at the position of the right heart chambers is a limitation concerning the position of the clip. And of course, there are several techniques that we can plan in order to place the clip at the anteroseptal, or going for another strategy, putting the clip between anterior and septal and posterior position. This is a case with a lead at the tricuspid position. The lead has a posterior position at the posterior cusp, and with tilting the probe, we can see and prove that this is actually what we see. You can see here when putting the probe towards the posterior part of the right ventricle, we can very nicely visualize the lead, and also going to the transgastric views, we can see that the lead is towards the posterior leaflet. This is the aorta, anterior, septal, and posterior leaflet. So there are several gaps in knowledge concerning the tricuspid regurgitation. I think that this is the most interesting slide. Gaps concerning the pathophysiology of TR, the disease detection, interventional management, and medical management of this patient. It's very critical to have the patient in good volume. The role of diuretic therapy is very critical in order to assess the regurgitation and the anatomy of the RV and tricuspid valve. The rhythm control, and also we need to have the patient optimize as for its volume. In conclusion, given the complex anatomy of the tricuspid valve, a comprehensive protocol integrating 2D and 3D, transthoracic and TOE imaging is of paramount role. There is a great variation in the anatomy of the tricuspid valve, so ongoing research efforts are essentially to continually improve the interventional techniques and integrate them with other advanced imaging methods. Thank you.
Thank you, Dr. Drakopoulou. A very comprehensive talk. You have presented all the strengths of 2D and 3D transthoracic and transesophageal echo. We are happy to use in everyday clinical practice the 3D echo. Do you think that we need the other cardiovascular imaging modalities in order to evaluate the anatomical morphological data of tricuspid valve, or we are okay?
I think in everyday clinical practice, we can assess by echo very well the tricuspid valve, and I will insist on assessing also the RV function, LV function, and actually understanding the pathophysiology of the tricuspid regurgitation. I don't believe that in everyday clinical practice we need more imaging. But in patients that are scheduled or are for discussion for further interventional therapy or even surgery, maybe we need something more, but this is individualized. Maybe we need cardiac CT or even MRI in congenital patients for sure. But overall, I think that in everyday clinical practice, the transthoracic echo and transesophageal is good, except for individualization when we have to discuss for intervention or surgery.
Thank you very much for the presentation. Even if the tricuspid valve is anterior, and as you know, the transesophageal is very difficult to image, you had very good images for the transesophageal cases. I want to ask you, usually we have 3 leaflets, anterior, posterior, and septal, but there is also a classification, the new that you showed. In your practice, have you seen patients with more than 3 leaflets? Or maybe, are you taking into account into the anatomy the anterior papillary muscle in order to define which leaflets are you describing?
Yes, actually, when we assess a patient, we are not so focused on the tricuspid valve concerning the anatomy. So I don't think that we check with the transthoracic echo in detail the number of leaflets. It's a little bit hard. In transesophageal echo, we can distinguish the 3 leaflets or more, and we use the anterior papillary muscle for distinguishing the anterior from the septal leaflet, so it's like a guiding structure. But I think with the transthoracic echo, it's not like we focus on the number of the leaflets, because I don't think that it's of clinical importance. I think this counts when we need to do a procedure and we need to schedule the plan.
Thank you very much. Dr. Samarkati, please.
Thank you, Dr. Drakopoulou, for the nice presentation. I just have a couple of questions for you. First question is, do you depend a lot on multiplanar imaging during doing a TEER case, or like edge-to-edge repair, and do you think it will help, or usually mid-esophageal going back and forward and explain from the RV inflow is more reliable? And second question, have you encountered using ICE or intracardiac echo 3D in your practice, and do you think it's the new tool coming around the corner, or still there is a big room for transesophageal echo to stay in the game?
Thank you for the questions. We usually use the X-plane or the multi-D depending on the echo machine we have. And I think it's very good to see in 2 planes the tricuspid valve because we can be sure in which cusp we are, and it's very good. I prefer both the multiplane or even the 3D zoom when we go transgastric, so it's very good to have the 3D imaging. I think it's also for the mitral valve, but also for the tricuspid, it's very good, and we need to do it in TOE. Concerning the eyes, we only do TOE in our cath lab with Professor Ageli. We're in the first department of cardiology in Athens University. So we don't have a big experience with eyes, but I think that it's a promising technology. Maybe the next years, and if we put it in clinical practice, it can offer, I think, some advantages because we don't have to incubate the patient. And it's the limitation is that it's invasive. I mean, we need to put an extra catheter, so there is a limitation, but of course the patient does not need intubation, so this is a big advantage, I think. But our experience is limited. We usually use the TOE probe.
Very nice talk, I enjoyed it really. Just 2 points you already mentioned, I think it's worth pointing again, is that defining the mechanism defines prognosis, and we know that TR related to right ventricular dilation carries worse prognosis than RA enlargement and TR. And the same occurs with lead TR. If the lead causes TR, then the prognosis is worse because it's going to get worse throughout the years and needs more close follow-up, where if it existed before, then things are better. That's the one thing. And the second thing is obviously very crucial to define the morphology of the valve for the to decide which intervention is better for the patient.
Excellent talk. Congratulations. To the point that Dr. Sondos is making regarding multiplanar reconstructions, I think this is a way to go in the future, especially now that we have the transcatheter tricuspid valves. We use multiplanar reconstructions heavily, and that also helps expedite the procedure. And I think also for TEER, it's a very good tool to use because going into the stomach and back into the esophagus all the time can create injury to the patient. So for the sake of efficiency, we use multiplanar reconstructions a lot. For edge-to-edge repairs as well.
Yeah, that's a good comment. And I also wanted to extract from congenital patients that sometimes in our everyday practice, the subcostal views might give us in some patients a very good idea of the tricuspid valve anatomy. Not all adults obviously have clear subcostal views, but as you are there doing the IVC and see what the IVC is doing on inspiration, etc., if you do the subcostal short axis, you will get a view like the transgastric view that you showed very beautifully. And you may have this slim patient that has really very nice pictures. And when I do it in adults, they ask me, what are you looking in my abdomen? And they are not used to having this examination and this subcostal view. So it may be helpful. Let's try it in our everyday practice for the anatomy, but congratulations for your talk.
Thank you. So we continue with the last talk. Dr. Tsoumani, anatomical assessment of the tricuspid valve, CT findings. We need CT or we are okay with 3D?
Absolutely. So, good evening. I would like to thank the organizing committee for the kind invitation to talk about the important role cardiac CT has to play in the assessment of the tricuspid valve. And I would like to start by reminding us why we should consider cardiac CT in every structural heart disease. Echo is an exceptional tool, is the first-line tool, but sometimes it comes with limitations. For instance, in terms of acoustic windows.
CT can actually overcome many of these limitations. It has high spatial resolution, providing excellent anatomical and functional analysis of the tricuspid valve apparatus, highlighting its relationship to surrounding cardiac structure, while in the setting of tricuspid interventions, it can minimize procedural complication and exposure time. Cardiac echo is one of the pillars now of the multimodality assessment of the tricuspid valve. It can study the tricuspid valve morphology, measure the right heart, SVC and IVC, and allow a more comprehensive vascular assessment, and in this case, the venous assessment. By calculating the anatomic orifice area, we can have a semi-quantitative parameters of the tricuspid valve severity. To have all this information, we need at least a 64-slice CT, or ideally a more advanced dual-source CT or volume CT scanners that come with a larger Z-axis coverage and a shorter temporal resolution. We scan during the entire heart cycle, so we can have reconstructions every 5 to 10% of the RR cycle. The CT protocol involves an extended scout from the external auditory canal to lesser trochanter, paying attention not to miss the often enlarged right atrium, and finishes with an additional delayed, non-gated scan for venous access assessment. In order to have the maximal quality of the scan, and homogeneous and smooth right heart opacification is key, avoiding streak and beam hardening artifacts. We use not the standard but dedicated biphasic or much better triphasic contrast agent injection protocols that are based on a mixture of contrast and saline, and we finish with a saline flash. We can use the test bolus or bolus tracking with a technique with a region of ROI to be placed in many structures, ideally at the middle of the right ventricle, in order to avoid early or late triggers. However, in the vast majority of the cases, we need to assess the right coronary artery at the same time, so we have to shift to our standard thoracic aorta triggering to allow us for simultaneous right and left opacification. So, using multiplanar reconstruction, we can have dedicated right ventricular views in order to study the subvalvular apparatus, the papillary muscles, the chorda, the leaflets, and the commissures. We can even have cinematic images, and we can assess the regional wall motion abnormalities or the septal motion. In a similar way as we do with echo, we can even perform a volumetric analysis. And the values that we get with cardiac CT have been extremely validated and correspond to the ones that we get from the cardiac MRI. And this is important because the right ventricular ejection fraction assessed by CT or MRI is a important prognostic predictor in patients with tricuspid regurgitation. Using this volumetric method, we can have an indirect method of TR severity as per CMR by subtracting the left ventricular stroke volume from the right ventricular stroke volume, providing that we don't have any cardiac shunt or significant valve disease. And this may be helpful in patients with unfavorable echoacoustic windows when CMR is not an option. An indirect sign of TR severity is the early opacification of the IVC or hepatic veins. We can calculate anatomical surrogates for TR severity using cardiac CT. We can calculate the anatomic regurgitant orifice area during mid to peak systole or the tricuspid annular area during mid to end diastole. Using the MPR, the multiplanar reconstructions, with the plane through the tricuspid valve and through the right ventricle, we can have like a short axis view of the annulus, which is planar. We can do measurements here, area, perimeter, and dimensions. And we have to do those on both systole and diastole, as we know that the tricuspid valve is actually a dynamic structure and its area changes during the cardiac cycle. We have to bear in mind that actually the tricuspid valve is not planar, it's a 3D structure, a D-shape, saddle-shape structure. And CT can help us by giving us three-dimensional parameters. In order to do that, we use an indirect method, which is actually the same as we do with the mitral valve. We rotate the plane of the measurement along the RV plane, and we manually place seed segmentation points at the level of the anterior and posterior heads. Then we get this image, and then we apply a mathematical model, which is this red line, and this is actually the 3D perimeter of the annulus, which is then projected to the short axis, and then we can do new measurements now in both systole and diastole. And there is a high agreement between this indirect method as assessed by transesophageal and CT. We can apply the same technique to measure the gap, the tricuspid valve area. And studies have shown that this gap, as we measure from the anatomical regurgitant orifice area, as we measure for the CAR-CD, correlates very strongly with the vena conducta as assessed by 3D TEE, and moderately correlate with the right ventricular and right atrium remodeling. Oops. In recent years, especially with the evolution of the tricuspid valve intervention, cardiac CT has an additional role to play in selecting the appropriate patients for the interventions and by providing us accurate tricuspid valve size. There are different interventions that require different extra additional parameters to be measured, as well as the diameter tortuosity of the femoral, iliac, IVC veins. And although cardiac CT is not generally recommended to edge-to-edge repair and surgical tricuspid valve repair replacement, if we still have the data before, we can measure the tethering, height, area, angle, giving predictors for recurrent TR, or even help with the catheter angulation of the edge-to-edge repair during the procedure. Another example is when we have to use the spacer device, for instance, Forma here, where actually, we have to measure the RV size perpendicular to the tricuspid valve to the RV insertion point of the device, the height and width of the anterior papillary muscle, as well the diameters of the left subclavian vein, the left axillary vein. In terms of transcatheter replacement, except for the right ventricular and the right atrial measurements, we have to pay specific attention in the RCA on the right coronary course and the distance of the right coronary artery to the tricuspid annulus. A distance less than 2 millimeters is considered to be unfavorable, and because of the proximal implicament. With CT, we can provide the best fluoroscope views for procedural planning. For instance, the first one, which is RV, a two-chamber, can be used for the trajectory of the device through IVC in the right coronary artery. The second one, which is a three-chamber view, can help with the coaxiality of the delivery system. And the third one, which is actually a short-axis view, can assist with the coplanar deployment. Using dedicated softwares, we can actually simulate specific valves in order to have the precise size to prevent right ventricular outflow obstruction, as well as any paravalvular leak. If we are going for a heterotopic valve implantation, then CT can help by measuring the SVC diameters and areas at different levels from right atrium, the IVC diameter at the RA and IVC point, as well the height between the IVC and the first hepatic vein. Another important area is that cardiac CT can help is to understand the interaction of the leads with the tricuspid valve. However, this can be limited because of the significant blooming artifacts that from the leads, and echo might be would be better. We can use CT for the follow-up, especially when we have increased gradients through the valve. We can do 4D, functional 4D, to look for the how good the valve is opening and closing, to identify thrombus formation from leaflet motion. And we can use also 3D printing, which is an interesting area, as well as fusion imaging that may help during the procedure. In conclusion, multimodality imaging in the tricuspid valve assessment is key. CT is important tricuspid valve assessment, essential for patient selection and pre-procedural planning, while during the post-procedure course, it can investigate the causes of valve dysfunction. Thank you.
Thank you very much. Very comprehensive talk. I think that we have discussed all the strengths of cardiovascular imaging modalities in evaluation of tricuspid valve, morphological data for tricuspid valve and right ventricle, and all the other anatomical data. So, do you have any questions or?
Thank you very much for the presentation. The CT is ACG gated, right?
Yes.
So if the patient has atrial fibrillation?
Yes, with the advanced technology, with the newest card, it's not any issue. Mm-hmm. The most important thing is to have as high temporal resolution as possible. So beta blockers may be the key to that, to have as close as 60 beats per minute. But with the advanced, the dual source, or the volume scanner, this should not be an issue.
Okay, thank you.
Okay. So, a question? Okay. Dr. Nikas?
Yeah, hello, it's Dimitris Nikas from Ioannina, Greece. Just a short practical question. Sometimes we find difficulty to see if tricuspid regurgitation caused by pacemaker or valve defibrillator lead, it's the cause, or if it's caused the adhesion or puncture of the tricuspid leaflet. Do you think that this is the CT could help us more than the cardiography to find out what's the main reason? Because this is something, I don't know, I would like to have the opinion of the panel. This is really difficult for us sometimes to differentiate which is the main cause.
Yes, it can help. Sometimes, though, you can see actually with cardiac CT, with functional imaging, how the lead interacts with the commissure or the leaflet, and see if it is stuck there or not. but sometimes we may have blooming artifacts because of that lead, and then maybe echo is a much better choice. So generally yes, but it has its own limitations. You cannot predict actually from the beginning.
Okay. I would like to thank all the speakers, the moderators, and all of you. And we continue to the next.
Moderators and very known also lecturers. They will explain us many new proceedings concerning the forgotten valve, which is the tricuspid valve, which is not anymore forgotten. So, Kostas, we can proceed with your first talk.
Thank you, Aris. And you are away, I'm away. I'm forced to be away. I'm sorry about it. A sudden problem with the back pain forced me to be away from you, but I'm very glad that the Congress is going very well attended, and I'm glad to participate at least online. So I start the presentations on the tricuspid valve with tricuspid tear, which is edge-to-edge repair, Transcatheter edge-to-edge repair. But like many suggest, we should change this terminology and we should say body-to-body repair, because with these clips, we don't just bring the edges together, but a large part of the body of the leaflets, we bring them together. Anyway, this is under discussion whether we should change this terminology. And when we are talking about clips, it was the only available transcatheter therapy practically till a few months ago. And then suddenly we have the first transcatheter valve, the Evoke, that is now available. So it's not the only kid in the block, the clipping anymore. But this is the most widely available, and I'm sure it will be very widely available for the coming years. I don't think it will ever become like a secondary approach. Disclosures and the heart team were working together at the year. So what we have for the tricuspid valve, we have the TriClip and the Pascal. The TriClip is both FDA and CE marked. The Pascal is CE marked for now. And we have the Intrepid, which is both CE marked and FDA approved. And we have the heterotopic tricuspid valve replacement, which is the trick valve that is CE marked. So these are the available therapies, transcatheter therapies for the tricuspid valve. And this paper by Fabienne Praz put very nicely the algorithm of treatment depending on anatomical and clinical characteristics. And we can spend some time to review this algorithm to understand which therapy is best for which anatomy. So we have now the TriClip and the Pascal devices that we're using for the transcatheter body-to-body repair, as I said, to the tricuspid valve. And we can assess here nicely the differences between the two. So the TriClip opens and closes very firmly. It's like a vice grip, so it doesn't allow for any movement once the clip is inside, and clips clings very strongly. And on the other hand, we have the Pascal that is nitinol, so it has some elasticity and allows for some movement of the leaflets. So this is the Pascal generation 2 we're using now. And you can see that the other difference is that the retaining elements of the Pascal are all down here. So they're like a line of burbs here, whereas the retaining elements of the TriClip are along the grippers. So this is a small difference, a small detail that may make some differences on how they work. And these are the sizes of the different devices that we have now available. So you see here the small TriClip, the NT, it has a span of 20 millimeter, and the large has a span of 25 millimeters, and this dimension is very important because it shows how much we can go behind the leaflet, how big the reach can be of these devices. And then for the Pascal is 26 millimeters, so 1 millimeter more for both of the devices. And then we have the width. The width for the TriClips is 4 or 6 millimeters for both the short and the long, 4 or 6 millimeters. And the width for the Pascal is 6 millimeters for the small and 10 millimeters for the large. The other difference is how much of leaflet they can get inside. So for the tricuspid valve, practically we only use the Pascal Ace and the TriClip, the XT, the big one. So if we can put them together, we see that we can get 10 millimeters of leaflet within the Pascal Ace, but once the leaflet goes in, all the retaining elements, they grab it. And we can get up to 12 millimeters of leaflet in the XT. But how many barbs will be on the leaflet, it depends how deeply it will be inside. So if it's 6 millimeters in, it will get only 2 or 3 barbs. And what we have on clinical trials, we have the TriLuminate pivotal trial that randomized 350 patients. At least this is the report on the 350 patients. In practically, they randomized, as you can see, much more patients, close to 300 patients, but this analysis is for the 350. They also had a single-arm cohort that they accepted patients that wouldn't be accepted in the randomized trial, so anatomies that they thought the result of the TEER wouldn't be perfect. So those patients, they accepted into a single arm. And this is the algorithm of the study. And you can see here that from the 1,500 patients, the 350 only got randomized. So this is a small percentage of patients. The other patients were excluded mainly of anatomical reasons, but some of them, 100, that they thought that they could have some procedure, they went in the single arm. So when we talk about this study, we shouldn't forget that only a small fraction, like 20% of the patients screened were actually randomized. This is very important. And these are the results. The results, there was no difference in the all-cause mortality between TEER and control. There was no difference in heart failure hospitalization. All the difference were in the quality of life improvement, more than 15 points improvement in KCCQ score. And you see here there's significantly more in the TEER arm than in the control arm. And this was a component of the endpoint. That's why the primary endpoint was positive. As you can see, the win ratio here, 50% more likely to have a better outcome if you have TEER than optimal medical therapy. And you can see here that we had like 88% success in the reduction of the TR with Ryclib to moderate or less. And all this with 2.2 clips per patient on average. So more than 2 clips, 88% reduction. But if we see the single arm, you remember those that they thought that the anatomy wouldn't be very good, perfect for TEER, and then you see a 10% drop in the success of moderate or less compared to the RCT study. And it's important also from this study, we saw that the more reduction we have in the TR, the better the improvement in the quality of life. So there was a mechanistic connection between the two, which is very important to see. And the number of patients you need to treat to get a patient alive and well more than the medical treatment is 3.5 patients to get one patient better. And on the other hand, we have the Pascal with the TriCLASP study, the initial study, 6-month results, very similar, 88% improvement to moderate or less, exactly the same with TriClip, but with less devices per patient, 1.75 as you can see. This is the respective study similar to the TriLuminate, the CLASP-2 TR trial that is completed and will be reported soon with 800 patients randomized to Pascal and optimal medical therapy or optimal medical therapy alone. And we already have a report of the 3 first patients per site in the roll-in of this study. And we see here at 30 days, 74% had a TR moderate or less, which is considered a successful improvement in quality of life and symptoms, with a mean number of devices 1.5. So there is a difference, less devices when you use Pascal than when you use TriClip. And if we get together with the randomized trial, all the registries we have, the BRIGHT, TriLuminate registry, pivotal, we see that we have a consistent TR reduction across TriClip to 71 up to 88% moderate or less. And similarly, if we get the registries of the Pascal, you will see that similarly we get exactly the same number, 71 to 88% moderate or less. So good reduction with both technologies. And what is clear now is when we use these devices in the tricuspid valve, we always go for the larger ones. So you see in the BRIGHT registry, only the large TriClips were used, XT and XTW. Similarly, in the PASTE registry with the Pascal, you see 93% of the cases, the Pascal ACE was used only. So it's very clear now what devices we use there. And as I explained earlier, It's very important for the tricuspid valve. Two things for the devices. First, how far away they go, the spanning of the device when it's fully open, and how much of leaflet you get inside. Another important issue for tricuspid TEER is the single leaflet device attachment that is much more frequent than in the mitral field. You see here in the BRIGHT registry, in the TriLuminate study, proportions 3.7 to 7%. This is a quite big problem when you have it. And similarly with the Pascal device in the CLASP study, it was 4.8%. So it's easier to lose a leaflet in the tricuspid valve than in the mitral valve, and we have to remember that. What is complex or unfavorable morphology? A large gap size, certainly. TR that is not central or anteroseptal. Multiple leaflets, more than 3. Very large tricuspid annulus, large dimensions of the ventricle, of the atrium, torrential TR, tethered leaflets, and of course pacemaker leads. This is a gap, as you can see, it's a huge gap, so no device has the span to reach and to close this gap. Sometimes we can reduce this gap by prehabbing the patient, by diuresing the patient. You see an example of this here. It starts with a large gap, and after diuresis, this becomes much less and amenable to TEER. It's also important how we measure the gap. You can see there are many ways to measure the gap. Some are correct, some others are exaggerated. It's very important to remember, but by just tilting the patients, we change the fluid balance and distribution into the body, and we can reduce the dimensions of the gap by 25%, as we can see on average. This is important to remember. And from the screening from various literature, we can see that approximately 30% of the patients referred to us for TEER are rejected because of morphology, anatomy, or pacemaker leads. So 30% initially, they're just off. And then there is this study that they created, the TEER score. They take into account all these negative and disadvantages factors for TEER, and they created this score. So if the score is 6 or above, the possibility to have a very good result, it goes considerably down. And you can see that we have a very good discrimination by using this score, who will go well and who won't. So if we match together, if we add together the 30% of the initial rejection, the 20% that is not going to have a good result after applying this score, we understand that approximately 50% of the patients we're seeing today for TEER, it's good to be directed to another therapy, and that's why the TTVR is here, and probably that will be the final distribution between the two therapies, clipping and valve. It will be around 50-50 for these reasons. So this is an example of ours, but you can see a very large gap, very torrential regurgitation, and you can see this gap is close to 2 centimeters, so there's no way to get it done with TEER, and these patients should be screened for EVOQUE. And I will finish my presentation by just showing a procedure with TEER that we use 2 Pascal ACEs. You see a complex anatomy with regurgitation going from everywhere. The vena contracta is from anterior to posterior. You also see a pacemaker lead that is in the posterior septal commissure, as you can see here. We have a gap that is less than 1 centimeter, as you can see here in the center. We don't believe that the pacemaker wire is responsible for this pathology, at least fully responsible. They may have a contribution. That's why we accepted this patient for the procedure. We knew that it would be challenging. So here is the first Pascal ACE coming below, the first clasping, it's easy. It's towards the anteroseptal commissura. We move more into the anteroseptal commissura here. We do the independent clasping here. You see the falling of the septal clasp. The lateral clasp is already in. Then we close the device, and we have a reduction of the color from the area of that device. We knew that it would be a multiple device procedure, so this is the second Pascal ace coming, and just lateral, more posterior, and or towards the center, in comparison with the other one. Again, the independent clasping, first the lateral, and then here you see the falling of the septal clasp, and then we close the device, and this second device made the trick, and this is always the case. The more you go towards the center, the more the effect you have with the device. So we had a very good result with these two devices, and we accepted this minor mild TR for a very good result. And this is a procedure we used for the first time, the 4D ICE Accuson by Siemens, that we found very, very useful. And I'll just finish by showing you some images from 4D ICE. So initially, we went into the mitral valve just to have a look there, and you see how good imaging you can have by using the 4D ICE. We started with the mitral valve first. We had to do a clip there. That's why we crossed, but we did it with transesophageal. But this is the imaging we got, and I'm sure if we had the problems and we couldn't use transesophageal, we could use this imaging also for mitral clipping. So after finishing with the mitral clip, we went with the Pascal in the tricuspid valve. You see the imaging for the eyes, how nice it is, very clear imaging with the leaflets. So here the Pascal is below the leaflets, and you see the leaflets resting on the paddles, and then you see it is retracted upwards, and you see the falling of the clasps here, and then you'll see the closing of the device. We had to move it to a better position. That is the first device. If you remember, we moved more into the septal commissural, and this is the result with the first, and here is the second device, next to the other one, the closing of the device. And you'll appreciate that we had a very good result with these two devices without any interaction with a pacemaker lead, and this is the final result. 1 Pascal ace in the mitral valve, concomitant treatment of both valves, and 2 Pascal aces in the tricuspid. And this is from another procedure in another patient, just to show you what kind of imaging you get from 4D ICE. You had a discussion about 4D ICE earlier. And I think it will be very useful in the future because it gives you the possibility to do tricuspid procedures without intubation and general anesthesia. You get this kind of imaging that is unbeatable and very helpful. And with this, I would like to thank you for your attention.
Thank you, Kostas, for this excellent presentation. May I ask to Dr. Nikas what is his input on and his experience?
Good evening from Athens. This is really an amazing representation of what we can achieve today with the new devices we have in order to reduce tricuspid regurgitation. And I'm very happy to see that it's not anymore a forgotten valve. Actually, I don't ever believe that it was a forgotten valve, but we didn't have any tool in order to tackle this kind of disease. And we can see all these patients coming into our hospitals every week, every month with this congestion, and we couldn't do anything else that give them diuretics. I think this is a very promising treatment for all of our patients. We have done a couple of cases in my hospital, and we've seen really good results. And my worry now is, and Mihalis is sitting beside me, and I would like also to ask him which is the phenotype. Every week I'm checking the literature. Nowadays we can see a different type of phenotypes in tricuspid regurgitation. And I would like to ask also, Kostas, what is the preference, one device over the other, in terms of phenotype, whether this is going to be an annular dilatation causing by, let's say, atrial fibrillation, or an annulus dilatation causing for RV failure? Is any device better than the other in this case? And is there any data comparing the two devices? What do you think?
Michael is here. Let's ask Michael first.
That's a very good question. At this point, there's no data comparing TriClip to Pascal for treating tricuspid regurgitation with edge-to-edge repair. I think it's more of a preference depending on the operator and their familiarity with the devices. We could argue about one or the other, generally speaking, but I think it's more of a preference based on operator experience. For the fact about atrial functional TR, I think for atrial functional TR, usually we don't have that much tethering of the leaflets towards the ventricle. They sort of close at the level of the annulus. So technically speaking, they appear to be rather amenable to edge-to-edge repair. For ventricular functional TR, Dr. Spargus showed it very nicely. We have long, big gaps and very tethered leaflets, then things become very difficult sometimes. But in these patients now, we have the option of a valve, and we always have to really consider carefully whether we would proceed with edge-to-edge versus a valve, because maybe leaving a moderate tricuspid regurgitation may not be the bar for success that we would like to see nowadays or moving forward. Thank you.
Yeah, I agree with Michael. My view is that we can get very good results with both devices. All the studies that I've shown to you and the registries demonstrate very, very similar success. So it depends on the experience of each center and of each operator. In our hands, we have a preference for Pascal, especially in the tricuspid valve. The reason is that because of its design, it's nitinol, it's much more forgiving for movements into the right heart, for movements under the leaflets, and because it elongates, and in the tricuspid valve, you very often need to come back and in again. So this elongation provides, I think, larger safety to do this device in the mitral valve. The other thing is that with Pascal, there is no limit to how many times you're going to open and close the device. You're not injuring the leaflets, especially the tricuspid leaflets that are very flimsy. With mitral clip, TriClip, every time you close it and you open it, you are more aggressive on the leaflet. So I don't think there is it's limitless how many times you're going to attempt on the leaflets. With Pascal, we don't have this problem. You can try many times. Now, the other thing, I think that the tricuspid valve is a very different animal from the other valves because the symptoms are very elusive, and you have to make clear that there's no other underlying pathology responsible for the symptoms. And many times when we see patients with advanced tricuspid regurgitation, this is just a sign of poor prognosis. And we have to be very careful when we decide to treat the tricuspid regurgitation first, that the etiology of the symptoms is this and nothing else. And second, that it's not just a surrogate or indicator of bad prognosis, and in those cases, any intervention will be futile in the tricuspid valve.
Kostas, on this, on the last topic you mentioned, could we imagine that you intervene before us, the surgeon, in a patient that he is much in a better condition, and then doing the Pascal or TriClip, and then if things deteriorate because the regurg relapses or isn't completely done because of the annulus enlargement, doing it endoscopically, just inserting or implanting a ring and leaving in place the tri-clip.
You're absolutely right, Aris, because if we do edge-to-edge repair and we fail for some reason, then we close the rod or we make the rod very treacherous for you to go and be successful in repairing, or for a transcatheter valve to go and implant it. So that's why now that we have available the transcatheter valve, and of course surgery is always available, we have to be careful when we select patients, and we shouldn't attempt on patients that the anatomy is unfavorable for success. So those patients, especially if they're younger, should be directed to surgery, no question about this. And if they're older, then we should think of transcatheter valve like Evoque first. Another therapy that I think is forgotten and underused is the transcatheter annuloplasty. The Cardioband is out there for some years now. It's not very successful so far, but I think it's another good transcatheter option that leaves everything open for the future. So if the anatomy is good, to go with a Cardioband and do transcatheter annuloplasty at an early stage. If it's successful, everybody's happy. If it's not very successful, nothing is like everything is available as an option in the future, both transcatheter and surgical. But I think that's why when we treat these patients, we need to be a heart team and discuss all these cases with you guys, the surgeons, that we have a lot of experience in the endoscopic, thoracoscopic repair, because you can also get very good results. And so that's why we should be very careful when we select these patients.
Should we proceed with Dr. Rahul Sharma? Dr. Sharma, are you on the panel?
I am.
Hello.
Hi. Okay. I hope you can see my slides.
You are on the screen, at least for me is...
Perfect.
Okay.
Well, thank you. Good afternoon, everyone. I'm sorry I couldn't be there in person. I too am traveling. I'm actually in Prague at the moment on my way to EuroPCR, but nevertheless, thank you for the kind invitation to join. My role today is to speak to you about transcatheter tricuspid valve replacement as a nice segue from the prior talk on transcatheter edge-to-edge repair of the tricuspid valve. These are my relevant disclosures. So I think it's important to appreciate that there are a number of challenges with respect to the tricuspid valve, and some of these were identified in an earlier talk on imaging and certainly in the last talk on edge-to-edge repair. But some of the challenges we face and hence impact the procedure and also the choice of device, or the position and size of the regurgitant jet or jets, as there may be multiple, the number of leaflets, and I've never been so struck by how many quadricuspid tricuspid valves there are until I started working in the tricuspid space. The presence of pacemaker leads, the various shape and size of the tricuspid annulus, the variable and complex leaflet anatomy, particularly when they're tethered leaflets, especially the septal leaflet, which can be quite difficult to capture. And then, of course, the proximity of the conduction system as well as the coronary arteries. And I think the etiology of the tricuspid regurgitation is also important, particularly when it comes to selecting devices. At least in the United States, we now have commercial approval for the Abbott tricuspid clip. The CLASP TR of the Pascal device, CLASP TR trial is still ongoing. And then, of course, we now have commercial approval of the Evoque replacement valve. And so there are some choices, and the choices are only going to increase. So it's important to understand the etiology, which might help determine which device is more suitable for which patient. For example, patients whose annulus is far too large for an edge-to-edge repair may be better suited to a transcatheter replacement. Similarly, patients who have multiple jets or complex leaflet pathology, which would preclude them from having edge-to-edge repair, may be better served with a replacement. And then conversely, there are a number of patient and anatomical factors which we'll get into, which may preclude a replacement device. We're all familiar with the newly proposed classification system. As I mentioned, I think this is something we're seeing as we look at more and more of these echoes. I think this is more important for the edge-to-edge repair, particularly these quadricuspid valves that have divisions or scallops of the leaflets. But I think even it's just as important for the replacement devices where you've got multiple jets involving multiple leaflets that may be more complex and challenging for edge-to-edge repair. The idea of this expanded classification system of severity is quite interesting, and based on some earlier data that showed us that even when you had a reduction in TR and an improvement in clinical symptoms, the overall TR grade based on current conventional echo criteria would still say that the TR was severe. So you were taking patients from severe to severe with no delta on their echo report, but yet there were clearly improvements in RV volume, in overall TR, and importantly, how patients were feeling. And so that was really the platform for this proposal to introduce the gradings of massive and torrential. Again, I think seeing a reduction from torrential to massive or severe is something we see more on the edge-to-edge space. When we're dealing in the replacement space, it's a much more drastic amelioration, if not complete mitigation of the tricuspid regurgitation. We heard a great talk on imaging, and I think the role of imaging in the tricuspid valve cannot be understated, particularly CT in the pre-planning phase. Of course, transesophageal echo still remains the gold standard for intraprocedural imaging, although we have been using ancillary intracardiac echo, not so much to guide the positioning and trajectory of the device, because that can trick you, but more for ensuring leaflet capture, particularly when there's shadowing of the device under TEE. So I'm going to speak about two valves, predominantly focusing on the Evoke valve. I'm not going to speak so much about valve and valve and ring. I think we're all familiar with the expansion and use of the aortic devices in the tricuspid space, but really about the dedicated devices for the tricuspid valve replacement. So this is the Intrepid valve. Currently, it's a 35 French system and it's EFS. There is a newly designed and developed 29 French system that we hope to see in the near future. This is a very similar device to the mitral Intrepid device, which is part of the Apollo trial. So you can see this flexible brim there, which is within it is housed a valve that's 26 millimeters across, so it's all one contiguous device, and it's deployed in a top-down fashion. So the capsule enters the right ventricle, and then the valve is unsheathed. You can see the brim unsheathing here. The brim sits on the floor of the RA, and then the valve is deployed intra-annular, and you can see those small fixation tines there, which adhere to the tricuspid annulus. For those that have had experience with this device in the mitral position, it's a very elegant, very seamless, straightforward device, and so that trial is currently underway. Some of the elements of this study, so classic study design, heart team assessment. This is for symptomatic severe TR, so not moderate, but severe and worse. They obviously have to have adequate transfemoral access. But I'm going to focus here on the Evoke device just because it's been commercially approved and we have the most experience with it. So this is a very interesting valve design, has these atraumatic anchors. So converse to the Intrepid valve, which deploys in a atrial to ventricular fashion. This is more from a ventricular to atrial fashion. This got this conforming frame, which is designed to achieve this retention force of the leaflets. And the mode of retention of this device is twofold. One is the radial strength that's outwards towards the tricuspid annulus, and the other is the entrapment of the native leaflets within those anchors. And that ensures that the valve stays in place. There are multiple sizes that offer a broad range of treatment across pathologies. The approval is for every size up to 52 millimeters. The 56 millimeter device, which is the largest size, is currently not commercially approved. It's still only available through a continued access scheme, simply because the 56 millimeter device was introduced much later in the study. And despite the 56 millimeter device, we're still seeing a not insignificant proportion of patients who are excluded because they have an annulus that's even larger than what would be treatable by the 56 millimeter device. So this is how the procedure works. It's a transfemoral transvenous access, 28 French outer Dana delivery system, and there's 3 planes of movement of the device. There's a primary and secondary curvature, which allows you to maintain coaxiality. It's delivered over an extra small Safari stiff wire, pre-curved wire that sits in the right ventricular apex. And then the valve is slowly unsheathed in stages under very careful guidance with both fluoroscopy, but mainly transesophageal echocardiography. until the valve is fully deployed there. You can see with the ventricular aspect where the leaflets are housed within the device, and then the atrial aspect. So let's go into some of the data. This was quite impactful earlier this year. So this is the TriScend 2 study, building off the TriScend 1 study, which was for moderate and severe tricuspid regurgitation. This was severe. And so this is a randomized study. And you can see here the primary endpoint of safety, effectiveness, and then this hierarchical composite of additional outcomes at 1 year. And so this idea of a breakthrough pathway cohort is what led to this early FDA approval. And so the safety endpoint was met at 30 days, and a 6-month effectiveness endpoint, which was based on the TR grade reduction to less than or equal to moderate, and then a composite of an improvement in their KCCQ score, NYHA class, and then 6-minute walk distance. Meeting both those primary endpoints is what led to the FDA approval. There was also some data from the full cohort in terms of what 1-year data was available that was also presented. But the full cohort 1-year data is going to be presented at TCT later this year. So these were some of the patient characteristics. You can see there the medical therapy group versus the intervention group, very similar across both patient characteristics, comorbidities, and phenotypes. The degree of tricuspid regurgitation, you can see here a significant proportion of these patients were graded as having massive or torrential TR. So there certainly was a tendency in this study to put patients in compared to, say, some of the patients in the edge-to-edge repair with more significant degrees of TR. All of these procedures were done under general anesthesia, very successful implant rate. The procedural time was actually quite reasonable considering the learning curve with this device. So, on average under 2 hours. And the device time, which is when the device goes into the device delivery system coming out, was just over an hour with about 30 minutes spent on fluoroscopy. These patients do tend to stay in hospital a little longer. I think we're learning still how to manage these patients and how critical it is to look after them in the peri and postoperative period. It is the idea RVP coupling or uncoupling, impact change in both patients in terms of their RV function. So keeping an eye on their volume status as well as their conduction afterwards is very important, and part of why we keep these patients in hospital for a few extra days. So just going through the safety endpoints, this is at 30 days, the composite major adverse events. Mortality was quite low, no strokes, there was no need for dialysis. Bleeding was really the biggest driver. These patients do need to be on at least 6 months of anticoagulation. And so the bleeding rates we're seeing come down now, but I think probably related to access site bleeding because of the large venous sheath and the fact that either a lot of these patients are already on anticoagulation for atrial fibrillation and the remainder needing to be started on anticoagulation. So that's certainly a consideration for patients who may not be appropriate for the Evoke device, are those that cannot tolerate any anticoagulation. Arrhythmias requiring pacing, another, I think, Achilles heel of the transcatheter replacement. Hopefully we see these numbers come down. We've been very aggressive with the degree of oversizing that we use just to ensure that there's very little PVL and, of course, no migration of these devices. But I think similar to what we saw in TAVR, we hope that these rates will come down as we get a better understanding of sizing these devices and therefore having less oversizing without trading out rates of PVL and embolization. This is just a breakdown of the bleeding events here. You can see none of those bleeding events were fatal, and most of them were related to the device or the procedure, and as I mentioned before, mostly due to the access site. So what about the effectiveness? And that was, as I mentioned, moderate or less TR. So you can see here there was quite a drastic reduction, as one would expect, with replacing the valve versus an edge-to-edge repair. So all of these patients basically had down to mild, moderate, none or trace TR, and that was, a sustained result out to 6 months, and obviously a drastic difference compared to medical therapy alone. In terms of the composite of how these patients felt in terms of their scores, so you can see here again, this is a win ratio similar to what was presented in Triluminate. So a significant improvement in their KCCQ scores demonstrated by a delta of more than 10. The NYHA had to improve by at least 1 class to deem an improvement. You can see there was a 20% improvement in the Evoke plus medical therapy versus just 2% in the medical therapy alone. I think importantly, a lot of the patients that we saw who were referred for this therapy were those in whom medical therapy had clearly failed by whichever metrics you judge that. And then there was a small proportion of patients in whom medical therapy was not tolerated, either due to renal dysfunction, hypotension, or some sort of adverse reaction to mostly their improvement in 6-minute walk distance was not significant between the two groups, but overall, clearly a significant improvement with the cumulative improvements in KCCQ, NYHA, and 6-minute walk distance with EVOKE plus medical therapy compared to the medical therapy alone. And again, this is just showing the delta between those two, and you can see there the NYHA class driving most of that difference, as did the KCCQ score, but not a big difference on the 6-minute walk. In terms of changes in morphology of the right ventricle and IVC, there were changes in the right ventricular end diastolic diameter out at 6 months with the EVOKE group, so already some signs of positive remodeling. As we know, the right ventricle is quite responsive to changes in preload. So when you take away a lot of that, there's a reduction in preload, you expect the ventricular volumes to decrease, unless, of course, the right ventricular dysfunction is significant. But importantly, patients who had worse than moderate RV dysfunction were excluded from this study. The right ventricular fractional area change, you can see there was a improvement based on the EVOKE device, and also longitudinal function. And TAPSE is obviously a surrogate for the RV function and an important component of when we're assessing for RV coupling. The relationship between the right ventricular function and TAPSE is a surrogate of that, as well as PA coupling. And what we've seen is that the patients who have preserved RV-PA coupling, that is the right ventricle's ability to respond to changes in afterload, mainly derived from pulmonary artery pressure, is a marker of adverse outcomes. So when you've got preserved RV-PA coupling, your clinical outcomes are good, versus if you have uncoupling at baseline, that usually reflects an inability of that RV to respond to those changes in afterload that we're going to see once you take away that pop-off of the TR. Pulmonary artery systolic pressure, not a meaningful clinical reduction, but nevertheless trending in the right direction. And then importantly, the gradients were elevated slightly, as one might expect with this device, but certainly not to a level which is of any clinical significance. Remembering again, these patients are placed on at least 6 months of anticoagulation. Obviously, we will need long-term follow-up to ascertain whether there's any issues with leaflet thickening and thrombosis, as we've seen on the left side of the heart. Stroke volume improved. Of course, there's now more forward flow. And in turn, there was no reduction in the left ventricular outflow tract cardiac output overall. That was maintained. There was a slight increase, but no significant difference between the medical therapy and the EVOKE groups. So this is the data from the full cohort. Not all of the patients were available. Roughly 300 patients' data was available for this. This is the 1-year endpoint of mortality, the need for RVAD implant or transplant, the need for surgery or reintervention of the tricuspid valve, heart failure hospitalization, and then the other metrics based on patient scores. And so these are what was the data available. So 250 patients, or nearly 250 patients available. By the time visits were completed, 220 patients. And this is just showing, again, a significant improvement across all of those hierarchical endpoints, starting, of course, with all-cause mortality for the patients in whom the follow-up was available. But again, the caveat being this is not the whole group. There's a favorable trend towards mortality, but I think it's definitely too big a statement to make that there is a mortality benefit here, but at least the numbers are trending in the right direction. The rates of heart failure hospitalization, slightly less. And then, of course, the need for tricuspid intervention. We didn't see a significant increase there with the need for intervention. This, I think, is distinct from what we see in edge-to-edge repair, where not infrequently these patients need to come back either because of significant residual TR or worsening TR and the need for additional devices. We're not seeing that. Once the index procedure goes well here, their TR is gone, and so you would not expect there to be a need for reintervention or surgery. The early results that we saw at 6 months in terms of the improvement in KCCQ, 6-minute walk distance, and NYHA are certainly sustained at 1 year, and arguably a more magnified effect of those early changes we saw at 6 months. So in conclusion, based on the results of this led to FDA approval. The safety and co-primary effectiveness endpoints of the breakthrough pathway were certainly met with an acceptable safety profile, although I still think there's work to be done in terms of reducing bleeding and the rates of pacemaker. Clearly, it's an improvement over medical therapy alone, but I think we're still learning a lot about which patients to treat and what is too early and what is too late. I think, like any technology, goes through these cycles, and I think that we're out of the trough of disillusionment when it comes to the tricuspid valve, and I think we're entering the slope of enlightenment, but we still have a lot to learn before we enter the plateau of productivity. And so very excited to see what the 1-year data from TriScend is at TCT. And we obviously didn't have the scope to talk about some of the other therapies looking at other parts of the tricuspid valve, such as annuloplasty. But I'll end there and very happy to take any questions. Thank you. Dr. Panos, I think you're muted.
Dr. Sharma, can you hear us?
I can hear you, but I think,
Yes.
there we go.
Okay, yeah. Thank you for those amazing news. And I would like to ask to Dr. Ziakas in Athens to comment on what he is thinking or his experience, already experience on the Evoque valve in Thessaloniki.
There's very little experience in Thessaloniki with this valve, but I think the presentation was great. And everybody would like to ask one question to Dr. Sharma, as he's, I think, a guru in this topic. So I would like to ask Dr. Sharma to do a prediction in 5 years' time, as the technology in the valve is evolving. How many patients will go for repair? How many patients will go for valve replacement?
It's a great question. I think there's a couple of factors which will determine that. I think, as I mentioned, anatomy and the ability to deliver the valve is a big predictor. Of course, we all love the idea of getting rid of all of the TR. That makes the most sense. If we had a choice between reducing versus completely mitigating, I think we would all choose that. But we have to be careful because, as I mentioned, I didn't have time to delve into it. This idea of RV-PA coupling is something we're getting a better understanding of. And Becky Hahn has done a lot of work on trying to look at echo parameters to predict which patients will fare well. We know that replacement has a bigger impact on RV dysfunction, particularly valves which are oversized, the impact on the basal RV in terms of reducing function, they take a bit of a hit. And that sudden change in preload and the corresponding changes in afterload, if you have an elevated pulmonary artery pressure and the RV, there's a threshold at which the RV can no longer compensate. And so in those patients, perhaps it doesn't make sense to replace their valve, and perhaps an edge-to-edge repair with a reduction is a more appropriate solution. I think the ability to take long-term anticoagulants is important in replacement. The bleeding rates are not insignificant. So I think that while the gestalt would be to replace all the valves, get rid of all the TR, I think the anatomy, and we didn't go into the right ventricular space, the ability to gain height, these devices are quite large, will really dictate, along with patient comorbidities, including RV function and ability to tolerate anticoagulation, what proportion of patients will go, to which camp. The other thing is that, I think we're all very comfortable with edge-to-edge repair from mitral experience. I think a lot of people were underwhelmed with the results from Triluminate and argued that, what's so impressive about a win ratio driven by an improvement in KCCQ? The counter argument to that is that if a procedure has the safety profile of edge-to-edge repair and results in a symptomatic improvement for those patients, is that an adequate threshold? And I think that's a reasonable argument. If those patients feel better with a procedure that's safe, timely, doesn't require anticoagulation, then perhaps that is an appropriate bar. So, I can't give a number, but I just think that these are the things I'm thinking about in terms of now and in the next 5 years, where patients go in terms of which therapy.
Dr. Sharma, thank you. Yes, excuse me.
Ro, Mike Reardon, how are you? Very nice talk.
Oh, hey, Mike.
So, Ro, two really interesting things I wanted to ask you about. One was, the mortality curve is very interesting, not surprising. It's a little higher to begin with, more invasive, but it's really coming down. It makes me wonder, how far would this have to go down as far as long-term mortality before you think it'd be reasonable to randomize against clipping? be hard to do it right now, but what kind of results would you want to see at 3 years or 4 years from EVOQUE before you'd say, well, maybe it should randomize and see how they do?
Yeah, I think that's a really good question. And I think we do need longer term data because I think that the RV remodeling, takes a little bit of time. We need to see where these patients settle out. I also think we need to understand whether 6 months of anticoagulation is enough. We've had patients in whom we've stopped their anticoagulation after 6 months and, they develop leaflet thrombosis. So that's an issue. And what's the impact of that going to be on mortality? So I think that we would have to see the mortality rates, the difference rather between the replacement and medical therapy alone come down. I think probably another few percentage points before it makes sense to say, okay, that there's an unanswered question here in edge to edge. I think the other question is, where is their equipoise in terms of the patient phenotype, in terms of anatomy, as well as some of their other comorbidities. And I think that's, it's going to, if we do that trial, it's going to be important to get that trial design spot on in terms of making sure it's a fair randomization.
Dr. Sharma, I have a question for you. Is there how we can deal with a pre-existing pacemaker lead? Isn't a contraindication or has nothing to do? And the second question would be, yes.
No, go ahead.
And the second question would be is there any application in the rheumatoid tricuspid regurg or the carcinoid regurgitation?
So the first question about the pacemaker leads. The pacemaker leads were certainly not an exclusion for EVOQUE, and they aren't now. I think what's important is that the presence, location, and amount of slack on the pacemaker lead does not preclude the ability to deliver the device. In certain cases, there might be risk of course, fracturing the lead, but more commonly in displacing the lead. And in those patients who are 100% pacemaker dependent, it's important to have an appropriate backup plan. Obviously, you don't want to traverse the new valve and place another regular RV lead. So the options really are a micro-leadless pacemaker or coronary sinus lead in that situation. Primary prevention ICD leads, again, are not an exclusion or contraindication, but secondary prevention ICD leads at this stage are understandably. But the other issue is, of course, the shadowing and the issues you get with imaging in addition to trying to get around the lead in a mechanical fashion as well. Your second question about rheumatic disease or carcinoid, there were some carcinoid cases done early in the EFS experience and a couple, I think, in compassionate use. I don't recall, I'm not sure, to be honest, about rheumatic disease, but certainly those patient phenotypes were not included in the main study.
Dr. Mack?
Thank you very much.
So, Rahul, great talk. This is the other Mike from Texas, Mike Mack.
Needs no introduction.
So let me be a little bit of a skeptic here for a minute. I think we have two devices that have been approved by breakthrough device designation. One, you could argue, is safe but not effective. The other is effective but not safe. And so if you just look at the triluminate or TEER, you got 50% of patients with moderate or greater residual MR at the end of the procedure. You've got EVOQUE with a 27% major complication rate and a 70% screen failure rate to begin with. And now these are all in expert centers. Now we're about to unleash this in the United States. So do you have concerns about that? And how would you undergo, should we say, the term that was used for TAVR, rational dispersion of this therapy?
So I agree completely with you, Mike. And as someone who proctors both devices, I am concerned. As you know very well, the balance between what is clinically judicious and what is commercially viable is difficult to achieve. We have conflicting priorities. And I think it's important that we don't rush into this therapy. And I think one of the questions that was raised was, did the FDA rush into approving these therapies? And I think it's a reasonable question to ask. For me, I think the big issue is, so one, yes, I think we need to be very judicious in terms of where these go, because it's not even just about expert operators. It's about expert imagers. It's about expert pre-planning. It's about expert management of these patients. You know, a lot of them that we see in clinic, you realize, weren't appropriately tuned up before they were even sent. So I think to suddenly jump in and start putting devices in, you know, we learnt this from COAPT on the mitral side. It's important to make sure first and foremost that we manage these patients, because the vast majority of these are functional. And so a lot of them do and will get better with medical therapy. We've just got to make sure we pick the right patients who truly have failed medical therapy. And I think the other issue is we need an annuloplasty solution, because we won't need to repair or replace the valve in the vast majority of these patients if we can find a suitable transcatheter annuloplasty solution. Now, easy for me to say. The engineers are obviously having a lot of difficulty to deliver us a device that does that. But I think we may have jumped ahead in terms of the right solution for these patients. But I share your concerns.
Thanks, Raul. Great comments.
Can I ask something to Dr. Sharma? You hear me?
Of course, yes.
Yeah, absolutely. Go ahead.
Dr. Sharma, thanks for your presentation. We learned a lot from your presentation, very updated. We have very little experience compared to you, just 5 cases. But our experience is that the acceptance rate is much, much better, far better than the acceptance rate in the mitral TMVR trials. In the mitral TMVR trials we participated, the acceptance rate was like 10-20%. And here our experience says that the acceptance rate for our cases is probably 70%. And those rejections were just for size. So if the new size, the 56, comes through next year, then probably this acceptance rate will be even lower. So I'm a little surprised to hear that the rejection rate in the TRISCEND trial was 70%, like Dr. Mack said earlier. Can you?
So I think firstly, it's probably testament to the fact that you guys are appropriately submitting patients. You know, there's obviously a degree of pre-screening that's going on, either consciously or subconsciously, where you're putting forward the right patients. So I would congratulate you on that. With respect to the study, I think we definitely saw a reduction, a drastic reduction from when we started the study to later in the study in terms of acceptance rates. And naturally, part of that is, and you know, I was part of the screening committee for these, is understanding, we start off very cautious, appropriately so, and then as we get experience and we learn more about the device and more about the patient we're putting it in, particularly in complex and challenging anatomies, I think the judiciousness remained, but we were a bit more flexible in expanding what was included in the study. So we certainly saw the screen failure rates come down. And you're right, at the moment, the biggest screen fail reason is size, or other anatomy that would preclude safe delivery of the device, mostly when it comes to flipping those anchors ventricularly. We're seeing fewer screen fails in late in the trough for patient-related comorbidities. They were screen failed out early, but patients who were too sick, too frail, or were deemed to have RV dysfunction that might preclude them became less and less common, you know, I think as people got familiar with what the right patient was. So certainly not as bad as the mitral TMVR space is right now.
Can I make one last question to Dr. Sharma, please? It's Dimitris Nikas from Ioanna University Hospital in Greece. I do understand the benefits and the advantages of the orthotopic replacement of the tricuspid valve. However, I do see that when these devices of heterotopic transcatheter tricuspid valve replacement came out, I said, oh, this is really clever. Do you see any future in these devices, or can you suggest, I mean, the reason, so 2 parameters that you probably choose one orthotopic device versus an heterotopic replacement of the tricuspid valve, or the opposite, vice versa?
I think that's a good question. You know, I don't have any experience with the heterotopic devices. You know, at the moment, I know there's been sort of very small volume, obviously, with the devices that are currently out there in that patient population. So I think that, you know, the greatest volume of experience we have is clearly in the edge-to-edge and now the replacement space. So I think there needs to be a little bit more data in the heterotopic space. It's mostly sort of small first in humans or very small EFS studies that are being done. But I think it's an interesting approach, but certainly one that, there isn't enough data that to merit any, conclusions, and certainly not to make a decision on choosing.
For me as a surgeon, this heterotopic approach seems to me like more symptomatic treatment, and is more like bringing the problem a step before where it was. So I'm not sure is a real treatment.
Yeah, certainly our early experience with, putting stents or valves, albeit not designed for that purpose, in the inferior and superior vena cava was not, successful. So again, now there's dedicated devices for this, but as I mentioned, I don't have personal experience with those devices.
Okay, thank you very much.
Thank you.
Should we proceed with a colleague, Dr. Turani from Atlanta, I think, and he will expose us which treatment is better for which patient. Dr. Turani.
Can you guys hear me okay? Can you hear me okay, Dr. Panos?
Yes, for me it's okay.
Great. I enjoyed listening to Rahul's talk, and I'm glad he got all the hard questions, and that I won't get those hard questions. So that was great, Rahul. So this is a topic, it's quite interesting. I gave this topic in Toronto a couple of weeks ago at AATS, and it was a very similar topic of, what do you do between the repair, the replacement, and surgery? And so I'll kind of go through a little bit what we talked about in Toronto, and I think it's very appropriate now with these two technologies and the two previous talks that have just been given. So these are my disclosures, and for this specific topic, I'm one of the national PIs of TriSCEND-2 that you just heard Rahul present some phenomenal data on, and I'm on the steering committee of TriLuminate, and I'm a surgeon by trade. So that's why access to all three of these technologies kind of becomes interesting for me, and how to deal with this. So this is something that we discuss. I would say we have a valve clinic here at Piedmont in Atlanta where we have 3 structural cardiologists, and we have 2, soon to be 3 cardiac surgeons, all do most of the valve procedures. And we see all these patients on Monday. And I would say that about a third of we see about 40 patients every Monday. About a third of those are for tricuspid regurgitation. And so all of these are discussed with a surgeon and a cardiologist at the same time in the 11 exam rooms that we have. And so here you can see that I'm going to go through 3 different cases of patients that have come through the clinic, and I'll tell you about how I dealt with the heart team, how I dealt with all 3 of these patients, and we'll go through it not as much in detail in data, but in the decision making that we have. So here's a 49-year-old patient who shows up with symptomatic TR, N3 class 3 heart failure, has some CAD, has had a previous MI, had a stent put in. Is a smoker, actually had a right and left stent, I think. He had former smoker, has stage 3 CKD, was on Lasix twice a day, has an EF of about 35%, and had previously an FMR, severe FMR, for which they received a clip and had residual mitral regurgitation as part of that clip. And here you can see the tricuspid regurgitation on transthoracic. You can see, you don't see very much, but you see some level of tricuspid regurgitation that you have there. And there you can see on the right side of the screen, the LV and the mitral clip in position there. We took this patient for a transesophageal, and you can see that the TR is really blossomed on the bottom left-hand corner. You can see that also, and I'll show you the mitral valve in a second, but you can see that there's a lot of tricuspid regurgitation in this patient. Remember, the patient's young, but by the previous physicians who saw the patient, they thought that he was better with a clip. And so this is kind of the patient that I'm seeing now for the first time. And what are our options for this patient? Is it medical therapy? Do we operate on this patient? Do we do a tricuspid valve repair that you've heard about 2 lectures ago? Or do we go what Rahul said, do we do a replacement in this patient? Well, I think that just to remind everybody, the primary reasons for tricuspid regurgitation are about 5 to 10%. Secondary is about 80%, and that's where surgeons come into play a little bit. And then the CIED related about 10 to 15%. What do the guidelines tell us, at least the U.S. U.S. guidelines? They tell us that diuretics can be helpful. That's a class 2A recommendation for medical therapy for TR. And again, a 2A in severe secondary TR, and you treat the primary cause of the heart failure is really what they recommend. And when you look at surgery, it's really class 1 for those patients who have severe TR and undergoing left-sided valve surgery, and it's a 2A for those who have progressive TR undergoing left-sided valve surgery. And really, you can see that there's a cutoff for annulus, as we as surgeons know, and then also right-sided symptoms. There's no class 1 recommendation for isolated TR whatsoever. As you can see, it's a 2A. And so that's really where we stand as surgeons as far as isolated tricuspid regurgitation. And again, a second bullet is 2B for those for isolated TR for surgery. It's a 2B in asymptomatic patients and a 2B for reoperation with isolated tricuspid valve. The first thing that we wanted to know was what's going on with the mitral regurgitation. And here you can see that you have 2 jets. The left atrium is large, as you can imagine. And in this patient, because of the mitral regurgitation, we started to think into the pathways of the guidelines, and we did not think this patient was best suited with that much mitral regurgitation. And I ended up operating on this patient. I did a tricuspid valve repair with an MC3 ring. You can see there's no residual tricuspid regurgitation. There's a 31 Magni Ease is what I use. I ended up doing a coronary bypass on him too for his LAD actually. And then a month ago, this is a month after his surgery, postoperatively, he has good recovery of his left ventricle, and right ventricle looks good. He has no more valvular issues left whatsoever. And there's surgical repairs that are common for tricuspid regurgitation, more for the cardiologist in the room. The most common is ring annuloplasty. I personally have not been a huge fan of DeVegas, and so I don't do those. And I don't do the K or the Clover for the most part. I mainly do ring annuloplasties for these patients. Historically, we as surgeons have noted that we've had a 30-day mortality of about, an in-hospital mortality of about 9%. And that's the numbers that have been used for surgical tricuspid valve repair. We have more recently done an analysis in the STS database. I presented this in January of 2024. And what we were able to show is that roughly 2,200 patients are done a year for isolated tricuspid valve repair or replacement. About 2,000 are done in the United States a year for the STS database. And what we've noticed is that there's a mortality of about 5.5%, 5-6%, and not the historic 9 to 10%. Remember, that was in-hospital mortality. This is 30-day mortality. So we're showing much better outcomes across the board for this. And as you can see, this is all the numbers going in a positive direction, that over from 2017 to 2022, we've really made a lot of progress from the close to 8 to 10% mortality all the way down to 5.5% mortality. And you can see that this is prolonged length of stay, it's M&M, it's prolonged ventilation, all of that is much better off. This has just been published in the Annals of Thoracic Surgery in May of 2024. So you've had a good look at some of the catheter options. We're not going to go through those in details because you've heard quite about them. But let's talk about what are some other options that we have, and in our heart team, how we make these discussions. Here's a 73-year-old patient with severe TR. You can see on the echocardiogram, patient had a previous severe AS and had a transcatheter valve put in for that at that time. The patient's EF, also patients in HFrEF. The patient has some mild coronary disease, is a renal transplant patient that actually has failed and now is back on hemodialysis and also has cirrhosis. So you can see that the patient originally, when we saw the patient, the original EF was 20 to 25%. The patient had severe AS, severe TR, on hemodialysis and on cirrhosis. And my personal feeling is that these patients can be operated on, but they don't do very well. And in this patient, what we elected to do was do first a TAVR on this patient. to see what would happen. You can see the EF has improved from 35 to 40%. The patient remained on Bumex, but still had severe tricuspid regurgitation. So at this patient is most likely a pacemaker lead associated tricuspid regurgitation. And you would ask yourself, what would be your options for this patient? And so when we went through the heart team, we thought this is also before the era of Evoke, but here you can see the stents that are in the patient. You can see the TAVR valve that's already in place, and we chose to do a TriClip for this patient. A lot of this had to do with his lead placement that he had, but also I think that we probably now would have considered him for Evoke because he has good leaflet coaptation, and it would be something that we would think about for him. And here you can see we're able to put a TriClip onto the leaflets for this patient, and we've made some impact for this patient, but he still has, as Mike Mack mentioned earlier, he still has some residual tricuspid regurgitation. A second clip was added for this patient. This was done off-label, actually, at this time. When we were doing this patient was not part of the Triluminate trial, but you can see we've made a dent in his tricuspid regurgitation as we see it. And here you can see that you now have two TriClips, and here you can see the mitral sheath, and there you can see ice. And one of the ways that we've gotten, I know that Rahul mentioned this, one of the ways we've gotten out of imaging issues, especially with pacemaker leads, is with the use of intracardiac echocardiography, which is used very frequently in our cases for this. And so after two clips, you go from torrential tricuspid regurgitation to moderate regurgitation. And so at this point with the medications, we believe that this patient actually symptomatically has felt great, but we still left him with a moderate regurgitation. You've already seen the data for the tricuspid clip. I won't show you very much, except to say that there are two devices. One is in trials, the Pascal-Edwards device, and one, of course, that has just been FDA approved. And as Mike Mack said, and you heard earlier, about 60% of patients had none, mild, moderate. We would fall into that moderate category for this patient. And you can see another about 40% have not been benefited extensively as far as the clip goes. And here you can see the class TR EFS shows a little bit higher numbers, but of course the numbers are small and is still experience that's being gained with this. I think there are a lot of challenges with the leaflet devices. Imaging is a huge one. Catheter navigation difficulties. The regurgitant orifice is often broad and not circular and difficult to deal with. And I agree with Rahul that a transcatheter ring is really the next step to making this better. I did, want to mention that what are some of the failure points what we stay away from. I think one of them is the coaptation gap. If you have a coaptation gap of less than 7 millimeters, you can see the moderate or less TR 73%. I'm happier with that number. As you can see with greater than 10 millimeter gap, you only have a 59% success. I'm not sure those should even be attempted with a TriClip. The amount of tethering is really important, as is a different type of a tricuspid valve morphology. So I think we need to start getting more sophisticated in our analysis of who's going to have success and with a clip versus replacement versus surgery. The last patient I want to present to you is a patient. What do we do with this absolutely torrential TR? You've heard some good talks already about this, but here's an 89-year-old lady that we had who had weeping edema of her legs. She had a hypertension, hyperlipidemia. She had a previous RCA PCI. She has some macular degeneration, and she's already on torsemide at 40 milligrams twice a day and metalazone also. I, as a surgeon, am not going to operate on this patient. I think that her outcome surgically would be poor, especially at the age and her macular degeneration and other comorbidities that she has. For this patient, we did not think that TriClip was available. And we thought that Evoke would be the best option. You can see somebody asked a question, Dr. Panos, I think about leads. You can see this patient has 2 leads in place. And here we're able to, because of the laxity and the leads, we're able to drive an Evoke valve into it. I think we've done about 45 of these. And in the trial, we're the 4th largest enrollers for this trial. So a lot of experience with the Evoke valve. And here you can see we've driven this across the tricuspid valve. You can see the nose cone is in the right ventricular apex, is very well seated there. And we're slowly over time, also you can see the right coronary stent there, so that gives us a good marker. And here you can see we've now opening up the right ventricular portion of the stent frame. We're almost finished with that component of it. And as we start to unravel and pull back the sheath further, you can see that we're almost completely have finished the right ventricular portion here. There's no need for pacing. There's no need for any of that type of stuff for this procedure. And here we're about to deploy the valve. And I think that this becomes a relatively, in our hands, we've been fortunate that it's been a relatively safe procedure, even though Dr. Mack has obviously noted some of the shortcomings of some of the complications that can occur. Here you can see a fully deployed valve. I think what's important for everyone to understand that the imaging is really intense. The NPRs that you have to understand in 3 dimensions how this works is really important. And I think for surgeons and cardiologists, this is quite honestly unfamiliar territory. In the last 2 to 3 years, I know Rahul and I have spent a lot of time in the cath lab with these patients, and I think we're starting to grasp some of the ideas of really how complex this is, but how we can do it effectively. And here you can see how nicely with this NPR, we're able to scan and actually look at each of the anchors as they're being deployed and making sure that we're adequately catching them in this very complex valve, sometimes a quadracus valve. As you all know, the tricuspid is very complex and is very difficult to understand at times. And here again, different ways of looking at it for this patient that we also performed in EVOQUE. For that patient I spoke about, a 1-month post-op, she has no more tricuspid regurgitation. Her quote was, "I have not seen legs this small in years," of course, because she used to have weeping legs from that. Rahul showed you this slide as far as the EVOQUE goes. I'll skip over it. This is what it looks like. I don't remember Rahul showing this. This is what the device looks like, and you have plenty of time. And there are a lot of ways. What makes it easy about this valve is you can move it septal, lateral, anterior, posterior, into the RV, out of the RV very easily. And so the manipulation of the knobs looks overbearing, but it's actually not, pretty straightforward. Rahul showed you this. The results show almost all of the patients have a resolution of their tricuspid regurgitation. Their challenges with the TTVR, analyst size, conduction system, RV function. I've had one patient who had RV failure after this has occurred, and they did not have a good outcome. I think from the over aggressive sizing that we had for that patient. Leaflet thrombosis we've talked about, and we have no clue what the durability is in these patients. So it's unclear when to treat these patients. And I think at the end of the day, when I look at repair replacement, we need to look at hemodynamics, we need to look at implantability, the durability, the thrombogenesis, and the lifetime management. And these are all 5 criteria that we need to look at for surgery, for catheters, and for replacement. We need to decide on what's considered success. Is it the symptoms of heart failure, or is it mortality? We're still deciding on our own what is considered success in these patients. There are a lot of competing risks in these elderly patients that may mask these benefits, and long-term follow-up is required to show the benefit. So I think that it's very important to have a willingness to fail. We've failed, but we've also learned from our early experiences. Rahul mentioned we're continuing to make device iterations. I think there has been an absolute imaging revolution, and I think that there has to be an evolution of the heart failure team, or the heart team, which has to involve heart failure and pulmonary hypertension experts and imagers for the tricuspid valve, people that we haven't used as much in the past, especially the pulmonary hypertension in the imagers. So this is our pathway for Piedmont Heart Institute. We did 75 TMVR and TTVRs last year, so a large volume of these patients. And the way we think of TR is they all need to be on GDMT. Some of them require surgery. When we go into catheters, what we have available at our institution is the TriClip, the Pascal, and the Cardioband. Those are all catheter-paced. And then for replacement, we have EVOQUE, Trisol. We've done 5 out of the 10 Trisols in the United States. The Croy valves, the Intrepid, the Laplace, and the heterotopic. And so when we sit with our patients in the room, we actually map out all of these trials, and we try to determine which pathway they're going to go into. So in summary, surgery is improving. It has improving outcomes, and it's been done now with excellent outcomes. The TTVR is extremely safe, but has less efficacy. The TTV replacement has higher morbidity with first-generation devices, but it eliminates the TR in most cases. The ongoing trials show quality of life benefit, but not mortality at 1 year. And I think there's still long-term issues that need to be investigated. Thank you very much.
Thank you, Dr. Turani, for this excellent and comprehensive presentation. Do it from the moderators.
Yeah.
Any questions?
Actually, sorry, Michali. Okay, thank you very much. Excellent talk, Dr. Turani. Very, very good. I think that the problem is the right heart failure here and the heart failure generally. We have to select patients that, are suitable for even going to the surgery or for the TTR or for another method. We actually had a patient with heart failure, 20 ejection fraction, that had right heart failure also with huge tricuspid regurgitation. And we didn't know what to do with him because he had all the symptoms of the right heart failure. And, finally, we decided, even though that we had all these methods, for example, to go to a TTR with a minimal invasive method, but finally we sent it to the surgeon, and he's right now good. I think that we have to specialize and to see every person differently and every patient differently, because we have a lot of things to think about all these patients. It's not only the technique, which technique is better or not. It's not only the durability of the devices that we have or the effect that the device will have on the patient. We have to think about patient's life and how he will go on. Thank you very much. It was just a comment. There is no question. Yeah.
No, I think that you're absolutely right. Now, I do want to make a comment on how we deal with these patients. And so over the years for these patients, we'll actually bring them to the ICU commonly for the patients you're talking about. We'll put a swan in them. We'll put them on Milrinol. We'll repeat their echo and see what really, we call it prehab. And I think that that's been a term that we've been using quite a bit. And I think that's what's led to some of the outcomes and benefits and outcomes across the board. And for us, you're right, in our program, surgeons and cardiologists are in the valve clinic together, so we see the patient at the same time, and that's why we can make these decisions. After we see them, we then have a separate call on Friday. It's a virtual call for 1.5 hours every Friday morning from 7 to 8:30, where we look at all their imaging and their scanning and stuff, and then we make the final decision. So it has to be together, and we do some of the hard surgeons have to put their pants on and do some of these hard cases that we normally wouldn't do. But then we're also very good about sending some of these to TriClip or TTV replacement. So it's a huge team effort, and I totally agree with you on the management schema has to change. It's funny, I'll be in Athens next week. I'm sorry I'm not there today. I'll be coming to Athens for the ICMIX meeting, first Santorini, then Athens. So I'm sorry I'm not there in person.
Can I quickly a question about your experience with Cardioband? I saw you were doing research on.
Yeah, we haven't. We have not started. We're in the process. We're looking for patients for that, and so we're part of that trial. And it's now getting it's IRB approved for our site, so we're screening patients for it. So we have not had actual experience, but that's now up and running. So we're screening patients. That slide I showed you was from last week, and so we're starting to screen patients for that. We have, I know you asked in the last question, Rahul had not done experiences. I've done 2 cases with IVC devices, and the patient's symptoms absolutely go away. I think Dr. Penos mentioned that also. The symptoms for the patient went away. The patient's mortality, they didn't die, but there's stent fractures that occurred in that IVC graft, and Edwards actually has stopped that program completely. So there's still, I think there's symptom relief, but I'm not sure there's no benefit to the RV at this time.
Dr. Mack, yes.
Thank you very much.
Vino,
Dr. Samar Gandhi is out. Yes, Dr. Mack, excuse me.
Vino, it's Mike.
Go ahead, please.
Great talk. So let me ask you this. What you think the role of surgery, if any, is going to be going forward. And I know you, as well as us, have experienced about triple the increase in tricuspid surgery, isolated tricuspid surgery volume due to the screen failures for all the trials. And I think it was you that published that surgery outcomes are actually much better now, and the volumes are much higher than we thought before. So do you think that surgery is going to have a significant role going forward? And if so, how are you going to sort that out?
So, Mike, I think that's an important question. And I think that, I'll give you, yes, our tricuspid surgical volume has increased for me quite a bit because of our heart team. The way that we do our heart team, surgeons and cardiologists are physically there seeing the patients together. So we have a complete buy-in to that. And I spend that energy in seeing these patients with the cardiologist. So I think for us, a surgeon is critical to that decision-making on what we're going to do. And the surgeon is also involved in the procedures. I'm less involved personally in the triclips because that day is my surgery day. And so it's hard for me, and if I can, I try to go in there, but we're less involved in the triclips. We've been involved in all the tricuspid valve replacements, partly because we understand the mechanisms very well as a surgeon. We see the valve just like mitral valve. And because of the potential complications that can occur, we have also always been there for bailout, for vascular reasons, and for pericardial effusions and all the other things that can happen. So I think a surgeon, quite honestly, is critical to this. We have now done over 45 evokes, so it's one of the world's largest experiences with evoke. And having a surgeon there, our outcomes have been unbelievable. And I think that's partly to do with just the mentality of a surgeon and a cardiologist working together to make sure that we're seeing everything appropriately. So, Mike, I hope that the country and the world can follow examples of yours and our program where we're doing a radical number of these cases. We've done 7 evokes in the last 2 weeks, just FYI. And it's something that is working well, but it works well when you have a team effort, not individual people trying to make the procedure work.
Very good. So shall we proceed with Dr. Samargandi?
Thanks, everybody.
Thank you very much.
Dr. Samargandi is, I think she's not anymore with us. She had to leave because of her duty in the hospital. So I think the meeting
she has a pre-recorded,
is over.
It's a pre-recorded, actually.
Ah, okay. Sorry. Because she sent a message. Okay, good. Good.
Arabia. Good evening, everyone. I'm Dr. Sundus Samargandi from Saudi Arabia. Thank you so much for the invitation. I would like to talk today about the future interventional therapeutic itineraries for tricuspid valve. I have nothing to disclose. So, the tricuspid valve anatomy highlighting vulnerable structures, starting with the annulus, that it has a crescentic shape, which is vulnerable to dilatation. And the septal leaflet is small in size and lack of papillary muscle, which create a coaptation vulnerability. But now the tricuspid valve is not forgotten and new lessons have been learned. No evidence, new strategies, and multiple therapeutic targets. We have started from medical therapy, going through the surgical repair or replacement, and ending up with CAVI solution to accommodate broad spectrum of different patients. The current landscape of tricuspid intervention goes in multiple domains, with the annuloplasty, coaptation enhancement, orthobitic replacement, or heterotropic replacement. And then there are the spaces or the spacer that we have to go through. Why do we need so many devices? Well, many patients cannot be treated with TEER or tricuspid valve replacement percutaneously, and anatomy-directed devices are important for long-term success and durability. Anatomy of subsets are challenging, sometimes like the large coaptation gaps, suboptimal imaging, the presence of a pacer meek or an ICD lead, and the RV dysfunction plus large annuli. and some patients have very difficult challenging subsets, as in end-stage renal disease, poor imaging window, inability to tolerate oral anticoagulation, or they have a high risk for bleeding. And finally, of course, the challenging to do a transesophageal echo, as in presence of varices, esophageal diseases, or difficult intubation. There are several options to treat tricuspid valve regurgitation, but one therapy is dominating the field, which is transcatheter edge-to-edge repair, or TEER. And we have two players in the game, which is starting with the Abbott system, the TriClip system, with its first generation, which is multiple devices, and it can act sometime to some extent ability to optimize the grasping, and with its active closure, it might do as an annuloplasty sometimes. And then you have the Pascal system from the Edward Life Science, which is also a unique system, especially with elongation and nitinol and softness, that it can prevent some, entanglement in the dense cord of the tricuspid valve. Many trials have demonstrated the benefit and the improvement in the quality of life of these patients when it comes to successful end procedures. Anatomical screening selections are key to procedural success. You might use some 3D ICE imaging and maneuvers to help to reduce the procedural time, and it might improve the outcomes. There are some conflicting data between the RCT and real-world data on clinical and quality of life improvement, but this is only at 1-year follow-up. Improvement may be more significant beyond 1 year. Getting tricuspid regurgitation to less than 2+ will likely confer a clinical outcome. Second one, transcatheter annuloplasty repair. We have few toys, let's say, in this field with the Cardioband and the K-clip, but unfortunately still they are not very vast commercially available, and it's usually advantages. It goes more with atrial functional TR, standalone therapy, or combination to decrease the coaptation gap, and leaves a future option open still if you need to go again. And it doesn't need an anticoagulation, though that's a bonus for everyone. The problem is its availability and the lengthy procedure. Other tools are coming to the field, which is the CROI, the Coramaze, and the TriFlow, with bridging untreatable gaps and high ease of use, with potentiality of quick procedure and spacer and central valve, as in the CROI. There is also the dual coaptation valve system with prosthetic valve with coaptation skirt and anchoring system, which is adjustable catheter system, suspended coaptation element between the native leaflet, allowing them optimally positioned coaptation element. SVC stent anchor catheter while leaving the right heart untouched, ensuring no disruption of the normal cardiac function. They are still in the case study period, still not very available. And finally, you have also the transcatheter valve replacement or orthotropic replacement. So we have now the Evoke system, which is, CE marked, and it's started to be more available in the European countries, and now soon will be also in the Middle East. And then we have some of the other devices, as in the Interpret, but still in the phases of trials. Why do we have so many valve replacement? Because the valve design originally actually it was for the mitral valve and being implanted in the tricuspid position. So by increasing the radial force, there will be high pacemaker rate, and the tricuspid annulus is larger, so require large valve than the mitral. And then the IVC to tricuspid annulus offset requires dedicated delivery system or non-transfemoral access sometimes. The impact also of the stiff valve on the RV function, we have to take that in consideration. And don't forget, there is a large bore delivery system, there is a risk of permanent pacement, as we mentioned, and risk of valve thrombosis. So that's why you have vast majority of different devices, each encountering different kind of problem. So going back to the Evoke system, which is from the Edward Life Science, it's an internal frame, bovine pericardial leaflet, which is delivered through a 28 French transfemolar approach. And the beauty of it, it has 3 sizes, 44, 48, and 52. And it has 3 planes of motion, which allows steerability and precision in positioning. Going forward, we have also the Laplace TTVR system. Again, still we don't have it commercial or CE marked, but it is it's a simple transjugular delivery using 26 French delivery system, tissue-to-tissue contact near the AV node with a flexible outer core to minimize any TTVR-related conduction abnormality. It's a low-profile valve that minimizes the interaction with the subvalvular structure. And it has a medium and large size currently available to treat broad range of pathology and anatomies with parameter from 133 to 177. It's simple to deliver and optimized in the valve design, and it minimizes the conduction abnormality as we mentioned a while ago. There are potentials still with the TTVR, which is the anatomical eligibility. Because we know usually these cases depend on CT screening in order for you to make sure about the sizes and about eligibility. Unfortunately, there is like 50 to 60% high screen failure rate. And most of the time it is due to the annulus is too large or the lack of, having good, or the RV is small. And we know that most of the patients with a severe symptomatic TR are like a female dominancy, but they have a smaller RV, they have some big coaptation gap and big annulus. Second point is the anticoagulation need and duration. We don't have the sweet spot for that, and many patients have multiple comorbidities that may be preventing them from continuous or having lifelong anticoagulation, as in warfarin or in direct anticoagulant. Still, pacemaker is a risk, and you have to consider management strategy after the implanting of the valve, where to put the leads afterward. And then the final one is the acute RV afterload mismatch and prolonged hospital stay versus next day discharge in TEER cases, which is a very major issue. And this is where right heart cath and hemodynamic evaluation pre-procedure is very crucial in planning the strategic way of treatment. Finally, for those patients who are out of the spectrum of these, they go with the heterotropic valves, which is available now at the TRIC valve, and also recently the trilimium has been introduced, which is the sidestepping untreated tricuspid valve anatomy with a massive RA and RV dilatation, which is exclude basically whatever is going on in the RV or the tricuspid valve and just deal with the consequences of a TR. And TRICUS study and TRICUS Euro have shown a very dramatic improvement in the quality of life of the patient after the implantation, but they will be requiring lifelong anticoagulation. And from personal experience, many of these patients have did tremendously great in terms of the quality of life improvement after the procedure. And it's a next day discharge. So you can see there is many factors that contribute to the choice of the therapy. It goes with anatomical criteria for the device selection, for patient going for tricuspid valve intervention, especially in the atrial secondary TR, because this is the most common one. And it goes either for TEER, ortho, HATU, or annuloplasty. And you just go whatever it's more favorable in your patient or less favorable for your patient. And with the last final slide, what are the future perspectives in terms of the transcatheter tricuspid valve repair or replacement? Well, the toolbox for the percutaneous treatment for tricuspid valve disease is rapidly expanding. Every person in this room have a device on his name. And secondly, the trend toward tailored device selection, taking into consideration anatomical features and clinical status and patient risk profile, is expected in the near future. So it's not going to be one size fits all. On the other hand, transcatheter tricuspid valve replacement lies behind the repair in terms of the procedural safety and major adverse cardiovascular event. But let's keep that in the point or in the side, because the orthotropic valve replacement has just started and the future is still bright ahead of us. In regard of the heterotropic transcatheter replacement, which is like an example in the trick valve, it may be considered an intervention aimed exclusively to reduce the congestion and its consequences. But to take it in the first step or the first line of treatment, still we are not there. And finally, I would like to thank everyone for attending this seminar and being here with us, and it's my great pleasure to be here. Thank you very much. Have a good day.
So, Dr. Samargandhi, thank you very much for this beautiful overview of what's coming next. We will close this session for lack of time, but we do appreciate all the speakers for their beautiful presentations and the beautiful discussion that we had so far. Thank you.
Okay, good afternoon. So I'm very happy to moderate this session. It's going to be a very interesting session. And the first speaker is Dr. Georgiou from Cyprus. Cyprus is in the forefront of technology when it comes to structural disease. And we are all ears. So you will present a Medtronic valve that is not currently available in Greece, the Evolut FX. So, George.
So, dear Chairman, ladies and gentlemen, once again, let me thank the organizers and especially Dr. Spargias for their kind invitation. So the case I would like to present to you is about a 79-year-old male patient who was recently admitted in our hospital because of signs and symptoms of uncompensated heart failure due to severe aortic valve stenosis and the paroxysmal atrial fibrillation, which was successfully converted to sinus rhythm with a DC shock after a transesophageal echo. He is an obese patient with a body mass index of 35 and has a previous medical history of rheumatic heart disease, as he underwent surgical mitral valve replacement with a bioprosthesis, a Hancock 29 millimeters bioprosthetic valve. At the same session, he had a tricuspid valve annuloplasty and CABG with 2 grafts, a Lima to the LAD and a vein graft to the RCA in 2013. He has also a chronic impairment of his renal function and depression, as well as hypertension, hyperlipidemia. Here is medication with the NOAC because of the paroxysmal atrial fibrillation and the high CHATS2 VASCOR, and some other medicines to control the rhythm and the rate of the atrial fibrillation. His Euroscore 2 was 9.15. The STS was also very high for both morbidity and mortality, so it's a high-risk patient for reduced surgery. And we had a heart team discussion about this patient, and we all decided to proceed with transcatheter aortic valve implantation. I don't know if Mr. Chairman would like to discuss.
I think it's a clear indication. I don't know if any of the surgeons. Dr. Riardon, do you have any comment on that? Yeah.
So it's a patient with a previous sternotomy and a patent Lima just beyond the sternum. So I think it.
Yeah. I think it's definitely an indication for TAVI. Yes.
So this is the baseline ECG with a narrow QRS complexes and a PR interval at the upper normal range. And this is the transthoracic echo, which confirmed the diagnosis of severe aortic valve stenosis with extreme calcification of all 3 leaflets, good contractility of the left ventricle, which was confirmed with global longitudinal strain, well-functioning mitral bioprosthesis, and the mean gradient of aortic valve of 42 and the peak gradient of 70. And this is the coronary angiography and the control of grafts that was performed a few weeks before the TAVI procedure. Total occlusion, chronic occlusion of the right coronary artery, some diffuse disease of the left system with occlusion of the LAD ostially. And this is the Lima that was patent, supplying well the moderate-sized native vessel. And the right side video is the vein graft to the right coronary artery, which is a good graft, widely patent, supplying well the good-sized right posterior descending artery. Here is the ECG-gated multi-slice CT, which showed the extreme calcification of the tips of the 3-leaflet aortic valve, confirmed once again the patency of the grafts, and showed that the distance from the vein graft of the right coronary artery to the aortic annulus was 60 millimeters, 60.5. Interestingly, the distance from the aortic valve to the mitral, the skeleton of the mitral bioprosthesis was small, was 2.9 to 3 millimeters. And the virtual placement of the Evolut valve, a 29 millimeter valve, was, as you can appreciate here, it was a borderline position with some risk for to interfere with the leaflets of the bioprosthetic valve. These are the measurements of the CT that were done by our hospital with a 3-Menzio. The perimeter was 76.9. The minimal diameter was 21.7, and the maximal diameter 27 millimeters with a mean of 24.3 millimeters. And this is the ECG-gated multi-slice CT for the peripheral arteries, which showed insignificant disease of iliac and femoral arteries, some calcification at the posterior wall of both common femoral arteries that must be taken into account during the ultrasound-guided sheath placement in the femoral arteries.
So, George, if I may interrupt you. So, historically, we know that when we're dealing with a TAVI procedure involving a mitral prosthesis as well. So, we want to have, when we deal with self-expanding valves, a distance of mitral to aortic annulus maybe around 4, at least 4. So, here we will have less than 3. So, are you worried at all to
Yes.
use a self-expanding valve? Would you consider a balloon expandable valve? And I didn't see any mitral angulation measurement. So,
The
do you think
angulation,
it's a factor on that?
The angulation was favorable for TAVI procedure, was not so unfavorable for that procedure, and the distance was truly small. That's why we considered that the implantation of a self-expanding valve that can be repositioned, resheathed, and repositioned will be a good idea in this case. And we wanted a very stable platform, a stable system that will offer this stability in order to have good chances to anchor the valve in the correct position. Obviously, it was a small distance with high risk of embolization of the valve, but sometimes it was also mentioned yesterday, this distance is not so, sometimes not so critical because even by protruding within the mitral bioprosthesis by 1 or 2 millimeters, it doesn't interfere with the function of the bioprosthetic leaflets. So the mitral valve is still functioning, even if this protrusion within the mitral valve system is a minimal of 1 or 2 millimeters.
So, would your practice change if this was a mechanical valve, or if it is, or even more if it's a single leaflet valve? And maybe this question can be answered by Dr. Riardon as well.
Yeah. We talk about this every time we do a TAVR with a previous mitral. I've never seen it interfere. With a balloon, I'd be very worried with this biologic valve and blowing up your balloon with those struts there. Now, if it's a mechanical valve, that would, we think about it. I've never heard a balloon with a mechanical valve with a balloon. But in this valve, I think this will work fine. There's always more distance than you think on the CT. And we've yet to impair a mitral valve by putting in either an evolute or a balloon expandable valve. But again, with the biologic valve, you have to worry about blowing up your balloon to expand your valve and bending one of the posts.
Okay, so there's no issue. Any other comment from the audience? Any other surgeon? Dr. Dimitrakakis, you have a question on that? No? It's fine, okay.
So we decided to use the new device from a Medtronic platform, the Evolute FX system, with multiple new features that improve the quality of this device. It has a redesigned tip that makes the tip looking and functioning as like a dilator with a very smooth insertion without causing any damage to the femoral artery. Redesigned capsule which increases the flexibility of the system. A single spine shaft for greater shaft flexibility and improved deliverability. A stability layer that improves significantly the stabilization of the whole system in order to decrease the possibility of protruding within the left ventricle, which something is happening with the balloon, with the self-expanding valve of the Medtronic platform, and enhanced visualization by using the 3 gold markers that are placed at the level 3 millimeters above the distal tip of the valve, and they're very helpful in order to identify the annulus and the correct position at the annulus. And this is the benefit from the single spine shaft that makes this whole system to deliver it more easily and to move around all the directions compared to the previous generation that moves only in 2 directions. And here is the stability layer, this green layer which improves significantly the stability of the whole system. So it prevents this movement. You can see in this territory here from the Evolute Pro system, which sometimes protrudes in the left ventricle. Even if we pace the patients in high heart rate, this sometimes it's unavoidable, and to have some deep protrusion within the left ventricle increases significantly the risk of permanent pacemaker need. So this is the TAVI procedure that was done through the right femoral artery. The right femoral artery, common femoral artery, was punctured under ultrasound. Here you can see the coplanar and the cusp overlap views. You can appreciate that at least moderate aortic regurgitation. That's why we decided to avoid pre-dilatation of this valve in order to decrease the possibility of increasing the aortic regurgitation. In this particular case, the commissural alignment was not so important because the patient has two grafts, lima to the LAD and vein graft to the right coronary artery, but this FX valve can be easily orientated in order to avoid any problems with coronary obstruction, and at the same time to have easy access to the coronaries post-TAVI. And here is the deployment of the valve using the 3 markers. Slow deployment with a pacing of 110 beats per minute. The final position was not bad. We had some moderate, at least moderate paravalvular leak. That's why we decided to post-dilate. We post-dilated initially with a 24 millimeter valve, which was the mean diameter of the annulus. The result was still not good enough. That's why we post-dilated even with a 25 millimeter balloon, and the final result was better. So we left the cath lab with mild paravalvular leak, which was confirmed by the echocardiogram, the transthoracic echo that was done in the cath lab. All our patients are treated with conscious sedation without transesophageal echo over the last 6 or 7 years. And how we used to close the femoral artery, we replaced the 6 French sheath. We use only a single proglide. We put the 6 French sheath back to give some contrast. If there is no massive bleeding, then we use one angioseal, and we finish with this one angioseal, the closure of the femoral artery. This is our practice for 1.5 years, and recently we have some data supporting this strategy, the multi-close vascular closure algorithm, which shows very low rates of major complications in the femoral arteries, which is similar with our results with a complication rate of 2%. The ACG post-TAVI, obviously there was a wide QRS complex and an increase of the PR interval in both 24 hours and 48 hours later. That's why we decided to follow this algorithm, which proposed to proceed with an invasive electrophysiology study. An EP study was done. The duration of the HV delay was 54 milliseconds. So it was a case with very low risk for complete AV block. And according to the guidelines, we worry about this if it's the HV delay is more than 70 milliseconds. That's why the patient left the hospital at day 3 after the intervention without any complications. This is the transthoracic echo post-TAVI, minimal paravalvular leak. We know that the nitinol of the self-expanding Medtronic valve is still expanding within hours after the intervention. And so minimal paravalvular leak, well-functioning mitral bioprocesses. The mean gradient of the aortic valve was 6 and the maximum gradient was 11. And this is our case.
So thank you, George. This is an excellent case. So we don't have any experience with this new valve. Is there a caveat in that? Of course, you have more stability, as you said. You have enhanced visibility regarding the markers. maybe the nose cone, it's better to get it in the ventricle. Maybe it's better to get it out because some of the pop out that we see, it's due to the nose cone, right?
Mhm.
So is there any caveat in this valve? Would you have a tip on that?
I think we have a small experience with this valve. We used only 4 valves, 4 FX valves. But obviously, we feel that the deliverability and the stability of the whole system is much better than the previous generation. So it's, for example, this case was done for the first attempt. We do not need to take it back or to have any migration towards the aorta. And the same was true for the other 3 cases. So we feel that the stability of the whole system is improved significantly by this new platform. Otherwise, we need more cases in order to have a more wide opinion of if these have some other benefits by using this valve.
This is excellent, and I noticed also it's very important what you suggested, your practice, that you did an electrophysiology study to investigate if there is you measure an HV to investigate if there is a high grade of pacemaker implantation. I don't know if the other centers are doing that. Dr. Riordan, are you doing that?
All of ours are FXs now. That's what we're doing every week. And one thing I have to teach new sites is when you're doing the Evolute Pro or the Pro Plus, you're worried about it diving, so everybody starts high and they hang onto the valve. With this valve, I have to teach the fellows, put it where you want it, let go of it. And if it moves, you have tension in the system. Once you can get it where you want it and let go of it, it's not going to move. You don't need to push or pull. And the other thing is, I'm going to fly back tomorrow. Monday, I'm going to do my first 2 FX Pluses, which is the FX with the 20 French holes in it. So I'm going to fly home, do those on Monday morning, and fly to Paris Monday afternoon. But I think that and commissural alignment will really help in future orientation of access to corneas. This guy's not going to need it, but some of them will.
So that's a very important thing. So we look forward to place this valve. So, Michali, let me ask you. So, do you follow this practice that you talk to your electrophysiologist? So, if you have a new LBBB and an enlarged PR, you ask for an EPS study to measure an HV.
I know people have advocated for that to measure H2V ratios and do EP studies, but we don't routinely do EP studies in our patients. We follow them clinically for the most part.
Okay. We don't do it. Okay, thank you. We'll have to leave it there. Then we have to go to the next cases, going to be presented by Dr. Spargers, who unfortunately is not here.
I'm online, Don, Yanis.
Okay. Hi, Costa.
Hello, hi.
So, okay. So first is Dr. Katsianos, who will present a TAVI case from IEA Hospital.
Thank you,
Okay.
Dr. Yakovo. I don't know if Dr. Spargas wants to say a few words about our new valve.
Kyriakos, you can do that.
Okay. So we were really honored to treat the first patients in Europe with the new platform of the Edwards valve, the Resilia valve, and we had a great outcomes for those patients. The Resilia valve has a new technology, a tissue that enables the dry storage of the valve, and it is also calcium blocking technology. Also the innovative is that we have at the bigger dimensions, the 29 millimeters, we have an ultra. The ultra technology also a skirt that we also took advantage, and we will see for next patient that we are going to present. Here we see the innovative tissue technology of Resilia, leading to 72% lower calcium content. And this is state-of-the-art new publication showing that with Resilia, we have achieved lower mean gradients, also better hemodynamics. So we'll proceed with our case, 85-year-old male. We would like to also to see in the background the case maybe as live in the box. If it is possible. So 85-year-old male patient, BMI for 26.8, short of breath on exertion, especially in the last 4 months, NIHA stadium 2 to 3. In the transthoracic echo, a severe aortic stenosis. We see the numbers, LV ejection fraction of 40%, dilated in hypertrophic LV with impressive diameters. Also a dilated aorta with 45 millimeters, a moderate to severe TR with possible pacemaker electrode involvement, a mild MR and RVSP for 23 millimeters. Medical history, permanent pacemaker, hypertonus, and problems with thyroid. We see his medication. The Euroscore 2 was 9.16%. Is it possible to, yeah, okay, thank you. So, it is important to, as I said, to notice that the Resilia valve has a dry tissue storage, so we need only 2 minutes to place the valve in the water infusion and it is ready. We don't need longer preparation. Beginning the intervention, we used 2 proglides, one at 10 o'clock and one at 2 o'clock, before introducing our sheath. We see a severe stenosis, I said, with a Vmax for 4.23 meters per second. Here's the ECG of the patient and the X-ray. We see the leads in proper position of the pacemaker. CT, heavily calcified bicuspid valve, probably of type 0. And we see also a calcium region diving in the direction of the mitral valve, which should we take care of. In the live in the box case, we see, as I mentioned before, the dry storage tissue of the valve. It needs 2 minutes, as we said, to place it in the water. So this is the innovation. Moving on with our case, we see the heavily calcified bicuspid aortic valve with a large annulus, the diameter 31 to 35 millimeters and an area for 8.97 square centimeters. Maybe we should ask the colleagues now what would be their thoughts. We have a bicuspid valve, heavily calcified with a very large annulus.
Discussion. So I didn't see. So the LVOT measurement was.
That's coming. Yeah. Sorry. So this is a supraannular measurement, 4 millimeters from the annulus, and 7. You see a diameter from 38 millimeters. And I don't know if we have. No, that's all that we have from our CT measurements.
So when you're dealing with a bicuspid valve, you always look for what kind of bicuspid is, and also you look for the LVOT, if it's tapered, non-tapered. So all this information will help you guide the procedure. So Mihaly, how do you normally approach these patients?
Yeah, indeed, it looks like I got type 0 with a lot of calcium on the leaflets and severe stenosis. Definitely challenging anatomy and fairly big annulus. As we saw, it's over 800 millimeters square. So technically speaking, what one could think from the get-go about implanting a large valve, either one of the very large MyValve 30.5 or 32 to consider that, or a Sapien, the Resilia Ultra 29 with a lot of plus on the balloon. I'm not sure about the Evolut 34 in this case. I think it was also horizontal anatomy, and there was also other issues that were against an Evolut valve. But definitely in all bicuspid valves, we tend to do a pre-dilatation that will always give us a hint about the degree of stenosis and how well this valve will behave during actual valve deployment. So I think balloon pre-dilatation in this case would be very important.
I think that's of paramount importance to do a pre-dilatation with the nominal balloon and according to 12 VOT measurement, maybe undersized a little bit. But yeah.
We were indeed between two valves, the MyValve and the Resilia valve. Maybe we could use the new innovation of the skirt in the bigger diameter. And we decided to do a valvuloplasty, and according to the outcome, we would decide also the type of the valve that we were going to implant. So moving forward. The coronaries of the patient didn't show something crucial. The axis, the peripheral axis, was also feasible. See the right side, and we see the heavy calcified aortic valve, and we also see a mild to moderate regurgitation. We wanted initially to place a sentinel protection, but due to anatomical reasons, there is also calcified. We decided that it was not in the favor of the patient. We check also the pigtail position before placing our extra stiff, the Safari wire, and now we see the valvuloplasty. It is a 25 millimeter balloon of Edwards. We see the sealing of the valve, which enables us to think about using the 29 millimeter Resilia valve. And we should also bear in mind that it is a bicuspid valve. So although the measurements of the very big annulus, due to these aforesaid factors, we were thinking about using the Resilia 29 millimeters valve. I don't know if Dr. Spargas has a comment.
That was the decisive moment of the procedure where the decision was made about what valve we're going to use. We had available all the valves, and if we stuck to the CT scan information, that would be my valve, probably the very large one, the 32.5, according to the CT data. Clearly, the perimeter was too large, more than 100 millimeters for any self-expandable valve. But because of the bicuspid anatomy, and especially the type 0 bicuspid anatomy with a lot of calcium, And from our previous experience, we knew that such anatomy is very likely to prove to be sealed by much smaller balloon expandable valves. And this is exactly what happened here. So this is a 25 millimeter balloon, and you can see it offers complete sealing. You don't see any contrast going back to the ventricle, which means that the 29 millimeter Resilia valve with the sked will be super sufficient to do the job. If someone was going blindly, according to the CT scan with a 32.5 Mi valve, I think the effect will be catastrophic.
Also, we could comment maybe that there is some proximity of the leaflet, the severely calcified leaflet towards the left coronary sinus and towards the left main. Essentially, it fills the whole sinus of Valsalva. There is good flow over it into the left main, but again, this 25 millimeter balloon seems to be very adequate in terms of sealing the valve.
So
29 is the way to go in this case. Maybe a 34 Evolut would be sufficient as well. Probably in our center we would use an Evolut 34, but yeah.
About the proximity of the left main, yes. Michael commented earlier. I think this is a 2D imaging that is misleading us, because on the CT scan imaging, the planning, the distance from the left main to the other side of the sinus of Valsalva was like 36 or 38.
Yeah.
So I think it's the 2D imaging that is a little misleading us here.
Good.
That was the case. We also did a lot of different projections to be sure that there was adequate distance to the left main. But as Dr. Sparga said, we had also this very important information from the CT. So we have here placed our valve in position. We've pulled the pigtail, and we are ready for the valve implantation. Under rapid pacing was a 29 millimeter Edwards Resilia valve, -4 ml.
It was plus 2 on balloon.
Sorry, +2, yeah, +2. And we check the outcome. We see that the valve was not optimally expanded. Since it was also a very big annulus, we wanted the maximum expansion of the valve. So we decided to proceed with the post-dilation. We put another 2 millimeters. So it was a total sum of +4 in this post-dilation under rapid pacing. And this is our final result. The access point remained very good, and we ended, as Resilia platform says, with a very low mean gradient, a good hemodynamic result.
So I think that this is an excellent demonstration of how to treat the bicuspid valve with such large anatomy. So this is very tricky. The valve is also a little bit horizontally. I think that this was a great demonstration with a new valve. So basically, it's the same ultra device. So the skirt is the same. So you don't worry about more frequent pacemaker implantation. Of course, this is not the case in this case. But yeah. So you have the same practice as the previous ultra, right?
Essentially, yes. The platform is the same. Loading of the valve on the device, everything is the same. And the implantation technique is the same exactly. We don't have any The major difference is, number one, the Resilia treatment of the tip of the leaflets, and the way the leaflets are sutured on the frame. It actually allows for a bigger valve orifice, which is very important for smaller sizes, obviously, not so much for the 29, but it's an important consideration as well.
So, so if you have a Resilia Ultra, it's purportedly it has the same durability as the Resilia surgical implanted valves. You think? So I don't have any knowledge on this issue. Maybe Dr. Riardon can make a comment on that. So, is the durability-wise is the same?
No, we don't know. I mean, so far it looks really good, but the 7-year data from the COMMENCE trial was reported a year ago at the AATS, and so we really are only up to 7 years on Resilia. You know, the 7-year data is coming out on the Valus valve, the 2 new pericardial valves. But until we get to 10 years, we don't really know. It looks very good at 7 years, but again, we don't know. We'll see in a couple years if it's going to hold up. But so far, the data is very encouraging. To me, the most encouraging thing is I like the way they redesigned the way they put their commissure post on there, and it allows it a bigger opening. I think that's an improvement.
Okay, this is excellent. I think, Mike, we can proceed on the next case. So thank you, Dr. Katsianos.
Thank you very much.
So the next case will be presented by Dr. Stathogiannis, again from the home team.
Thank you very much. Again, this is a TAVI round session, so everyone is allowed to ask comments and interrupt us anytime. Let me just quickly go to our second. So we're leaving the aortic valve landscape, and we're going to the tricuspid. I think we feel much more educated after the last 2 sessions on the tricuspid valve. So we're going to show a case of a 78-year-old female, BMI 20, rather thin lady. So she has been complaining of shortness of breath, at rest, fatigue for the past few months, and has been up-titrated to her medication. She has been recently hospitalized due to dyspnea and congestive heart failure symptoms. She's been suffering from rheumatic heart disease, so she has been having lots of previous procedures, surgical AVR 2010. She required a valve-in-valve 13 years later in the aortic valve. Another pertinent history of atrial fibrillation, hypertension, and hypothyroidism. So these are TT images, as we always do in these cases, parasternal long axis. Not the best video right now. With good ejection fraction, let me just go a little bit further. Mild MR, so we can see the aortic valve is functioning well. A Vmax of 2.6 and a mean gradient of 15. Remember, this is a valve-in-valve aorta. Apical 4-chamber view, we can appreciate the mild MR, maybe some mild to moderate mitral valve stenosis. Rather enlarged right atrium and right ventricle, and we can appreciate the sizes here as well. Enlarged right chambers, dimensions measured. So we have been talking about who are the ideal candidates for tricuspid valve therapies. TAPS on the left side, TDI on the right side. Seems that we have a pretty good functioning right ventricle. I don't know if Dr. Chrysoheris would like to comment on these images.
This is transthoracic images of the tricuspid valve, 3D images, and we can see very nicely that this is a valve that has a very big malcoaptation. The anatomic regurgitant orifice is huge, and as expected, she has torrential regurgitation. It could be an element of a little bit maybe rheumatic involvement of the leaflets, but she didn't have stenosis. It was torrential TR. You can see also the restricted septal leaflet here, very limited mobility, a big coaptation gap that would preclude the positioning of any edge-to-edge devices. And the coaptation gap is about 15. So again, this is transthoracic subcostal views. That shows torrential TR with an ERO of 0.7 square centimeters.
So as we are evaluating these patients, we're very fortunate to have very detailed measurements. And of course, we don't know beforehand what kind of procedure we're gonna, or what kind of device we're gonna choose, but so the companies do send back their reports. So considering that this patient, I don't know, maybe, Chairman, we would like, just before we decide which kind of therapy, repair or replacement, before I go into some details for the EVOQUE valve.
It depends what kind of arms do you have, right? So up to now we had only TIR, but now it seems there is a new armament. So it's the TTVR, right? So let's see, how did you plan your procedures? I see you did a CT analysis, I suppose, yes?
So these are the CT measurements. We do measure at the tricuspid valve annulus and at 5 millimeters below. Ideally, we need to have some oversizing so we can avoid in the future that the valve might be dislodged, and that's why it's pertinent to know and note down the weight of the patient during the CT scan and during the actual procedure, because as we said, this might change the plan eventually in the future. And of course, we need to have measurements from the right atrium, the right ventricle. We need to know the distance from the IVC and the SVC to the income of the right atrium, because maybe some of the valve and the technology that we have might not be working if the room is very small. And of course, we have other detailed analysis of the valve-in-valve procedure that we can see. And of course, we always have, as we mentioned in the previous TV sessions, to have the invasive hemodynamics, both from the echo, but of course from the right heart catheter. So we have this 78-year-old patient, frail, very symptomatic, has all this rich surgical history, and these are her Euro score and tri-score, and a without significant coronary artery disease.
So it's a high risk for surgery. So I noticed that the indication that you have with EVOQUE, there is no mention for high risk score, right? It's not like the TIR. So you can actually, it's an expanded indication, and you can correct me if I'm wrong. So it's when you have the FDA approval, it's in the TIR, it says that you need to have good anatomy and high surgical score, but in EVOQUE, it doesn't say that you need to have high risk for surgery, right? Well, am I right? Or am I right?
Dr. Reardon's.
Low risk for surgery, you need to fix that mitral valve at the same time, because that's not dramatic. That's a right heart that's failing because of the left heart problems, and that mitral valve is causing more trouble than you think. You may think the gradient's 9 and there's moderate, but just look at that heart. That heart's sitting behind a really bad mitral valve, and that's what's caused the whole right heart to start to fail on you. So anytime you get the right heart look like that, they're all high risk. But if there's a low-risk patient, you need to fix the mitral valve at the same time.
So you think, if I understand, we should start from the, as we always do, from the left valve, right? So,
there's a lot of reasons, but if you just look at that, that's a right heart that's failing on the basis of left heart disease. You fix the aortic valve, that mitral valve is causing more trouble than you think. But so if it was low risk, you wouldn't be doing an EVOQUE. You'd fix both valves if you really want to fix the patient, but it's clearly not a low-risk patient.
Okay, so Michael, any comment on that?
Would you be concerned about the pulmonary pressure of 55? She has good RV function based on TAPSE and RV S prime, but do you think that will cause any issues with the right ventricle?
Well, your right ventricle has been slowly trained, so that's helpful, and certainly that wouldn't dissuade us from fixing her mitral valve. There's no really pulmonary pressure that's too high to fix mitral stenosis. But again, what's really going to add to the risk is the fact this patient has already got some pretty significant right heart symptoms. He's got some pulmonary artery hypertension, got a fairly big right heart, even though it's working pretty well, and that's going to add to any surgical risk that I do. And again, if I'm going to think about operating this patient, I'm not going to leave that mitral valve alone. That mitral valve is a bad valve. And now, fixing her torrential TR and see if that makes her better, That's fine. But you're going to, you know, if she lives long enough, you're going to have to deal with that mitral valve sooner or later. There's too much MR to do a balloon. You know, maybe there'll be a better valve for us transeptal at some point. But yeah, all those things worry you. But I mean, the reason that you've gotten to where you are now is the mitral valve's bad.
So in an ideal world, you would fix the mitral valve first. But we don't have, you know, the correct device for that. We don't have the Intrepid, we don't have the EOS. How would you fix the mitral valve first? Would you do that?
I think as of now, based on hemodynamics and so on, we've qualified it as moderate. One could do a MV area assessment by transesophageal echo and see what the number is actually. But definitely you have to consider that this mitral valve is causing trouble here. But we don't have any good devices for the mitral except for a tendyne valve, which would be a transapical device, should the patient be a candidate. Overall, the heart team evaluation was that the mitral valve at this point could be on hold.
If I can make a comment here. This patient, initially, it was thought that the aortic valve degeneration, the bioprosthetic degeneration, was the problem of the patient. And despite the very low velocities there, it was 2.5, 2.6, it was decided in another center that TAVI should be done, and that would resolve the problems. At that time, the mean gradient of the mitral valve was measured to 4 or 5 millimeters of mercury, and the tricuspid regurgitation was like oversighted, despite that it was torrential since then with this huge gap. So not strange that TAVI didn't make any change in the symptoms of this lady. She came back requiring something more. And now when we see the other two valves, we see moderate mitral stenosis, I agree, but it is stable. And what we see on echo is a huge torrential tricuspid regurgitation with this very large gap. So I think it's the order we approach this multivalvular disease. And I think at this stage, the larger problem is the tricuspid valve. And then for the mitral valve, I think we can certainly do balloon valvuloplasty for palliation because there isn't the mitral regurgitation is very, very little, very mild. And why not one of the TMVRs that hopefully are coming soon, like the M3?
Good. So in hindsight, the heart team in the 1 year before maybe it should investigate the possibility of reduced surgical multivalvular approach, you know, more thoroughly, Mihaly.
To be a high risk for, but I agree with you. In hindsight, at the point of possible redo, but it would be a redo aortic valve replacement. Yeah. So it would be a very difficult.
Very difficult, and one has to do what one has to do, right? So maybe we cannot do everything. So how did you proceed?
So big discussion, obviously. This is the landscape. All these images have played before and previously regarding all possibilities. We do know now after all these sessions how the EVOQUE valve actually is. There's 2 interchangeable stents and 9 anchors that go actually below the hinge points of the tricuspid valve leaflets, and there's a 28 French outer diameter sheath delivery. So we have the white knob. We have a white knob. We have for the ventricular release of the valve, we have the blue knob for the atrial release of the valve, and we have the primary flex and the secondary flex knob, and we have the third knob, which is for the depth of the valve as we implant it. So our initial step is always ProGlide's dilation of the right femoral vein. We use 8-point French. This is an Agilis steerable guide catheter, and you can see the stiff wire placed very gently into the right ventricle. We make sure that there is that it's not caught anywhere in the papillary muscles or anything that could potentially cause trouble later in the procedure.
And this is a Safari small, right?
Sure.
Extra small? Extra small, yes.
And of course, this is a you need to be very patient with this procedure. It's fully dependent on the TE and the images that we get. And
on reconstructions from mid-esophageal view, the imaging is not great actually. I think most of the procedure we actually did it with transgastric 3D imaging and multiplanary reconstructions from a transgastric position, if I remember well. But the quality of the images is not as good as we would like it to be for at this stage. It's acceptable but not perfect. And so we see now we've moved into this transgastric view in order to reconstruct from a three-dimensional image all of the necessary planes that we need to. And with that, we're actually able to do it very well.
And this is how we slowly release the anchors based on what we see on the TE images. It's a very slow process. We need to make sure that we are below the tricuspid valve annulus, but we're not very well deep into the right ventricle, into the apex of the right ventricle, because then we'll have difficulty into actually being able to pull back the valve. Very slowly releasing again, as you can see, until we reach 90 degrees. This is what we call the flipping of the anchors. And now we're starting to release the ventricular side of the valve. And we can see the images from the TE that is actually driving us.
At this point, yeah, we've also, before we looked at all the anchors to make sure that the leaflets are sitting above the anchors and we're not pinning any leaflets outside. So it's a very deliberate process to make sure we see all the anchors.
And we always get to see here where we are. After we've finished with the ventricular release, we're going to the atrial release, and you can barely see here, the valve is almost ready to be released. And of course, we always keep an eye on what the TE shows us. And you can see now the valve is fully released. And this is, we always make sure to see whether the valve might have candid, might have dislodged. And we take many angles. I don't know, Dr. Sparias, if you would like to make any comments?
No, Constantinos, everything's fine.
And another angle to make sure that everything is working fine.
Yeah, and this is obviously the 3D after the procedure, looking from the right atrium, the valve. If I recall well, there was a small PVL, nothing exciting, but a small PVL was present, which actually diminished in the follow-up transthoracic images the next few days.
And this is a TT image.
Yeah, this is transthoracic images while in the hospital. The stable position of the valve, nice laminar flow through the valve, and a small paravalvular leak next to the septal area.
So it's almost a complete elimination of the TR. So what's the follow-up? Did it improve the symptoms of the patient? You know?
So basically, these are the first initial cases we've done in Greece and in Europe, to that matter, after it has been commercialized.
Yes.
And all the patients seem to fare good. Improvement of symptoms. Obviously, we don't have long-term outcomes, more than 2 months right now, but phone follow-up that we have, they're happy. So if they're happy, then we're happy. We're waiting, now we're collecting all these patients to our database and our registry and to make sure that we can have some kind of follow-up.
Okay.
But there seems to be a positive effect, but it's too soon to say anything right now.
Clinically wise, they are better. Of course, echocardiographic, did you have an echocardiography in these patients?
Of course, we had also discharge echo. We didn't have any issues pertaining to right ventricular dysfunction on clinical grounds. We didn't have any issues, and she went home actually, if I recall well, at 4 days of of follow-up for hospital stay. So stable medical management, we didn't have any...
Yeah. I can add that she's doing well and certainly improved after this procedure compared to the improvements she had after the TAVI procedure.
So she needs less diuretics, I suppose? Yeah?
So we don't tend... Oops.
Yeah, his symptoms are improved considerably. So I would say that she's now happy with her daily activities and can do things that she couldn't do before. She's coming for the 1-month follow-up, I think, the next few days. So it's too early, but the first messages we get from all these first patients are very encouraging.
Okay, so anyway, Evoke is approved for better quality of life, right? Not for there are no hard endpoints as far as I know. So this is the FDA approval, right, Michale?
I think the TriScent was a comparison between the TriScent study, the pivotal TriScent study is a comparison between Evoke versus medical therapy, correct?
Yeah, but there are no hard endpoints, so it's only quality of life.
Sure.
So we should stay there, I think, for the time being. And another question that I have, many of these patients, they have pacing wires. How do they fare when you place an Evoke? It's like the Edwards, the other Sapien valves that you place in a ring?
So the pacing wire, as we heard before, it's good that it has some slack, so you don't get to damage it. Of course, you need to have a backup plan in case everything goes wrong. We've done 3 cases with pacing wire. We didn't have time to show them. We didn't have any problem. They had some slack, so we need to work with the EP colleagues here as well. Now, you said what will happen if the valve eventually would degenerate? I couldn't hear you, sorry.
Yeah, but the pacing wires. So what's happened with the pacemaker?
So we didn't have any issues.
No.
So we know from the studies there have been some side effects, some conduction abnormalities. We did have one, but it just went off by itself within a few seconds. So otherwise, no, we didn't have any problems with patients with pacing wires.
Okay. So do you foresee any changes, major changes in your practice? So when you deal with severe torrential TR, that it's in the yellow zone or red zone for TriClip or Pascal, you would go ahead and place the Evoke, I suppose, right?
Yeah, I think if anatomically they're not suitable for edge-to-edge repair, then that's the only thing you have as an alternative. But if they are suitable for edge-to-edge repair, then you really have to convince yourself that with edge-to-edge repair, you're going to have a durable and good result. Because nowadays, when we do edge-to-edge repair in the tricuspid, we really think very carefully about our results, and we're very mindful that if we don't get a good result and we do implant a Pascal device or and we have a moderate residual, then the patient does not have any other options.
Okay. Good. Good. So if there are no other comments from the audience, so. Okay. Exactly. So we have an accurate device in the same patient, also an Edwards, Evoke, and maybe next year in Draping the mitral. So yeah. Okay, good. Thank you.
Thank you very much.
Mitral valve lectures. I'm with Dr. Vardis, my co-anchor person, and our first talk is mitral valve calcification When and How to Treat by my good friend and fellow Texan, Michael Mack. Michael.
Thanks, Michael. And Michael said it all in his last comment there. As surgeons, we love to give this disease away. But based upon experience so far, you don't want it either. So that's going to be the theme of this talk. So this is my conflict of interest disclosure. So what I'm going to do in this talk is give a brief background about the origin and incidence of mitral annular calcification, a classification of it that's just come up, and what the current management options are. So first of all, the background and etiology. Mitral annular calcification is a chronic condition. It's age-related. It's degenerative and a non-inflammatory process in the fibrous support structure of the mitral valve. And you can see on the right side of this slide how calcium invades the annular fibrous structure of the mitral valve. This is a review that we wrote in 2016, which was a great education for me on this. It begins in the posterior mitral annulus. It is highly variable pattern in severity. It is variably progressive. The overall prevalence in the MESA study is about 9% of the population, and obviously it's age-related. And what I didn't realize, it has the same sex incidence in males and females. However, we see this disease present clinically much more commonly in females. The amount of calcium and the effect on valve function and the need for intervention is greater than women, especially postmenopausal women. So in most series, about 70 to 75% of the patients treated are women, but the incidence is the same. It's just the progression is greater than women than in men. So likely etiologies include atherosclerosis, abnormal calcium phosphorus metabolism, such as we see in chronic kidney disease, especially end-stage renal disease. It is associated with coronary artery disease, and it is associated with Marfan syndrome, probably due to the higher levels of stress on the mitral annulus. It can be incidental or the cause of mitral valve disease, and the presence of MAC complicates surgical and catheter-based interventions. So this is just a surgical example of what MAC looks like at the time of surgery. And you can see this is a robotic procedure cutting into the anterior annulus, and this gives you an idea of what mitral annular calcification looks like. So this is in the annulus coming down onto the anterior leaflet. You can see why we don't get good surgical results of this because not only of the stiffness of the annulus, but all the calcium emboli that could be associated with debridement of these valves. Now there has been a classification come up with mitral annular calcification, published by Mayra Guerrero from the Mayo Clinic in the year 2020. And there are 4 parameters: calcium thickness, calcium distribution, involvement of the trigone, and involvement of the leaflets. And each of these is scored on a base, the first 2 on a basis of 1, 2, or 3, and the last 2 are 0, 1, and 2. So you can have a score from 0 to 10 based upon each of these components. And these are 3 examples here. The one on the top has minimal calcium thickness, minimal distribution, no involvement of the leaflets and trigone, so this would be considered mild. The one in the center would be considered moderate, and on the bottom, where there is great calcium thickness, extensive distribution, including greater than 270 degrees of the annulus, both trigones involved and leaflets involved, this would be a score of 8 or severe MAC. And this is useful in terms of helping determining therapy. Now, this is a very complicated one, so Dr. Guerrero came up with another simpler calcification of MAC. So mild MAC is this, moderate MAC is this, and severe MAC is this. This wasn't me, this is Myra Guerrero. I stole her slide. Now, it's also important to know that it's not just the amount of calcium and the distribution of calcium, but also whether it's caseous or not. And as you can see in the slide in the upper left, there's areas of less hyperlucency that are grayer compared to the breast white, and these are areas of caseous calcification, and this is what it looks like. And it makes the annulus more malleable. See, it almost looks like pus or endocarditis, but that's caseous MAC, and that allows a more malleable annulus both for surgery and for transcatheter therapy. So here's the options in terms of treatment. One is medical management, and there really isn't medical management but observation, and you have to see that not everybody needs to have their mitral annular calcification fixed. Surgery, transeptal valve in MAC, transatrial valve in MAC, and then some dedicated mitral THV devices. And so I'll go quickly through each of these. So this is an example of a patient that, an 82-year-old female with severe symptomatic AS and moderate to severe MS and mild to moderate mitral regurgitation, and she was extremely high risk for double valve surgery. This shows her mitral parameters here. You can see she has a mean gradient of 6. And this was her aortic valve measurements here. Now, one of the things I've learned is that I always thought if you had 2 dams in a river, the river was never going to flow unless you got rid of both dams. And I have been amazed a number of times over the years where if you just fix one stenosis, then it actually improves the patient despite the fact that you don't fix the upstream dam in the river. So we elected just to go with TAVR only in this patient. You can see the valve being deployed here. In interest of time, we'll move on. And at 1 year follow-up, she was asymptomatic, and her mitral stenosis and mitral regurgitation was unchanged. She still had a mean gradient of 7 across the valve, and she did fine with just 1 valve replacement. So, and we think we made the right decision, at least for a year, of not putting this woman through a double valve operation. And then if she becomes symptomatic, this was about 4 months ago, she was still asymptomatic, we'll do a dedicated TMVR or a valve in MAC procedure. Now, surgical mitral valve replacement. This can be done through a mini incision. You debride the focal calcium. In this patient, we put a 29 epic valve in here. The advantages of doing this, as you can see in the upper right, you can debride the calcium, and then you can bolster the whole area with not only with pledgets, but felt strips to prevent annular disruption, which is the most dreaded consequence of cardiac surgery. So this is the results from the STS database that was published in 2019. You can see that in the upper left, the brown is patients that have some mitral annular calcification present, and it represents between 17 and 19% of all patients undergoing surgery. and the operative mortality is 5.8%. So not great. And as reference, isolated mitral valve surgery overall has a 30-day mortality of 1%. So you can see it's almost 6 times as risky treating this with surgery, which is why Dr. Reardon would love to give this away. Now, this is a patient, this is another option of using a sapien valve in MAC. Here you can see a patient with severe mitral stenosis and mitral annular calcification. This is the 3D echo reconstruction. And this is a sapien valve being deployed in the mitral annular calcification. That's a 29S3 valve. This is the post-deployment echo that shows there's a paravalvular leak at 10 to 11 o'clock. So here you can see where it is on CT. And we went ahead and put a closure device in, a plug, and this completely corrected the regurgitation. However, this is the results from the TVT registry in the United States of valve in MAC, a sapien valve in MAC. And you can see from 2016 to 2019, the purple bars are valve in MAC, and the 30-day mortality ranges from 19 to 25%. So although it technically can be done, the results aren't great. So another alternative that we've taken is transatrial valve in MAC. So this is a patient with severe concentric mitral annular calcification penetrating the posterior wall, and we had no enthusiasm for operating on this. But some of the times doing this by a minimally invasive procedure, you can get a better result than totally transcatheter. So again, this is a robotic procedure. You can see we've excised a portion of the anterior leaflet of the mitral valve, and you're looking at the interventricular septum there, and we're doing a septal myectomy in order to keep the left ventricular outflow tract open during the procedure. And this shows we've put felt pledgets, bolstered felt around the whole annulus, and here we're deploying a sapien 3 valve under direct vision, obviously on an arrested heart. But this allows us to get a great platform for seating here and minimize the paravalvular leak. The downside, of course, is that you have to put the patient on cardiopulmonary bypass and arrest the heart, but it obviates the surgical procedure. And this is what it looks like at completion. And this is the post-procedure TEE. Post gradient was 4, no left ventricular outflow tract gradient, and no paravalvular leak. And this is the patient at 6 months afterwards, and again, with a good result at 6 months. So we embarked on this along with Gaurav Alawadi at the University of Virginia, and we had 51 patients, a technical success rate of 94%. However, you see that the 30-day mortality is still 13% with this, and 1-year mortality of 33%. Now, how about dedicated THVs? Well, there are 4 platforms that have had some experience with mitral annular calcification. We'll talk about 2 of these. First, the Tendyne procedure, which is a transapical approach to this. This is a patient with mitral annular calcification and heart failure hospitalization. This is from Paul Saraja here. You can see the calcification. This is the Tendyne valve being deployed prior to deployment on the upper left and after deployment on the right, and you can see the echo on the bottom with a good result. However, this is the experience with Tendyne in MAC. The 1-year all-cause mortality was 40%. Again, not better than any other approaches, and you can see these are the lists of mortality in the first 20 patients here. There is another alternative, AltaValve, which has some appeal in this disease because the valve sits totally within the atrium, and therefore you don't have to deal with a lot of the issues. Now, obviously, the more severe the MAC, this is not going to fix that problem. And this is what it looks like at 30 days afterwards. So there's a management algorithm that has been constructed for this to try to sort through what the best way of managing this. And like what's come up for mitral tear, there's a green, a yellow, and a red based upon annular size, the MAC score, the risk of LVOT obstruction, the risk of paravalvular leak, and the use of adjunctive therapies, including septal modification, leaflet modification, and surgical myectomy during the procedure. And we come up with some idea of which of these are best suited by which therapy. It results in a very complicated management algorithm, again, that's based upon your score and your risk for surgery. So in summary, MAC is associated with advanced comorbid conditions, including end-stage renal disease. The presence complicates any surgical or interventional procedure. There's now a classification based upon extent and location. The management algorithms are being developed, and despite progress made, management remains very challenging and outcomes suboptimal. Thank you.
Thank you, Michael. That was a great but somewhat depressing talk. I got very enthusiastic about transatrial valve and MAC when it first came around, and we'd take a sonopet and ultrasound it down, and they'd come off, and they looked great until about day 3 or 4.
Yep.
And then they would just start fading away, because I think this is a systemic disease, and this is one of those interesting diseases where you'd have a heart team discussion, and the loser gets the case, not the winner gets the case. Do you really, at this point, do you see anything that really excites you about MAC that might get better in the next 2 to 5 years?
No, I think, so the question is, do I see anything that excites me here? I think we're going to get better at figuring out which ones are appropriate for which devices. I think this classification system is going to help. But no, there's going to be no panacea or magic bullet here that's going to fix or cure this disease. You're right, I think it is a marker of systemic disease. People don't just present with mitral annular calcification, and despite the fact you do a great procedure and you leave the cath lab or the operating room with a functioning valve and no residual stenosis or regurgitation, the patients just don't do well. Even with a transcatheter procedure, just the insult of the procedure itself is kind of what tips things over.
So you're the chair of the Apollo Intrepid, and we have a MAC arm, but you have to have at least moderate MR to get into that arm. But we see a lot of these people have no real MR. Do you ever see us going to a Intrepid for pure MAC and no MR? Do you think that's a feasible thing?
I think it ultimately may be, but I think, as you well know, you take baby steps first, and if we can hit a couple singles or doubles here, then it's great. Then we'll start swinging for the fences.
Comments?
Great. Thank you very much, sir. I enjoy very much your very nice presentation. I would like to ask a question coming from another angle. You see, I am cardiologist. Nobody is perfect. I'm not a surgeon. I'm not. So I was pondering as I was listening, talking about MAC, and as you have approached the diagnosis, but mostly the therapy of MAC, as surgeon, cardiac surgeon, or even as an interventional specialist. My question is very simple. Do you think, as the population is aging, and as we are facing a new epidemic, the epidemic of calcification of the of the aorta and mitral valve, do you see any possibility to avoid this calcification in the valves through any way?
You know, I think that there are certain conditions that predispose to it. The most prominent one is chronic kidney disease with the altered calcium phosphorus metabolism. So the degree that you can correct the calcium phosphorus ratio, I think that won't prevent it, but it'll minimize progression with it. Secondly, there is a common etiology with atherosclerosis, so the better we can do of managing all the risk factors for atherosclerosis. Third is there's certain conditions like Marfan's that you aren't going to cure, and there is going to be added stress on the leaflets. No matter what you do, you can't fix anything about that. But I think, like so many of the diseases we see, it's risk factor modification to prevent progression of the disease when it's present. And it's especially important in females because the disease progresses faster in females than it does in males. And that may be a hormonal basis for that. And there is some thought that postmenopausal hormone therapy replacement may help affect the progression of the disease also.
It's a great,
but at the same time, these women are more osteoporotic with less calcium and everything else.
Yeah.
Exactly. It's a great paradox. You see, by the age, calcium is leaving the bones, it's accumulated on the valves.
Right. Exactly. Yeah. That's the conundrum here. You're losing it in the bones and you gain it in the valve.
Any questions from the audience for Dr. Mack while you have him here? Yes.
Interesting to see that cassius mitral annulus, that when you open it up, it has all that gluey substances in. I mean, is there a risk when you implant a valve there that this will rupture and cause embolization?
No, I don't. I think that those patients are probably better candidates for a transcatheter valve due to the fact that the annulus is less rigid. What you see with transcatheter, same as in the aorta, why all this calcium doesn't go anywhere, because it's all enveloped in endothelium. I think that when you deploy the valve, it does not disrupt the integrity, and therefore it's more malleable and may actually have less paravalvular leak. Again, Mike, any thoughts here?
I think that's true. I mean, when first time you operate on one of these as a surgeon, you cut into it, it's like toothpaste coming out, and it just keeps coming and coming and coming, and oh God, when's it going to stop? And I get sent, I do a lot of heart tumors, at least twice a year somebody sends me a mitral valve heart tumor, which is caseous MAC, and yes, say, no, don't touch this. But I agree with Dr. Mack. I think that as long as it's covered and you don't cut it, it'll stay confined in
Okay, great.
That's good. Good question.
Yeah, over there.
Congratulations on the excellent presentations. Because the raw data in the literature suggests that there is a correlation between MAC and coronary artery stenosis. What is your experience based on the cases that you showed?
You want to repeat the question? The correlation between MAC and coronary, just so everybody knows.
You said there's a correlation.
Yeah, there are data in the literature suggesting there is a correlation between MAC and coronary artery stenosis. Is that something that you have faced during the procedures we've been witnessing so far?
Yeah, I would say although there is an association with coronary artery disease, that hasn't been a prominent feature of most patients with mitral annular calcification, and it's very seldom that we have to deal with both at the same time. Highly unusual, and I don't know why.
Well, Michael, thank you for a great talk about MAC. Really, a MAC talk about MAC. You can't beat that.
Okay, great. So now it's my pleasure to introduce Dr. Stavridis. Dr. Stavridis is Chief of the 3rd Cardiac Surgery Department at Onassis Cardiothoracic Center. The title of his presentation is Primary Mitral Valve Regurgitation, Repair or Replacement.
Right. Thank you. It's dear colleagues, dear Chairman, I'm honored to be here with you. And thank you, the organizing committee, for the privilege to share with you this presentation. It's many ways some considerations can be made when you want to compare two techniques addressing the same pathological situation. In this situation, this is the primary mitral insufficiency. Somebody has to bear in mind the severity of regurgitation, the valve anatomy, the patient factors, the long-term outcomes, and most importantly, the surgical expertise. And we assume and best demand from the surgeon to be expert either producing these both techniques or each of them, it depends which one it's allocated to, and to perform that flawlessly. Of course, in being a human, it's flawless, maybe it's a bit heretic. And there are other considerations as well. Is there an absolute indication for the operation? That's the first thing somebody has to ask. Is there a suitable anatomy for both techniques? Is it the similar cohort of patients, or there is a gross heterogeneity? And again, you can see that the variable, which is very important, is a solid reference point in the surgical expertise. And of course, to have complete follow-up to compare these techniques and not have missing data. Most of you have seen, especially in some propensity or even observational studies, that after the first or the second year, there is a diminishing number of patients at risk. Not because these patients die, they are censored, but they are censored because they're missing data. And of course, there is another way as well to consider this thing. It's suppose that you can offer prognostically an operation. It's a patient that is borderline for the procedure with a good ventricle, not dilated, and you think that it's maybe I can offer a valve repair procedure in this patient, especially if it's young, provided that I can offer a procedure that it will be 98%, if it doesn't sound pompous, to be a mitral valve repair. Of course, here again, you have to bear in mind the variable anatomy. If the patient is young or old, it will depend on what sort of operation we can offer. Again, the surgical expertise, we can never forget that. That's the most important thing. And of course, somebody has to bear in mind when comparing these techniques, the survival, the long-term survival, the clinical status, the quality of life. And of course, we shouldn't consider the reoperation, the redo mitral valve, as a surrogate for a failed mitral valve repair. And of course, there are established practices in mitral valve for mitral valve reference centers regarding both hospitals and surgeons. These are the prerequisites that must be somebody must have. One of the recent studies, and Dr. Mack is here as well, it was a large study covering a large STS database from 2011 to 2016, having 55,000 patients. And you can see at the upper part of the slide is the hospital data, and the lower part is the individual surgeons' data. You can see on the left side, it's crowded. Crowded on the first slide, it's the attempted mitral valve repair, the planned repair. But the successful repair after that, in the next slide, you see next figures, it just gets diluted and has to do with the annual volume of both the hospital and the surgeons. And again, more contemporary data that emphasizes on this thing. Again, you can see that the median number of cases annually for a mitral valve repair, it's 5. It's quite low. And mind you, I had a look at our hospital about doing around 1,900 cases, and we are about 54 as well annually, which is, it's not bad, but it's, if you consider that on the individual surgical basis, most of the surgeons, they are on the very low single-digit figure. But again, from this publication, it appears that the mitral valve repair is a very safe procedure, even for the reoperations. And of course, you know, this publication, maybe it sounds, again, as I said to you, a bit pompous to say that I can repair 100% of my valves. But of course, if you are a center of excellence with big experience and you are very choosy with your patients, you can have excellent results. And coming to the most of the management of these patients, you can see it's green everywhere. It's mitral valve surgery. It's indication type 1, except for these patients with no symptoms and dysfunction that the TER can be helpful. And coming again to the to be more pragmatic, you can see again, it's a surgical valve repair, surgery repair whenever possible. You don't see anywhere valve replacement. And of course, it's following this platitudinous prologue that maybe it was boring for you. It's because there are no data. There are no large prospective randomized trials comparing mitral valve repair to mitral valve replacement. Of course, regarding, I mean, the primary mitral valve insufficiency. There are for the ischemic, yes, and the transcatheter procedures, yes. And of course, some of you, being in PIs for RCTs, you know what an ordeal it is to deal with RCTs. It's a matter of feasibility. It's always trying to find the economical issues, also collaboration within hospitals, the funding issues, ethical sometimes, especially if you have two techniques that one of them is better than the other, and the patients know that, and normally they select, they want to do a certain procedure. And there is also the clinical equipoise, especially if there is an uncertainty between the investigators. The endpoints and the sample size is very important, and especially the endpoints. It's no point selecting endpoints that they are meaningless. It's to find a statistical significance, but with meaningless results means nothing. They say that you must have evidence that matters to the patient, not to the investigator or to the industry. Of course, patient selection and standardization is very important. The patients, in both techniques, they must have the same follow-up, they must have the same protocols, preoperatively, postoperatively, the same care. And the standardization, of course, again, sometimes when the human factor comes in, it's a bit difficult. When you want to compare surgical techniques, certainly surgeons, most of them, they are seasoned and experienced. They do the operation theoretically flawlessly, but again, there is that human factor. And long-term follow-up with complete follow-up will be necessary. And of course, the most difficult thing with the RCTs is to take the results from a calm sea and adapt it to the ocean of the real world. These are more or less some of the meta-analysis and the observational studies comparing, and there are far more, and all of them favor regarding operative mortality, adverse event, and long-term survival, the mitral valve repair. One of the recent studies here, which again was propensity matched, again found that the morbidities and the long-term mortality were better with the mitral valve repair. Here you can see a hazard ratio. It shows that the mitral valve replacement is always above 1 across all ages. But the question is it a durable repair? I mean, it's very good to do your repairs, but it has to be durable. Especially for the elderly patients, sometimes it's better to have a chordal sparing valve replacement instead of doing a repair that you're not happy with it. And again, another pooled study shows the same thing. Not much difference when compared to redo cases. But again, here, it's when you do mitral valve repair procedures, you have the MVR. It's your lifeboat. It's a bailout procedure. It's not the other way around. And there are some confounding factors too. For instance, you end up selecting easy cases for the arm that does the repair. And so that makes things a bit more complex. Even from recent publications, it's supposed that the mitral valve repair fares better with reverse remodeling of the heart. But again, from this group, the patients that they went to the MV repair, they had mostly disease of the posterior leaflet. Of course, this is probably the only case when you have this mixed disease. It's most of the time a rheumatic disease. We hardly ever see it nowadays. But surgeons from Asia and Far East, that they have very good experience. They are seasoned surgeons, really, that they have produced very good results repairing these valves. Most of the cases, when we have cases like that and we have to do them surgically, we'll replace the valve. So what happens in the real world? This is the real data. We have the type 1 mitral insufficiency. We don't see it that frequently. This can be repaired. If there's endocarditis, some of the damaged tissue can be repaired, can be patched or whatever. If it's type 2, that most of the patients that we have, this can be repaired with various techniques, from resecting, respecting, doing Alfieri, doing plication, folding, etc., putting artificial cordia and the rest. And the type 3, it's again a rare procedure that, as you saw before, it's mostly due to rheumatic disease. So these are gone. There's not much left. And I think that probably this is going to be a nice assist, if I want to use a basketball term, to the next distinguished speaker. Maybe the question should be, do we need surgical mitral valve intervention or transcatheter interventions? These are things that are coming. They are scheduled to large studies that it will take a long time. They will not end in the near future. You can see when they start, when they're going to end. And maybe some years after that, I don't know, probably won't be here. It's the topic and the title of my presentation should be surgical or transcatheter. And I don't know that, but I conjure Diva Fortuna to give us good health so that in the near future, in the distant future, we'll be able to have these things. Thank you very much.
Great, thank you very much. We have time, although we are running a little bit late, we have time for one brief comment or question to Dr. Stavridis.
Or, this is going to dovetail into the next talk very well, so we could also have the next talk and then discuss both surgery and transcatheter, as one time, because I think from the surgeon standpoint, we really fixed degenerative MR really, really well. It's going to be interesting to see how these trials turn out.
That will take time, though.
That will take time. I'll be retired by then.
Okay, great. Thank you very much. We have to move now to the third speaker. It's really great honor for me to introduce Kostas Pargias. Please allow me to say a few words. Kostas is the founder of this department at Hygeia Hospitals Group. And Kostas is now, of course, the director of this department. No doubt, he performs as a state-of-the-art center a number of procedures, difficult procedures, but the most important, at least for me, is his great interest to introduce innovative techniques and cutting-edge technologies. Kostas, the title of your presentation, as far as I know here, is Transcatheter Mitral Valve Interventions, a 20-year journey. So practically, this 20 years journey is your journey here in the hospital, correct?
That's true. It's not 20, it's like 14, 15, but it's approaching to 20, yes.
Great. We are missing you. You have to be
Thank
here.
you. Thank you, Professor Valdas, for your kind introduction, and I'm really sorry I have this sudden back pain problem just from the day before. So it's difficult for me to join you physically there. But I see that all the meeting is going very well. Tremendous speakers and very nice interaction. I watched you online. So I hope there'll be nothing negative for my online presentation. Transcatheter mitral valve intervention, a 20-year journey, and the disclosures and the heart team were working together at the year.
So when we're talking about transcatheter mitral valve interventions, we're talking about transcatheter mitral valve repair, which, as we all know, comes to the form of clipping the mitral valve that we call edge-to-edge repair. But as I said earlier, probably we should change that and call it body-to-body repair, because we are not just bringing together the edges of the leaflets, but up to 12 millimeters of the body of the leaflets. We bring together. Then we have annuloplasty, although licensed, used very little so far, but perhaps things will change in the future, we'll see. And then we have the transcatheter mitral valve replacement, which is very easy in brackets when we already have a valve or a ring there. Much more difficult, as Professor Mark said earlier, when we have MAC. And finally, the transcatheter mitral valve in native valve without stenosis that is coming and is developing. So we're talking a lot about the clipping today in the mitral valve. It's considered a solid, well-established therapy and very widely used. But let's see the real results, not those coming from the study, but those studies from the trials, but those coming from the real clinical practice. And this is the latest data from the TVT registry, 60,000 interventions. As you can see, elderly patient average age is 82 years old, STS score close to 5%. And as you can see, most of these patients were DMR patients because the FMR approval in the US came just very lately. So that's why the majority is DMR, but there's also a considerable number, like 30% probably, of FMR. And so what's the 30-day mortality of this procedure in real life? It's not 0%, as many of us believe. It's 2.66%. So it's not zero. It's very low, but it's not zero. And then we have all the rest that are very rare. So it's generally a benign procedure, low 30-day mortality. And we have to consider also the population that's undergoing this procedure, which is elderly and high-risk population. Improvement in the symptoms, no doubt about it. As you can see here, New York Heart Association class, significant improvement. And what happens to the MR? We have MR reduction, as you can see here, at 30 days, and that is 97% 0 to 2 degrees and 77% 0 or 1 degree. So the second is considered to be a real success, to have 0 or 1 degree. And in reality, we have 77% post-procedure, but watch how it falls almost 10% at 30 days. So we lose some success just within the very first month after the procedure, and this is that we see in many studies. So are we satisfied with this 65%? I don't think that anybody of us would be satisfied with this outcome. That's why there's still studies, investigation, and new devices in this field. This is the reduction of the success if we also take into account a mitral gradient below 10 millimeters of mercury or MR2 or below. So it's 89% to 30 days. So if we go to MR1 or below, this will automatically go to 70-something%. And what happens through the years? Do we have an improvement in the results? Yes, absolutely. We have an improvement. As you can see here, for MR success, as defined earlier, it goes from 81% to 92%. And this is for grade 2 or below. So deduct 10% if you want to see the grade 1 or below. So certainly there is an improvement. What happens to those who have a successful procedure versus those that have a successful procedure is very obvious that the mortality of the latter is very bleak and very high compared to those that have a successful procedure. And of course, heart failure hospitalization readmissions are falling down when you have a successful TEER procedure, and reintervention is really very low when you're successful at the beginning. As you can see, 2% compared to 13% for those that were not successful at the beginning. Is there any tool of living moderate MR like do? Yes, there is. As you can see here, even moderate MR have worse outcome than those with mild MR. That's why we strive for the mild MR in the majority of our patients. And if we put into boxes all the possibilities here, if we go to this really much desired population outcome, we want to have mild MR and a gradient of below 5%, this is just 52% of the patients in the TVT registry. So we are all enthusiastic about this treatment, but we shouldn't forget this data coming from real life. And now, in contrast to this data, we have the data from the studies. This is the latest study for the Gen 4 MitraClip, the Expand G4, and we see here a success rate of 89%, MR or 1 or below the 30 days. Certainly, there is an improvement in the technology, and now this generation 4 is expected to provide better results than what we saw in the TVT registry. And similarly, with the Pascal device, the other device we have to use, we have similar results at 88% success, MR1 or below. But even in these studies, if we go and get the difficult anatomies, the risk of inadequate MR reduction, as we can see here, all the difficult anatomies, and then we see that the success rate falls like 15%, from 90% to 75%. So this is something we should take a note. Similar in the CLASP 2D trial that compared the Pascal and the MitraClip in DMR patients. There was a Pascal 2D registry, patients that thought to have complex anatomy and were not included in the randomized trial, but they went into this registry. And these are all the difficult anatomies that we frequently meet. And here again, you see the success rate falls from 83% to 56% for these patients. So TEER is here, we all use it, but we should remember that we can't get the best results for all patients, especially for difficult anatomies. Let's move now to the transcatheter mitral valve replacement. Things are relatively easy when we have a mitra, a biprosthetic mitral valve there that is degenerated. And as you can see, we started doing this procedure back in 2012. So it's like 12 years now we're using this procedure. Initially, we're going transapically, like in this first case, that we had a very good result after the positioning of the very old, as you can see, Sapien XT there. And this is the first case we did 2 years after with a ring, again, transapical valve and ring. You can see the old Sapien XT there, 29 millimeters. And again, we're very happy with the results when we have a valve or a ring. But of course, the goal was to move to transfemoral for all these cases to avoid all the mortality risk that is associated with the transapical approach. And this was the first case we did from transfemoral approach from the leg in 2019 or 2018, if I remember. And you can see the regurgitation. There is a ring there, as you can see, the septal dilatation, and then we go with a Sapien valve and we inflate it. You need to master the positioning of the valve here to put it in the right position so you avoid to have any paravalvular leak and the need for a second valve if something goes wrong. And here is how it appeared after the positioning. Again, very good result. What we measured from before and we learned with the CT scan is the neo LVOT that we're going to have after simulation of the positioning of the valve. This is another case. Generally, if we have a neo LVOT of 1.7, 1.8 square centimeters and above, we're happy. Again, another valve in valve. And another one, again, the neo LVOT was 2.2 here. This is a valve in a ring. So this is a sort of like a common procedure nowadays and makes things easier in most cases that we have a degenerated valve or a ring with acceptable result, but requires a lot of screening. And this is a very complicated case that I was involved in, done at St. Lucas Hospital. I find it very interesting. That's why I'd like to show you. It was a MAC case, as you can see here. That was initially treated with a hybrid approach, so debridement of the anterior leaflet, and then they implanted a sapien valve there with very good initial results. A very minimal paravalvular leak. Then 15 days after, the patient still in the hospital had severe aortic regurgitation from a degenerated aortic valve. I don't know if that was the result of the operation of the mitral valve, if it was provoked from that, but they had to treat it. So they implanted a sapien valve, evolute valve with a good result. But it was not over, because 3 days after that, the patient had severe hemolysis. As you can see here, severe paravalvular now leak, and probably the sapien valve, despite the sutures, moved backwards. So at that point, I was called for some help, and we decided to go for a valve in the mitral valve. And this is a procedure, septostomy, and going with a sapien 29, the big one, in a more ventricular position. And after doing this procedure, the patient improved, and she was able to be discharged from the hospital. This was the final result. So, and this was the appearance of a CT scan with 2 valves in the mitral valve and 2 valves in the aortic valve. Very interesting case. And that's why, as I explained earlier, we need something else for the mitral valve, because with TEER, we're not getting always an optimal result. And we have cases that we need to eliminate the tricuspid regurgitation. And for those, we have the TMVR. It's outside and discussed and analyzed and studied for like 15 or even 20 years now, but we haven't seen a device coming successfully into the market. Tendyne is the only one approved so far, but despite being in the market for quite a few years now, the numbers are very low. The study is still ongoing after so many years, the SUMMIT study, comparing Tendyne with MitraClip. There is also a MAC cohort that is finished, but the study, I'm not sure if it will ever finish. The reason is that the screen fail is, as you can see, 70% mainly for neo-LVOT obstruction or sizing. The other valve that we studied is the Medtronic Intrepid. We had our own share of experience here. This is the first implantation, transapical implantation we did of this valve many years ago. It's more than 8 years ago. And you see the expansion, the flaring, and the positioning, the delivery. And this patient is still alive. So I think it's the longest alive patient with Intrepid valve today. And last year we did this transesophageal echo. You see the functioning of the valve so many years after the implantation is doing fine, very nice imaging. So this is a proof that this valve, once it's implanted and the patient has a good life expectancy, it stands up to its work so many years after. Very happy to see this, and I think it's a testament that we should keep striving to find transcatheter mitral valve solutions. This valve is undergoing a full study. Dr. Mark is the PI, so he knows most than all of us. Initially, it was the 35 transfemoral device, but now I think they have available the 29 French transfemoral device, and also one additional size, the 54 millimeters, to have more patients included. This is another valve, the M3, the sapien M3 valve, that basically is 2 systems coming together, the sapien M3 dock, and then the sapien valve that goes and is implanted, the very well-known sapien valve within the dome. And I'll show you just this video here just to understand how it is done. So this is very similar to the Pascal device alignment. We have the 2 flexible guides one into the other, And then the dock is advanced initially as a guide catheter that circles around both leaflets, which means that the leaflets are held by the dock. And then once the dock is released, there is a holder, as you can see, into the base of the floor of the left atrium, and also this pillow to prevent PVL from the posterior leaflet, and then the sapien is implanted. So this is the study of this valve is the encircle, and it's the only one that managed to finish in time. And actually it will be reported later this year at TCT, and probably the valve will be the first one licensed for transeptal valve for mitral valve later this year, provided that the trial results will be good. And this is the main study with 300 patients. They also had a failed T registry with 100 patients and a MAC registry with 100 patients. And here, as you see, the dock deployment and the valve implant, how it looks within the dock after the implantation. And of course, with the other one that is in study is the Alta valve. We've heard earlier today that there is 70 implantations worldwide now. This is a very large device. It basically, it's like a ball within the right atrium, the left atrium. It has certain advantages, but also disadvantages. The results appear to be good. They have very good reduction or elimination, but the 30-day mortality is around 8%, still high. And the main problem with all these valves is the LVOT obstruction. This is the main reason that the patients are rejected from these studies. We learned a lot about how to predict the new LVOT. Initially, we're getting at the end of the systole, but we know that 75% of the blood is coming out in the first 20%. So now we measure the 20% of the circle to predict, and so this makes more patients acceptable for this procedure. And for those that the risk is very high, and we have all the lampoon flavors before the implantation that is sparsely tried so far, and unless it becomes more user-friendly and accessible to us, I don't think it will be widely used. Another approach is the pre-empty alcohol septal ablation. This has been proved to work, but it is linked with considerable mortality and also considerable need to use a pacemaker. And the final question is, if we implant a valve, how often we have to close the iatrogenic ASD? And once you close it, there's no way to go back. And if this valve degenerates and you need a valve-in-valve, then this is lost. So the question is, how often we have to do that? We get some information from this SAPIEN mitral valve-in-valve registry with almost 80 patients. And we see here that the closure rate was 11%, 10 to 11%. And so the SAPIEN is around 20 French, 22 French, similar to the M3 valve that will be 22 French. So we can predict that the need for the closure will be around 10% when we use this valve. And with this, I would like to thank you for your
Great, thank you very much, Kostas, for your nice presentation indeed, but also for your huge contribution to Hellenic and European interventional cardiology. Any comments from the audience? Because, as we said before, we are running very late. Just a brief, naive question. Do you expect in the next 10 years to see the trajectory of mitral valve replacement following more or less the same pattern like TAVI? No, I'm sure not.
Clearly, no, because there are many difficulties as we have seen and we have realized over the past 10 years in designing a device that will be good for the mitral valve. The reason is the mitral valve is much more complex than the aortic valve. I believe that because the engineers are so clever, they will come up with solutions to all these problems, and at the end, we'll have not just one, but multiple technologies available. The question is what the range of pathologies, of anatomies will be amenable for each of those valves. We need, because if one valve is good only like for 30% of the cases, then I think it will be very difficult to be successful commercially.
I think TAVI has been successful because you replicate something we do as surgeons that has been successful. Most of our transcatheter mitral stuff does not really replicate what we do very well. But one of these days we're going to be talking about neopapillary muscles and cords, and you'll be repairing mitral valves just like I do with a neopapillary muscle and a cord. And when that happens, that'll take off like TAVR. You'll see it in your lifetime. I may be retired by then, but it's going to be exciting to see.
Great. Okay.
Great session.
Great. Thank you very much.
It's my great pleasure to have as moderators Professor Vouranakis, Professor Dimitriadis, and Dr. Darladimas. Dr. Mitropoulos is not with us due to unexpected reasons. And it's my great pleasure to invite the first speaker, who is Dr. Aphrodite Tsifa. Dr. Tsifa is a pediatric and adult congenital heart disease specialist in Natera Hospital and senior lecturer at King's College Hospital in London. And she's going to talk to us about transcatheter interventions for the pulmonic valve. Dr. Tsifa.
Thank you so much, dear Chairman, dear colleagues. Thanks very much, Kostas and the organizing committee, to be here with you this year. I'm going to be very brief, talking to you about something pretty rare, which is the transcatheter pulmonary valve implantation. The TPVI took place before TAVI in 2000, and it took place because lots of our congenital patients will have repetitive procedures for the pulmonary valve. So Professor Bonhoeffer at the time at Great Ormond Street thought that we cannot operate on these patients again and again to change their pulmonary valves, and therefore he thought about this TPVI technique, and then TAVI followed 2 years later. It is listed in the procedures that congenital cardiologists do, pediatric and adult congenital heart disease. And it is stated in the ESC guidelines that it's best to be done by operators skilled in general in the care of congenital heart disease patients. And I'm going to show to you why is that. It does take place in organized centers because it can be pretty difficult and it can go pear-shaped. So it's best to be in a place where you have a congenital surgeon to bail you out if something goes really wrong. Also, the lab that it needs to take place probably is better to be biplane because we often have to switch between one plane or the other. And it's best to be done according to the EC guidelines by people who do more than 10 PPVIs per year to keep the skills going. We usually do it in patients who have tetralogy of Fallot, but there is obviously other indications. And the reason that we do it is because the surgeons don't want to take these patients on, like in TAVIs, and that is because they're often multi-operated patients, or they have other skeletal and thoracic abnormalities. They really don't want to go into their chests again. Pectus, lung hypoplasia, other predisposing factors. Look at this child who surprisingly has Marfan's, and you see his, over here you see his chest, and the CT shows how close the RVOT is to his sternum and severe chest deformity. Obviously, this was a case for us to do. We have 3 available valves for the pulmonary position: the Melody, which was the first valve, the Edwards, which is your Edwards, and we use it in the pulmonary position, and now the Venus P valve, which has been implanted for the past 10 years, but it's only this year that got CE mark, and therefore we have it available for larger RVOTs. The Melody valve is very, very common. The downside of this valve is that it can get endocarditis up to 10%, so that's not very nice. The Edwards valve has a less incidence of endocarditis, and it's available up to 29 millimeters, as you know. And the Venus P valve is actually good for RVOTs that the other 2 valves cannot sort out, and it goes up to 34 millimeters. We use it when we have a conduit in place, best to have something in place. As you heard earlier on, it's fairly easier to do a valve-in-valve procedure or a valve in conduit. When it's a valve in conduit, the conduit may be calcified and it can rupture. We also use it in native RVOTs when we don't have a conduit or a valve and there's been a transannular patch in place, and that's where the Edwards and the Venus P come in place because these RVOTs are far larger than the conduits that are pretty fixed. We first started assessing our patients with MRIs in the first years of the implantations, but actually, except for getting volumetrics and other physiological information like the RV volume, we have shifted from doing MRIs to doing actually CTs. Why is that? It's because on the CT, obviously, we can see the calcium much better, and what we really care about is that the calcium is not very close to our coronary arteries, and that is so because, as you see here on my LCA angiogram, the LCA ostium is so close to the posterior part of the homograft, which is heavily calcified, and you can see it on fluoroscopy. That means that if I implant a valve there, I might compress on the LCA. And that was a patient that I aborted and I didn't do the procedure. And if I hadn't aborted, then we might end up in this situation that is from the literature, a patient who had compression of the LCA and ended up arresting on the table. And as you see over here, there's an RCA and there is no left coronary artery flow. The patient had CPR, the stent of the Melody valve collapsed, and then there was reestablishment of the flow to the left coronary artery, but the patient died. So we don't want to have that. That's why I said earlier on, we need to do these procedures in very safe environments with congenital surgeons, with perhaps adult coronary experts, etc. So what are the considerations? It's where we're going to do the procedure from. We're going to do it from the leg, we're going to do it from the neck. And then the size of the RVOT, as I told you, the shape of the RVOT can vary, and then the location, the angulations, the underlying diagnosis. So first the shape and the size. Look at that. There's so many shapes and sizes, and really we can only sort out up to 20% of the patients that need revalvulation with the transcatheter technique. And that is because we don't have such availability to cover all these variables. The second is that we need to look at the tricuspid valve. Our patients are congenital patients. Usually they can have congenital tricuspid regurgitation, iatrogenic tricuspid regurgitation, and look at this patient who has an Alfieri stitch on the tricuspid valve, and this has ended up having a double orifice tricuspid valve, a very dilated RV because there is volume loading from the pulmonary regurgitation, bad RV function. He needs a pulmonary valve. Which of the two tricuspid valve orifices am I going to choose? The largest one to pass my sheath in. And how do I choose it? With TOE. And this is what we did. Then there can be concomitant stenosis of the MPA or the branches, and if we go in, we need to sort out the periphery first. We start with periphery, sort it out, stent whatever needs to be stented, then come back, put the valve. Then there is other problems. Our patients have thoracic abnormalities, scoliosis, spinal rods. Look at this patient. We had to do modified views in order to see what we are doing. And as I said, we start with the periphery. So look at here, that's the RPA distal. I ballooned this first, then I came back, and I had to actually balloon the calcified homograph because I couldn't even pass a wedge catheter through this calcified pulmonary valve. The balloon of the wedge would not go through. So with the same balloon that I did the RPA dilatation, I came back. I did a very careful pulmonary conduit dilatation to crack a little bit of the calcium, but not too much. And even so, I had an extravasation here, as you see, but it's contained. It's contained because this patient was multi-operated. And of course, if you're multi-operated, you have adhesions. And this is what saves us. But we need to be extremely careful. And now you see the melody valve coming up after the stenting, the mounted stent has gone in, and this is a cover stent. And we put a cover stent, dedicated CP stent from Numet, because first, they have a good radial force and they don't collapse. And second, they have the PTFE covering in case we get an extravasation, it should be contained. And then we test the valve at the end, make sure there is no pulmonary regurgitation. And as I said, our patients can be rather difficult. You see here something on the left-hand side. I've gone up the femoral vein, and I find myself in the left side of the thorax, and this is nothing less than a azygos continuation. So my patient had IVC interruption, azygos continuation, and you see here that this drains into the coronary sinus. What did we do? We went from the jugular vein, and this is how we do the procedure, as you know. And then sometimes our patients have to have their valves upsized. So we may have a child that's had a 23 valve, and now we want to put a 26 valve. What we do, we break the previous valve. So you see here, we use a high-pressure Atlas balloon. We break the surgical valve, and then we implant a bigger valve in the surgical valve. And often I get the question whether a pacemaker and the pacing leads is a problem. No, it's not a problem. Look at this patient, lots of pacing leads. Some of our patients have epicardial pacing leads from childhood, and then they have transvenous pacing leads, and it's not a problem to have leads in place. We just have to be careful that we don't dislodge them, and we have to be careful that the leads have been in place for at least 6 months, so that there's been adhesions, etc. And finishing off, the venous P valve that I said just got CE mark this year, and we are about to do the first venous P valve, hopefully in a couple of months' time. It's a good valve. It's got a lifespan of at least 10 years now. As I said, it was first implanted 10 years ago. There's a lot of experience abroad. We are starting our experience here in Greece, hopefully. First, we do a CT or MRI. We send it abroad. The company tells us whether the patient is suitable, and then we proceed. The largest valve, as I said, is 34 millimeters. So what can go wrong from this procedure? Many things. So first, homograph rupture, very bad. There's been cases where cases where people have put a drain in the a pleural drain and they just auto-transfuse. Okay, we don't want to get into that. Then the arrhythmias, systemic infection, endocarditis, thrombus formation. So thrombus formation, this is one of my cases. This is a Hancock conduit, but not very nice to put valves in the Hancock because you cannot really reach the end of the ring. But anyhow, we put this Melody valve, and you see on my angiogram, there is this whiteness here. It's actually calcium, it's debris within my Melody valve. What can we do? We can actually balloon it. We balloon it, but the calcium may go to the lungs. And this patient of mine, I had to balloon it. The calcium went to the lungs. We did a CTPA. There was some calcium. She did okay. She's on warfarin because she then got pregnant and we couldn't revalvulate her again and we couldn't operate on her. So this is a possibility, but we need to be very careful. So in conclusion, this transcatheter therapy for our patients is really revolutionary for them. It's really very good for them. It's good for the patients and for the teams and the surgeons. But we need to pick up the patients in a timely fashion. We shouldn't be neither too early nor too late. And the key to our success is, like in every transcatheter procedure that we've been hearing about these days, is the multimodality imaging and the multidisciplinary team. So it's not the cardiologist on show, it's the cardiologist with the surgeon, with the technicians, with the radiologists, the anesthetists, and the whole team. That's all. Thank you very much.
Thank you very much, Dr. Gifa. A brief question from my part. Do you have any long-term data of the Melody of the pulmonic valve site?
Yes, absolutely.
Regarding durability or the need of reintervention?
Yes, definitely. Excellent question. So it's been 24 years since it's been implanted, from 2000. So what we didn't know at the time was that if you put the valve, the valve is a Contegra, it's a bovine jugular vein, just sutured on a CP stent. So they would implant the valve in the RVOT with no pre-stenting. So about 40% of the first few valves fractured. And that is because the pulmonary and the RVOT and the chest are so close to each other, and in our operated patients, there's always a lot of adhesions. So in every cardiac cycle, the chest would actually compress on the stent. So we knew that from RVOT stenting even before the valves came on. So then what we started doing was that we always pre-stent. We pre-stent the conduits and the native RVOTs. We create a scaffolding, and within that scaffolding, we put the pulmonary valve. We don't have to do that when we've got biological prosthetic valves that have a ring. We believe that the ring protects us.
Yes, just a small comment. Excellent presentation, Dr. Gifa. Your techniques are almost similar to the TAVI. I saw you break the valve and all this stuff. I was very interested on the case where you have compression of the left main if you were to put the valve. Is anyone using protection with stents, or would that maintain the lumen? What your experience or some experience if there is?
Well, we just shouldn't get ourselves into that situation if we think that our coronaries from the CT scanning, and that's why we've moved from MRI to CT, if we think that the coronaries are close, then we first do a balloon interrogation to the full diameter of what our valve is going to go up to. And at the same time, whilst the balloon is up, we do a coronary angiogram. If that is fine, then we proceed. If we think that if sometimes there is a compression, we abort.
Thank
you.
Okay, congratulations for your clinical experience. Do you have any data on the generated Melody valves? What do you do then? Was the first one question. And second, you present the case of a child that you crack the valve. What is the possibilities of fracture and, a complete mess in this case?
Okay, so both excellent questions. So the first is, what is the durability of the Melody valve?
And did you have experience of doing something after generation of the Melody?
So the Melody, unless it gets an acute infection, you can actually get some years out of it if it degenerates, because it will degenerate. It degenerates in about 10 to 15 years. So that is comparable with the degeneration of the surgical valves. And that's why the guidelines say, if you can do it transcatheter, go for transcatheter, because perhaps the durability is even a little bit more. If it degenerates, you can do valve in valve. So it has been done up to 2 valves. And that is not weird to do a melody in melody so long you have a melody. The melody is 18, 20, 22. So long the patient is good for size. So unless you have a patient who has now grown and the 18 melody that you had put a few years earlier is not good enough for the child, then it's fine to implant it again. When you have endocarditis, you can implant a valve. So it's a myth that if you have endocarditis, you shouldn't put a valve again. So if it's chronic endocarditis, then it's organized. You can implant a valve, and what we do is we cover it, we put a covered stent, exclude the vegetation, and put a valve within it. And your second question?
Cracking the valve.
Oh, it's not a problem. You don't get any problem with fracturing the.
Congratulations for that excellent presentation. Just a short question. We all know that in cases that there is severe tricuspid regurgitation and annulus dilatation of more than 40 millimeter, that could be an issue, and the symptoms of the patient will relapse. So how do you tackle this issue in this case that you showed us? Is it treating at the same time, referring the patient? What's your approach?
Yep, that is very common to have tricuspid valve concomitant disease. And then we look at the reason for the tricuspid valve regurgitation. If it is because of annular dilatation, because the RV is now very enlarged because of pulmonary regurgitation, then, and depending on the degree, of course, then we will proceed with the valve implantation and assess the tricuspid valve, yes? But if it is iatrogenic tricuspid valve regurgitation, because sometimes we see the septal leaflet caught on the VSD patch, and there is a lot of tricuspid regurgitation, we don't go into transcatheter. We send the patients to surgery, and they do a pulmonary valve replacement and a plasty of the tricuspid valve.
Okay, thank you, Dr. Zifa.
Thank you very much.
Our next speaker is Dr. Halapas, interventional cardiologist from the Medical Center in Athens. He's giving a talk on transcatheter PVL closure in the mitral valve.
Dear Chairman, dear colleagues, it's a real great pleasure and honor to be part with you, and in the next minutes we are going to present the data having to do with a transcatheter closure of paramitral defects. So, opposed to paraortic defects, the mitral valve paravalvular leaks are more common, more symptomatic, larger, and often repair is more complex, and most frequently located between the anterior lateral and the posterior medial aspect of the mitral valve. In 80 to 85% of the cases, they are oval or crescent in shape, having irregular borders. And regarding the pathogenesis, there are several factors favoring the development of such defects, such as annular calcification, endocarditis, active or prior, the corticosteroid treatment, of course, several technical considerations having to do with the surgery, and almost 75% of the cases occur relatively early in the first year post-operation, associated mostly with the technical considerations. Regarding the clinical presentation, most of them occur asymptomatic, having a benign clinical course. However, less than 5% of the cases, they can have or they can lead to severe clinical consequences, such as congestive heart failure or symptomatic hemolysis that can be occurring in 40% of the cases, mainly with mechanical valves and smaller defects, and always we have to be suspicious about the endocarditis. This is a fantastic graphic coming from Garcia showing the different hemodynamic patterns related with hemolysis, and just to mention the fragmentation, the cohesion, and the acceleration. Of course, repair is the gold standard management approach in patients with severe symptomatic defects. And of course, surgery is maybe the first approach, especially when endocarditis is combined or when there is mechanical instability of the prosthesis. However, reoperation is associated with high, more than 10 to 50% mortality and up to 30% recurrency. This is a very nice observational study coming from Mayo Clinic showing similar recurrency regarding the reintervention rate between percutaneous and surgical approach. And based on meta-analysis and of several observational studies, the long-term results regarding mortality and MACE are similar between surgical and transcutaneous approach. Very recently, a few weeks ago, we have the data coming from the KISS registry, almost 350 cases, which showed the early benefit of transcutaneous approach regarding mortality and complications and the comparable long-term results. So based on that, guidelines from both sides of the ocean suggest as class 2A recommendation the PVL occlusion in mitral position based on percutaneous approach when these procedures done in comprehensive centers with a high experience, when the surgically risk it is very high or prohibitive, and of course when there are favorable anatomical characteristics. Limitations to proceed through percutaneous approach to close such defects is the high severe instability of the prosthesis, the so-called rocking valve, the presence of thrombus, the active endocarditis, and of course when another operation must be done. When we want to evaluate, gold standard approach is the echocardiography, and especially the transesophageal echocardiography. By using the QLab and 3T analysis, we can estimate the severity, we can define the location, the size, shape, and orientation, having always in mind the dropout phenomenon. And when we want to go one step further, we have to proceed with ECG-gated CT analysis using 3D and 4D reconstructions, and which can define better the anatomy and the morphology of these defects, and also providing information regarding the optimal crossing angle. Imaging is also important during procedure. Transesophageal echocardiography gives us important information for the precise deployment and implantation of the devices in order to estimate the correct function of the prosthetic valve, and of course to estimate the residual degree of paravalvular leak, and of course by using different fluoroscopy projections like the left projections, which can show us the mitral valve and phase so we can better confirm the correct wiring through smaller leaks, or the right projections, which are very helpful during implantation process. Fusion techniques can also be used. They can give us, provide us dynamic information during the procedure for the better and the correct wiring and implantation of the devices. And regarding across which is the access site, in case of the paramitral defects, we have always to think first the antegrader approach through the septum. In such cases, we have to follow the rules that we follow for the TR procedure, so we have to go posterior and slightly superior in order to have more space inside the left atrium. As an alternative, and especially in posterior and septal-oriented defects, we have to use, or we can use the retrograde transapical approach, which gives us direct and easy access. And no more, we don't use further the retrograde approach through the femoral artery due to the electrical and hemodynamic instability. Of course, when further support is needed, we can use the different loop techniques. And regarding the device that we can use, of course, up to now, there is no dedicated device. Most of these devices made from nitinol. In the early years, we used the ASD and the VSD devices, and lately we use more often the AVP2 for round-shaped defects, or the AVP3, which is better adapted for crescent and shaped defects. The AVP3 has CE marked approved in Europe, not at the moment FDA approval. However, we expect the data from the paradigm study, which is going to give us new insights regarding the AVP3 in such defects. Up to now in Europe, the only dedicated device is the Occlutech. It has CE mark since 2014. It comes in two different geometries, square and rectangular. The latter one is the more often used, up to 70% of the cases. It has a secure mechanism, and of course it is available in different sizes. And based on that, we can decide which type of device we have to implant and with which way, based on the size, if it is small or large, based on the shape, if it is oval, crescent, or based on the complexity. In case of complex anatomies, very large anatomies, or anatomies with boundaries which prevent the full expansion of the device, we can go with simultaneous or sequence deployment technique. And this is a very interesting technique, very recently published in JACC intervention, coming from memory, 40 cases for both para-aortic and paramitral defects, showing this interesting sequential deployment of a covered stent initially and thereafter a vascular blag. The technical success was 100%. There was no in-hospital complication or post-procedural hemolysis. Of course, although costly and expensive, the 3D printing models can be used, especially in complex morphologies, and always during procedures we have to be aware about issues regarding the resistance and the friction in advancing our devices by using different tips and tricks like stiffer wires or smaller hydrophilic catheters if that's possible, and the so-called span cans. By pushing and pulling technique, we can overcome such restrictions. Regarding the complications, we have always to be aware about the interference of the device with a prosthetic valve that can lead in sudden hemodynamic deterioration, and of course the embolization of the occluded device, which more often occurs early during the procedure. However, late medications can extremely occur. Hemolysis is another complication that can be seen during the follow-up of our procedures, and these can be seen mainly after not totally occluded defects, in partially occluded defect, in severe calcified cases, and of course more often in mechanical valves. In such cases, the first approach is to wait, hoping that the epithelialization of the occluder device and the development of the fibrosis is going to close these defects, diminishing the disruption of the red blood cells. And this is the first publication in chest in 1975 showing the spontaneous closure of paravalvular clique. This is the first publication in 92 in JACC coming from Hurricane for a percutaneous approach for para-aortic defects, and the first publication for paramitral defects done by Pate in 2001 with a small series of cases. Since then, there are several publications from a small series and observational studies showing a satisfactory high technical success rates, more than 80 to 85% of the cases. 3 years ago, we published the Greek data, almost 40 cases for both para-aortic and paramitral defects, showing very high technical success up to 90-95%, and by using the AVP3 device as the most commonly used device. Data coming from the Occlutech showing that the rectangular in-shape device is the most common in use, up to 70% of the cases, and that the device, procedural and clinical success were most of the cases 90%. And of course, regarding the predictors, we have always to think the type of the device and the experience of the center. These are data coming from Spain, from the whole registry, versus opposed to the para-aortic defects, where the size is the only independent predictor for procedural success. Based on that, there are several algorithms proposed showing that in symptomatic, severely symptomatic paramitral defects, especially when endocarditis or instability of the prosthetic valve exists, we have to think first the reduced surgery. In all other cases, we have to think the percutaneous approach, and by that, I want to conclude by saying that the paramitral defects are relatively rare. There are less than 40 cases per year in our country. Imaging is of meticulous importance. Procedure can be challenging, however, success rate is very high. In case of hemolytic anemia, we have to target the complete resolution of the defect, and of course, based on the recently published guidelines, decision of whether we can proceed with transcatheter or percutaneous or surgical approach depends on the risk status of the patient, the anatomical and morphological characteristics of the defect, and of course, the expertise of the center. And with that, I want to thank you for your attention.
Thank you, Dr. Halapas. I will give you a final message that it's fortunately rather rare condition, but the percutaneous treatment is building up. Professor Vorounakis, any experience in Greece with
We
closer to
yes,
the
yes,
mitral
yes.
valve,
I think we have the most, I would say, experience. A few centers are doing the procedure. This is an excellent presentation, but we have to admit that this is a very, I would say, difficult in a way that you cannot have certain steps during the procedure. You can fail in several steps. So it takes some experience, but also some, I would say, special conditions going to do. You might enter the leak and then you will not be able to cross the catheter. You have to develop loops. So it's a very, very complicated procedure and it needs time also. And it's different between the aortic and the mitral, of course. Imaging is very important. We have here Michael, who is an expert, so he can confirm that. But excellent presentation otherwise.
Thank you.
I just want to comment one case that we had that had severe hemolysis in the mitral valve. We corrected it with one device. There was some residual, which we thought was okay, but the patient continued to have severe hemolysis. And we tried again from a different approach, but were unable to close it completely. So that's, as you mentioned.
Hemolysis is an issue, and in almost 50% of the cases with paravalvular defects, there is 50% subclinical hemolysis. So we have always to be aware and be suspicious about that. Thanks for the comment. Yes.
Any comment from the audience? Final comment from Dr. Daladimas?
Congratulations on an excellent presentation. Supposedly, this is a mild to moderate paravalvular leak and the patient is relatively stable, no severe hemolysis. How would you suggest we follow these patients? Which modality? The echo, the TOE, CMR, volumetric criteria, and how often should we see them, especially as we said that sometimes deterioration might be subclinical? Thank you.
Thank you for your question. In case of not severely symptomatic with no congestive heart failure or no symptomatic hemolysis, then we go straight for the follow-up with echo. This is the first modality. And regarding hemolysis, we have to use the different laboratory parameters, like the haptoglobulin, the indirect bilirubin, and so on. So regarding the follow-up, that depends on the situation. Excuse me? That depends on the severity, and if we are suspicious about that, yes. Imaging is important, especially CT can be very useful, and CMR as well.
Okay, thank you, Dr. Kalapas.
Thank you.
We have to proceed. Dr. Gikas is the next speaker from Hippocratean Hospital in Thessaloniki, and he's giving us a talk on his favorite subject, transcatheter left atrial appendage occlusion.
Thank you very much. Thank you for the kind invitation. I work in Interbalkan Medical Center also in Hippocrates in Thessaloniki. So we will change the topic, and thank you for being here. It's getting late. I hope you will find this presentation interesting. Just to give you a background, my original research and PhD was in TAVI, but then I made a switch. So I focused my research in left atrial appendage occlusion, and I will explain to you in the next 10 minutes why and why you may consider this therapy. The main issue and one of the main global health problems right now is the stroke and the disability related to stroke. And the cardioembolic strokes that we usually have to deal with are usually the most disabling and the most serious, as you see here. So I'm sure, I mean, we are all in the field of cardiovascular disease. There is a long standing battle against stroke, but whenever we try to reduce stroke, we increase bleeding. And there is a limitation of the medication, and this is shown in different ways, and mainly, as you see here, even with the introduction of the new anticoagulants, the non-vitamin K anticoagulants, which are not new anymore, the adherence and the use of these drugs in the general population didn't actually increase too much. So I just fished one little publication from the in New England Journal of Medicine in the artesial trial. And this is not about the clinical subgroup of patients. It's about when you lower the risk of stroke, as apixaban did in this study, there is a higher risk of bleeding. So I think we reach a threshold there. And as in many other things in life, there is no free lunch. You give something, you take something. And the reality is that the annual major bleeding rate for in anticoagulation is close to 5%. And what happens next? The patient gets a bleeding, he's hospitalized, and then what? Out of, let's say, 3,200 patients in this very well-conducted study, we saw that 10% had an yearly major bleeding event. So this is huge. And what happens is that these patients, they suffer from clinical endpoints like stroke, myocardial infarction, cardiovascular death, etc. And this happens early after their original hospitalization for this bleeding event. And the main reason is the discontinuation of therapy. So all these seems logic, but sometimes, we tend to forget the elephant in the room and we talk about other things. So the adherence of anticoagulation medication, even in the best and well-designed clinical trials, reaches 50%. Okay, so what about the new drugs, the anti-11 factor drugs? Big hopes there. Unfortunately, we have signals also from this field that there is a plateau. The trial of the Oceanic AF study was stopped because the medication was not effective, actually. The bleedings were less, but they didn't really prevent stroke. Again, no free lunch. So we see that left atrial appendage occlusion has started to appear in papers, in publications, mainly coming from the US. As you see here, we have some patients that when they get discharged, they are offered this procedure. However, the European guidelines are still in a 2B indication. And the main reason for that is that we don't have, the big randomized clinical trials. And sometimes the reality is faster than the trials. But this is the situation, 2B. Now, in the surgical field, I will show you the LAOS 3 trial. There was some evolution. And on the other side of the Atlantic, we have seen the change of the guidelines to a 2A indication very, very recently for this procedure. The LAOS trial, as I mentioned, the very well-conducted surgical trial showed that concomitant combined LA closure, surgical closure with other procedures is beneficial for the patient. And I will just want to show you a few indications that sometimes are not considered because we don't think about it. And you see there group A, which is the most reasonable, the contraindication for long-term anticoagulation. But we also have the second group of patients where patients take the medication, they take it properly, and they still suffer from a stroke. So this is a stroke on anticoagulation for several reasons. And when we document that this patient had the thrombus in the left atrial appendage, this patient may be considered even for closure with a different technique, and I will show you how. So this is the consensus paper that's trying to explain what the guidelines don't explain, and make us think that some patients should be offered this therapy after careful examination. And this is a practical guide for the long-referring physician that we just recently published in a European effort to increase the awareness for this procedure. And this is a schematic approach, a schematic way to show which are potential candidates. Now, and also we have this algorithm showing that when we have high bleeding risk, one of the things that we should consider this procedure. Now, years ago, when I gave this lecture in TCT, we were worried about complications. We still want to know the patient, master the technique, and know the device, but right now we have changed, this therapy has changed, and now we talk about optimal closure. And this reminds me a lot of the early years of TAVI, when we talked about the depth of implantation and different things, and paravalvular leaks, etc. Now, there are two issues still. One is the device-related thrombosis, and the second is the peri-device leak. And we are working on that. Now, for the peri-device leak, we were honored to publish this meta-analysis recently in European Heart Journal, showing that any leak of more than 3 millimeters is bad. That's as a take-home message for you, and briefly, and that the leak should be detected by TE and not by CT, because CT will show occasionally contrast in the distal part of the appendage, but this doesn't mean there is a real communication that is clinically relevant. Now, what about the DRT? We had the problems with the definition of the DRT because it was people get confused with the healing process that we see on CT. Now we know that there is specific definitions of DRT, plus, just to remind you the TAVI days again, the depth of implantation. We intended to implant the devices deeper, and now we know that this is bad. This creates a slow flow environment that creates DRT. So these were published recently and were shown in EuroPCR lately. Another new thing is the idea of giving, instead of dual antiplatelet therapy for 1 to 3 months, because we wait while waiting for the device endothelialization, or single antiplatelet therapy, we don't do full dose anticoagulation, to give half dose apixaban. And this is a very nice small study shown last year in EuroPCR, that half dose apixaban may be the best drug for this short period of endothelialization for the first months after LA closure. Now, with this therapy, we need to collaborate with other specialties, neurologists, gastroenterologists, you name it. And this is a very interesting presentation that I borrowed the slides from, talking about intracranial versus extracranial bleeding and how bad this is for the patient, even in the big randomized trials with NOACs, and bringing the issue of microbleeds in MRI in our attention, which magnifies the risk for intracranial bleeding by 10 times. So we prescribe the drugs as cardiologists. The neurologists see the intracranial bleeding, but nobody can check for primary prevention. And this is a big problem. Now, I will move forward to adherence to anticoagulation. We published this paper a few years ago. I just want to show you this. In 1,000 patients that are hospitalized with atrial fibrillation in a Greek hospital, 13% had a previous major bleeding, and almost half of them don't take their drugs properly, their adherence. And I think this is very similar in other hospitals. So the patients are there. One word about the resistant stroke. There is not much data. We have this data from the ACP registry that showed that these patients usually have more comorbidities, but at the end, their outcomes are similar to the rest of the patients. Now, should we close the appendage in the presence of thrombus? In principle, no, but again, it depends. It depends on the anatomy, it depends on whether the thrombus is proximal or distal, the experience of the operator, and what are the alternatives for the patient. For example, this is a case I wouldn't do. But again, this is a dynamic situation where the thrombus may change. So this is the same patient before and after magnification of the anticoagulation, and actually we are going to treat this patient on Monday. How? You need to apply some special technique. Be careful. We don't give injection in the left lateral appendage. And the only barrier is that you can do a single shot. You only have one chance to do the implantation. You cannot just try and again. But it can be done. I just want to mention that, so this is not an absolute contraindication. Now, what about the non-randomized clinical trials? The most important trial right now is the Champion AF. They randomized up to 3,000 patients, and this is the enrollment has finished in all comers. Here we don't have patients with contraindications to anticoagulation. It's all comers, patients with AF. And we expect the results to come next year. In parallel, there is the Catalyst trial sponsored by Abbott with another device with an amulet. There, the enrollment has been slower, but we will expect the results in a similar, probably a year later. In the meantime, and the upcoming trial that will be shown, presented in AHA this year, is the combination ablation plus LA closure versus ablation only, the option trial. On Friday, actually, we did the first combined pulse field ablation in Hippocrates Hospital. It was a very smooth procedure. We did the transeptal. The EP people did the pulse field ablation. It took them an hour, and then at the same time, we implanted a Watchman device. Now, another trial that is coming is the closure AF. I will just want to be brief. Plus the Laos 4, Watchman Flex, in addition to oral anticoagulation, on top. So just to make you think. Now, what's the comparison with TAVR? It's a smaller market for sure, and this is a very easy research I did. But the growth is double. So this is a procedure that is probably here to stay as long as we increase our technique and also we have more data. So in conclusion, cardioembolic stroke remains a leading cause of morbidity and mortality. Percutaneous left atrial appendage occlusion offers the option of local therapy versus systematic. For surgical closure, we have very clear data that it's beneficial for the patient. We have results from large registries that are very promising and some new randomized clinical trials coming along. And this is a procedure that its number is expected to grow exponentially during the following years. And with that, I hope I explain why I'm here talking about LAA closure in a heart valve meeting. Thank you.
Thank you very much, Dr. Dzikas. Very nice lecture. Congratulations for your work on this field. Of course, it's still a problem and question what the thrombotic therapy this patient will need for the first period after the closure. It's for 3 months or for 6 months, at the platelet only, anticoagulant. You saw that they're doing a trial that they're giving anticoagulant on top. So it's a bit paradox. We do the whole procedure to avoid the anticoagulation, to avoid intracranial bleeding, but then we have in the strategy the use of anticoagulation.
So the trial that I showed at the end is something totally different than LAOS 4. When we do the procedure, we wait for device endothelialization. So for 1 to 3 months, you need to give something.
Right.
Usually it's single antiplatelet therapy, maybe half dose NOAC. But the benefit comes later, after 2 or 3 months, when you can stop everything. Now, the trial that I showed is for another patient population. We're talking about all comers. We're not there yet.
That interesting study you showed about the detection of microbleeds by MRI is in practice? I mean, you perform regularly?
No. And I asked the neurologists, and neither they do. So we just prescribe the medications as cardiologists without knowing.
Also, and it's difficult.
So there is a trend in the US now to screen for microbleeds in patients before getting anticoagulation, but it's still there is no real guideline on that.
And also, your initial comment regarding the 11A inhibitor was a bit negative. I would say it may be a good option in cases that you want to achieve some level of anticoagulation, but without having bleeding risk. Actually, instead of using apixaban 2.5, why not
still need to use
an 11A inhibitor, which will be rather safe regarding bleeding and do at least some protection.
Maybe that's a nice topic for a study, maybe.
Professor
Apostoli, yes. Apostoli, thank you very much. Excellent. As usual, you have, you know the topic, you know the field. To bring in a discussion, because, your concerns are why we don't have this, widespread use of the devices. And I would say that a question that I have, and I believe a lot of us have it, is, okay, if you have a low-risk patient for stroke, okay, you have a good candidate, you can use, your device, and will be equal effective. Trials have shown to giving oral anticoagulation. But I'm not sure that we are all convinced that if you have a very high risk for stroke, patient with congestive heart failure, remember, we keep on saying that it's not only the local effect, it's all the vascular. And that's why maybe anticoagulation, you need it. Yeah. And so this is a group of patients that I'm not sure that I feel comfortable. Okay, I put the device and that's it. You're done.
Yes, I agree with you. That's why patient selection is important. There are so many different kinds of patients out there. So we need to think, I agree. But what we have seen is the clot that is coming from the left atrial appendage and the AF-related strokes are very disabling. These are big strokes. And you have seen that clots with PFO and other strokes may be less disabling. So what we have seen after closing the appendage, and we did a study, we have some strokes that are minor. So the concept in my mind is that we avoid the big reservoir of big clots and thrombus of the appendage. But of course we need to prove that.
Congratulations for your excellent presentations. I'd like to thank you personally for all your valuable assistance in the cases we have performed in a year hospital. What I would like to say is this. You showed that thrombus formation inside the appendage is, let's say, a relative contraindication. Are there any major issues regarding patient selection, anatomical features, concomitant diseases, access that will really avert you from going through the procedure?
Yes, this is a good question. The size of the appendix is one, but usually this we see in Asia. For some reason, the Asian people have larger appendices, but there are dedicated devices. Another reason is the presence of a big ASD closure device, and this is what we discussed with Dr. Zifa a few weeks ago here. You close the door, you cannot do anything, you have a big ASD closure device, and these patients have AF. Another reason would be the presence of thrombus that is mobile and it's hanging there. We don't do the case. But I would say it's less than 1% the patients that are excluded because of this. And valvular AF. Valvular AF, which means mitral stenosis, that's another story. Then the thrombus, 50% is from the left atrium. So I did one, I closed one with thrombus, and then I have the thrombus on the device. So we need to talk about non-valvular AF, no mitral valve stenosis. Yeah, and I think...
Professor Skalidis.
Yeah.
Thank you. An excellent presentation in a topic that we don't know well. I want to ask, you said that it's bad to have 3 millimeters, more than 3 millimeters flow in...
A leak.
Yes, a leak. How common is and how do you treat? What do you suggest?
Well, to be honest, if you do it properly, it's very, very uncommon, depending on which device you use. That's why we need to have more than one device in our cath lab. It's the same as the early days of TAVI. Same thing, it's like a déjà vu. If you do it properly, that's not a problem. But the problem we have now is in the US, mainly, which is the market has exploded, that people do 10 cases in one day, and they don't care so much about these leaks. They say, it's okay. So the message is to them. Don't worry about that. In Greece.
Last question from...
Small comment. Congratulations for your talk, your experience. I think we undertreat patients now in Greece compared. I want a simple comment on that from you. And also we're seeing in abroad that they're doing concomitant implantation of the occlusion of the LA with, for example, AF ablation. You do the transeptal. You can do the implantation even after mitral clip in some cases, not in all. Any comments on that?
With the mitral clip, I'm not very happy to combine, to be honest, because there is some degree of mitral stenosis. I'm not sure if this is mitral stenosis situation. I'm not sure. It has been tried in Switzerland with fairly good results, but this is a population that would not be my first choice. But for the combination of AF ablation plus closure, after the publication, hopefully the option trial is positive in AHA, things will change dramatically on the EP side because you are there. I mean, the appendix is in front of you. It took us 8 minutes to close this one on Friday.
Okay, thank you very much to Dr. Gikas. Our last speaker is Dr. Mitsis from Cyprus. I think he's connected from Nicosia General Hospital. Dr. Mitsis, we can see you. And he's going to talk to us about devices for transcatheter closure for ASD, PFO, and the LAA, similarities and differences. Dr. Mitsis.
Dear Chairman, dear colleagues, greetings from Nicosia, from Cyprus. First of all, I would like to thank the organizing committee for inviting me to this very interesting conference. Without losing any more time, let's proceed with the topic, with the presentation, which is about the devices we use for transcatheter closure of ASD, PFO, and LAA. Let's explore the similarities and the differences of the devices. PFO is the flap-like opening.
I cannot see your slides yet.
Oh, sorry. Okay, now should be. Can you see the slide now?
Yes, yes.
Apologies. Again, PFO, the flap-like opening without any loss of septal tissue. It's a quite common condition in about 25 to 30% of adult patients. And now we have robust evidence that It is not a benign condition. It can be associated with cryptogenic shock via paradoxical embolism. Over the last 10 years, there have been conducted 6 randomized controlled trials comparing the PFO percutaneous closure with medical therapy with very promising results. These RCTs have been used different devices, and let's have a deep view in the most common of them, starting with the Amplager PFO occluder from Abbott. It consists of 2 nitinol wire mesh discs. The right disc is larger than the left disc, apart from the small device, the 18 millimeter device. There are 5 devices that can cover all the anatomies, and of course the device is covered with Dacron that stimulate endothelization. We have the Figula PFO occluder from Occlutech. The difference of this device with the previous one is that the nitinol discs are covered with titanium, and this can minimize the nickel expose and can be suitable for patients with a nitinol allergy. Furthermore, this device is less traumatic as there is no hub in the left atrial side. Again, 5 available devices. And last, we have the Cardioform septal occluder from Gore. This is a non-self-centering double disc device. Again, 2 discs covered with PTFE and 5 available devices. This meta-analysis tried to explore the risk of stroke recurrence according to the device based on the previous randomized controlled trials. And as we can see, there is no much difference with regards to the risk of stroke. However, the risk of atrial fibrillation following the procedure, especially with the Gore devices, was elevated. This slide concludes these devices. Again, the Amplager PFO, we have the largest experience. However, it's a rigid device and maybe cannot be used in more complex anatomies. The Cardioform from septal occluder, a softer device. We have evidence, a lot of evidence and data. However, the question is the atrial fibrillation following the procedure. The Figula PFO occluder, which is, as we said, very useful for patients with nickel allergy. And finally, a new concept, the Noble stitch, which is not a device, but this is a procedure where we put 2 stitches, one in the right side and one in the left side of the septum, and this is how we close the PFO. Let's proceed with the ASD. The ASD, as we know, is caused by abnormal embryonic development. More commonly, 80%, it is a secundum ASD, which is located in the fossa. And this can be completely asymptomatic, but sometimes, and if there is RV volume overload and with a QPQS more than 1.5 and there is no Acemaker, there should be a treatment for these patients. Surgery versus catheter closure, similar success, lower morbidity and lower hospital stay for patients treated with catheter intervention, but with higher re-interventions. Are all the ASD suitable for catheter intervention? No. Of course, the diameter of the ASD is the most important thing. There should be sufficient rim to facilitate the stability and the stable delivery of the device. And of course, the dimension of the total septal length should be no smaller than the left disc. The available devices, starting with the Amplager septal occluder, the most popular, and probably this device has been in the market almost 25 years with FDA approval since 2001. A device with nitinol again. All these are nitinol devices. Repositionable, recapturable device with 27 available sizes. The same company, Abbott, can provide also the cribriform occluder, which is suitable for patients with multiple fenestrations. And this is a non-self-centering device that, in this case, the two discs will cover the defects and not the waist. Gore has also the Cardioform ASD occluder, which is the self-centering version of the Gore septal occluder we saw earlier. There are 5 available sizes and can close defects from 8 to 35 millimeters. Occlutec provides the Occlutec Figula ASD occluder. Similar to the PFO occluder from the same company, the cover with the titanium can be a suitable option for patients with nitinol allergy. There are 20 available sizes, and disadvantages the slightly larger delivery catheters. And finally, these two devices, the Seraflex from China and the Cocoon from Thailand, softer devices with less variety in sizes and larger seats. This meta-analysis tried to collect data from 12 non-randomized trials and registries, comparing the effectiveness of devices for ASD closure. There was no significant difference in acute device embolization, but the residual shunt was elevated when the device with the Helix device, which now I have to highlight is not anymore in the market. And this is a busy slide summarizing all this that we already discussed. I will finish with the devices that we use for the left atrial appendage occlusion. Dr. Jikas presented beautifully in the previous presentation the whole concept. And as we know, all the patients with non-valvular atrial fibrillation should be on anticoagulation. Some patients cannot tolerate or have contraindications or are in elevating bleeding risk. So for these patients, the procedure is suitable. There are 3 randomized controlled trials so far comparing the concept of left atrial appendage occlusion with medical therapy. Protect AF and Prevail, these randomized controlled trials compare the Watchman device, the first generation of Watchman device versus warfarin. The LAO was non-inferior, and Prague 17 include the 2 devices, the Watchman and the first generation of the Amulet, ABC. And again, it was non-inferior. And this meta-analysis of these 3 randomized controlled trials showed that the ischemic stroke with the patients who were treated with OATs, where they had a better outcomes in regards with the ischemic stroke, but the favor for the patients treated with the closure devices, they have less hemorrhagic strokes and bleedings. What type of devices we use for LAA closure? 3 principles. The devices that we are using as a plug. There is an endovascular delivery of a lobe in the neck of the LAA, and this is how we close the communication between the LAA and the left atrium. The pacifier principle. Apart from the lobe, which is delivered in the ostium of the LAA, there is also a disc that is used to seal the LA. And finally, the concept of ligation, which is more a surgical concept. Many devices available. We will focus only in these 2 that have FDA approval. The Watchman Flex device, which is the evolution of the Watchman 2.5 device. It's a self-expanding nitinol frame structure with 18 fixation barbs. Has received the approval from the FDA in 2020. Just to highlight that the previous Watchman device was the only one with FDA approval. And the Watchman Flex can be used to close LAAs with size from 17 to 31 millimeter. From the other point, we have the Amplager Amulet from Abbott. Consists of a lobe and a disc. Approval from FDA in 2021, and it can be used to close a larger variety of sizes, starting from 11 to 31 millimeter. Both devices are recapsable, and the Amplager also can be used in more difficult anatomies. This is the evolution of the Watchman device, and for all of us who are Watchman operators, we can understand the correct choice of the delivery catheter. There are three catheters and with anterior curve, which is used for retroflex chicken wing LA anatomies. The double curve catheter, which is most commonly used for superior anterior directed LAAs, and the single curve for mid-level to inferior directed LAAs. And this is the Amplager Amulet, as we said earlier, and the sizes of the device. We will finish with the two randomized control trials that try to compare head-to-head these two devices. The Amulet IDE randomized control trial compared Amulet with the first generation of Watchman with regards to the device-based LAA closure. And this is the 3 millimeters per device leaks that you heard earlier by Dr. Gikas. And the results showed that the Amulet LAA closure was better with regards the residual jet, and the primary safety endpoint rate was not inferior from this device in comparison with the Watchman. And the other randomized control trial is the Swiss Apero trial, Amulet versus Watchman Flex, the new version of the Watchman device, and some old Watchman 2.5 devices. Again, the 40-day LAA patency, more leaks for the Watchman device, but less major bleedings and no cardiac tamponades, and similar clinical outcomes in 40 days. And to conclude, and to summarize, large experience with both devices, CE marks and FDA approval for both devices, advantage of the Watchman, the new round ball design that is safer and you can maneuver safely in the LAA. And these patients, since they don't have the LA disc, they don't need for further time anticoagulants for the endothelialization. However, there is more often peri-device leak, and the Amplager Amulet, a device that can close almost every LAA, and however, these patients need longer-term depth for the endothelialization, and the data shows more periprocedural bleeding and more procedural-related complications. Thank you very much for your attention.
Have time for questions. I would like to thank you all for attending this session.
Good night.
We have a great panel and 6 cases in this last session. We have moderator, Professor Hamilos from Creta, Dr. Poulidakis with me, and Dr. Dodds from Tirana, also Pristina, okay, with us. And we start the first case that is going to present from Dr. Demiraz from Tirana. Yeah.
Thank you for having me, dear Professor. Now I know it's getting late. I will try to be as short as possible. When I got the invitation to take part of this interesting meeting, I saw the program, I saw the participants, I said to myself to give you a complex and successful case, it will be difficult. I will not get interested in that. So I said to myself, what about a simple case, but with a very bad outcome, eventually? So, simple case, 76 years old, aortic stenosis, symptomatic, a lot of other problems, post-CABG, chronic kidney failure. STS score was high, Euro score 13.6, so obvious, it's a TAVR. Standard procedures, we did it last year in June. An Evolut Pro 29, femoral access went well, not single problem. Couple of days after the procedure, we let it go. We let the patient go. He came back, 10 days out of discharge. Pulmonary edema, fever, anemia. TAVR looked okay on the echo, but blood culture was positive for Enterococcus faecalis. So we started him on antibiotic therapy. Couple of weeks, he stabilized, everything came back to normal. We let him go. Again, 4 days after procedures, after the second discharge. Same story again. The valve looked good. Again, blood culture were positive. This time it was 6 weeks of antibiotics until we stabilized the patient. And, well, third time's a charm, I say. Blood culture were positive, he came back again. The echo was not that normal at that time, so I'm going to show the echo. Guess for yourself. We repeated 2 weeks after. More obvious than that, it's evident. So the patient died a couple of days after a cerebral embolic event. Pretty obvious. Now, since 2002 that we've started to implant TAVIs, we are becoming very good in solving technical issues. Kind of access. We're going lower and more hydrophilic and everything. We do cerebral protection. We're good with paravalvular leaks. We can implant in small valvular sizes. We know how to treat an AV block. We can prevent it. We do commissural alignment. We have larger cells for future access of the coronaries. We do wonders. We even put valve in pure AR. Sizing is not a problem. Some companies have up to 10 different sizes, and cost availability, that's not a problem either. I mean, you can see the equivalent of Edwards, it's the MyVal from India, and you can see the other equivalent of Medtronic is the Venus from China. You do have everything. We have adapted to fix technical complication. We are adapted with a technical advances. Now, just to show you, just to prove you that, it's a 3-year-old, it's my nephew. He did all that in less than 1 minute. The technicality is not a problem for us. The advances, these are not a problem. However, endocarditis still remains a problem. It was a problem, it's still a problem. Same mortality as the standard surgery, but at least 3 times more frequent after TAVR than after standard surgery. And that's one of the points why we cannot implant TAVRs in young patients with low surgical risk. That's the single point that surgeons are holding us, where they are not allowing us to put to implant TAVIs in those patients. Second problem, we have more and more resistant bacteria. So, in my humble opinion, the endocarditis will be our next challenge, not the technical one. Thanks for the attention. Keep it short.
Thank you, excellent. No one of us want to be in your position. And actually, we have no solution for that. Professor Davlouros, any comment? You are muted.
No, I'm not.
Okay.
Can you hear me now?
Yeah.
Good evening to everybody. Thank you for the kind invitation. It was a very interesting case, and indeed, this is going to be a challenge in the future. Although I have to comment that we all know, all of us are interventional cardiologists, and our colleagues, arrhythmiologists as well, know that infections in the perioperative time frame, are related to the invasive procedure itself. So what we need to do at the moment is to be very careful, sterilize the cath lab, and of course be very careful with vena punctures, with the insertion of sheaths for temporary pacemakers, and do the least invasive procedures apart from the main procedure, the TAVI, the least invasive procedure we can do. For example, in our center, we try to pace during the implantation of TAVI through the wire, through the guide wire, and avoiding inserting a venous sheath in the jugular vein or in the femoral vein, etc. The second issue is that, and it was beautifully shown, is that we have a resistance to the antibiotics, and I hope our colleagues, the infectious disease doctors, are going to be helpful in providing new therapies for resistant microbes that unfortunately are very common in large hospitals.
Let's hope so.
Any other comments? Do you find any source for the Enterococcus, I think?
No, we don't know. It's not the first case. It's the third case we've had in 3 different patients, 3 different centers that arrived. The issue, in my opinion, if I may, we're considering TAVR as a non-invasive, a very less invasive procedure considered to open heart surgery. And we are lowering our guard sometimes. So it's time to consider it. It can be risky, it can be dangerous, because it's a conundrum to tell a patient, we put you a TAVI to avoid your surgery, and then you have an endocarditis, you have to go back to surgery. It doesn't really make sense.
Do you use, in any case, antibiotic prophylaxis before TAVI?
Yeah, by definition.
And
of
after
course.
that?
Yeah.
So, Dr. Chrysogeris, yes.
We see occasionally endocarditis, and indeed it's a very difficult situation. Thankfully, we've been able to, in 2 or 3 cases that we've had with antibiotics, they were corrected. Do you think the mentality of the interventional cardiologist compared to the surgeon is a bit different in terms of antisepsis and prevention? Because, you know, the surgeons are very strict with their antisepsis and everything else. Do you think it's a matter of
all right, excellent point. I mean, I remember when I started my internship in year 2000, more or less, that the surgeons, before starting a surgery, before sending a patient to surgery, they were not that concerned about anesthesia or things like that. They are concerned for the patient to go to the dentist, to fix everything, to go to a doctor, to look for entry points. So at the time, they were extremely serious. The patient had no chance to go to the operation room without solving every possible point of entry for infection. Now we're considering the patient kind of, our procedure are considered kind of not that invasive, but a valve is a valve. So we are lowering our guard. That's what I'm trying to say, very probably. So shame on us.
Any other question? If not, just a last reminder that in endocarditis instructions for prophylaxis before TAVI, we have to check for Staphylococcus and treatment before implant. In this case, it was not Staphylococcus.
It was Enterococcus, but.
Okay. Thank you very much for your presentation, and we move to the next one from Dr. Koutouzis from IEA Hospital. Michalis, we are waiting to see your case.
Thank you very much for the invitation. I will show you a TAVI case in a bicuspid aortic valve with horizontal orientation. So it was a 70-year-old male patient, bicuspid valve, horizontal orientation of the aorta with severe stenosis and moderate insufficiency. He had a history, he had prostate cancer without treatment. So far it was diagnosed some days before he came to the hospital to treat the aortic stenosis. During the angio we found a severe middle AD stenosis, and he was a previous alcoholic patient. So we did the heart team and with a cardiologist, heart surgeon, and oncologist. And the decision was first to treat the LAD with PCI, then implant the TAVI, and then proceed with hormonotherapy for the prostate cancer. It was, as you see, very, sorry. This is the ballooning. In the second picture, you see the result of the PCI. Sorry, I don't know what's happening here. Other videos are coming up. Anyway.